session of revision of many topics. Okay, we are going to do many topics today. So please stick with me. Your commitment is required. Okay, because you will have to give the same kind of commitment for your exam as well. Use lab 2 wala or use lab 1 wala or use this annotated. Either of them are okay. They are all more or less the same. Means I am teaching also in the same order. GIT, hepatobiliary general surgery. Okay. So if you have made any earlier notes, no need to make any new notes, just listen. If you are coming for the first time, then use this annotated. Okay. Fine, cool. Let's get started. So don't put too many questions and doubts today. That period is done. Today, your only thing is to respond or to listen. No doubt discussion today, please. That period is over because we have to do a lot of matters to revise. Okay, a lot of things to do, and let's get started. And I hope we will finish in time. I don't want to stretch too much because today after my class you have another subject, and then you will have this for 5-6 days. So I don't want to stretch you, right? ठीक है, काम शुरू करें, तैयार हो? So every topic that I will touch is extremely important. Okay, don't ignore any topics. And I always give this list before I start for every component, and you will get questions from these. You can see I have not changed this list as such. ये मैंने कभी change नहीं करी है. इसमें से ही question आते हैं. Okay, like the love asking investigations in esophagus. For some reason, Barretts was asked in the last FMG exam. So please keep this in your mind when you are revising. And we are going to first start with the malignancies. Okay, we are going to first start with the malignancies, then we will do the benign conditions. Okay, so first we start with the malignancies, that is CA esophagus and CA stomach. 100% you will get a question from this. Okay, 100% sure shot you will get a question from this. So first and foremost, CA esophagus is what type of malignancy? What type of malignancy CA esophagus? Good or bad? Quickly. It's a bad cancer. It has a poor prognosis. CA stomach also has a poor prognosis. You will see how easy it becomes to study it like this. Risk factors are very similar. Smoking, spirits, sepsis, diet in both. Now, spirits means alcohol. Sepsis for esophagus means what? If you have esophageal candidiasis. Who gets esophageal candidiasis? Or if you have HPV of the esophagus. Who gets these conditions? It is seen in people who are immunosuppressed. Okay. Diet, if you eat foods which are rich in N-nitroso compounds. Right. Foods which are rich in N-nitroso compounds. Correct. Pickle foods. Pre-malignant or risk for squamous cell carcinoma. Remember, this is the most common esophageal cancer, squamous cell carcinoma. Pre-malignant lesions for squamous cell carcinoma. Very good one is achalasia. Any other important one you can tell apart from achalasia? Other is corrosive injury. Very good. No, don't say Barrett's. Barrett's is not for squamous cell. Barrett's is for adenocarcinoma. And adenocarcinoma is the most common in the West, in places where there is obesity. So Barrett's or places where there is obesity, that's where you will get adenocarcinoma. For stomach, sepsis means what? What infection will increase risk of stomach cancer? It is H. pylori. It is a class 1 chemical carcinogen or carcinogen. And diet here, all the things with S, like smoked foods. Okay, smoked foods or soya sauce or sushi, those kind of things, which is consumed a lot in the Japanese population. That's why stomach cancer is very common in Japan. Pre-malignant lesion for stomach cancer, you only need to know gastric ulcer or peptic ulcer. This is the one that you need to know. Others are not that important. Adenomatous polyps, atrophic gastritis, hypertrophic gastritis, not that common. Important one are peptic ulcer. Gastric ulcer can become cancer. And in stomach, there is only one cancer, that is going to be adenocarcinoma. right? Stomach mein there is no variation. It is only adenocarcinoma. Now, what will make you think person is having an upper GI cancer? This is how the question comes. You can't say it is esophagus or stomach. You have to see upper GI. They will have similar findings. So what will make you think he is a upper GI cancer? What is the patient in whom you will get a stomach cancer or an esophageal cancer? Seen in, tell the golden letters, elderly, male smoker. Okay, elderly, smoker, male. All GI cancers are more common in elderly smoker males. So even for stomach, elderly smoker males. This is the kind of clinical stem you will expect. For esophagus, the person's symptom will be dysphagia. Okay, what is unique about this dysphagia? It is more to solids. Okay, it is solids more than liquids. Contrast with achalasia. In achalasia, it is reverse. So solids more than liquids. Yes, it is painless and it is progressive. Okay, it is painless. It is progressive. So as the tumor will grow, the dysphagia will become more and more. What other symptoms? What other symptoms? He can get regurgitation. So he will say food comes up when he lies down. And because of malignancy, he will lose weight. There will be weight loss. These three things together is also seen in achalasia. That is why it is also known as pseudo achalasia. So you can get the same findings in achalasia. Only there it will be younger patient and there it will be liquids more than solids. That's how you will differentiate. So clinically you have an idea. It is the esophagus. For stomach, what symptom will the person get? What will make you think he's having stomach cancer? Elderly smoker male with fullness. One is he can get hematemesis, means vomiting of blood. That is one. Or he can get blood in stools. That is called melena. Okay, hematemesis melena. Sometimes the melena is so little, he can't see it. So he may just have anemia of unexplained origin. Elderly patient with unexplained anemia. It could be CS stomach, could be any GI cancer. Yes, he can get early satiety, non-bilious vomiting. These are the other features, early satiety, non-bilious vomiting. So don't say non-bilious vomiting means pyloric stenosis. Huh? It can happen in stomach cancer also in an adult. So these are some of the typical findings. Then there are some findings which will make you think that, okay, it is a metastasis. There are some features of metastasis, like he can get Furcow's node. That is an enlarged left supraclavicular lymph node. Okay, enlarged left, not right, supraclavicular lymph node. Or Sister Mary Joseph nodules. These are paraumbilical nodules. These are paraumbilical nodules. Or Krukenberg tumors. These are bilateral ovarian tumors. What is the connection between stomach cancer and these things? What is the connection? If any of this is present, it means it is metastasis. Metastasis means M1. Okay, it means it is a M1 tumor. It means you can't cure it now. Now it is too late. So these are some of the comparative findings which will make it easy for you when it comes in the exam. Then obviously when they'll give you a history like this and they will ask you what is the next step? What will be your answer? First step. Many times they have asked this question. Many times. What is the first step? So upper GIT, you remember in our mission classes, I gave you some thumb rules. The first thumb rule was this. Upper GI symptoms, the diagnosis here will be UGI scoping. And here, if you see a tumor, you will do a biopsy. Like you can see a tumor here, take its biopsy, depending on the location. It will tell you it is esophagus or stomach, it is adeno or squamous. Once you get the diagnosis, then you want to know, has it spread anywhere? The staging. This is same for both esophagus and stomach. That's why I put it in one slide only. It's common. So for local spread means the depth of invasion, you will do endoscopic ultrasound. EUS, endoscopic ultrasound. For distance spread, you will do PET scan. and that will tell you the TNM stage. And TNM is very similar. Okay, in staging in TNM, the T stands for depth of invasion. Okay, the T stands for depth of invasion. There is only one, there is no IOC, there is only a diagnostic test. I mean, again, don't go there. They will not ask IOC. It is biopsy for any cancer, for most cancers, right? Now, you should know the T staging. T is tumor depth. For esophagus and stomach, it is similar. T1A, tumor depth mucosa. T1B, tumor depth mucosa submucosa. T2, muscularis. So this is same whether it is esophagus or stomach. T1A, T1B, T2. It is same. Okay. T3 in esophagus, tumor invading adventitia. What is T3 in stomach? T3 for stomach. It is not serosa, it is subserosa. But okay, even if you say serosa, it's fine. Best answer is subserosa. T4A in esophagus is resectable adjacent organs. T4B is unresectable adjacent organs. Okay, unresectable means tumor is invading organs which I can't cut, like trachea or aorta. That is unresectable. Resectable will be diaphragm, pleura. That is resectable. For stomach, T4A is serosal breach. Serosa has punctured. Serosal breach. And T4B is going to be adjacent organ. So this is the only different part. That's why I put it separately. Are we clear? So now you know, now you don't need to revise it later. Now you know the T staging. And for colon and rectum, it is the same T stage as stomach. So you don't need to study colorectal cancer. It is the same T stage as stomach because they have the same layers. End stage is different, but don't worry about end stage. I mean, that is too much to memorize. This much you can memorize. So now I did all this. I did the tests. I got the TNM stage. Now I will determine the treatment. So to treat any malignancy, first I want to know the TNM stage. I divide the malignancy into early, advanced, metastatic. Normally, early means T1, T2. Sorry. Normally, early means T1, T2. Normally. Locally advanced is T3, sometimes T4A, and metastatic is M1. Okay. So T1, T2, what do I do? Means patient has come early, he is lucky. First, I will do surgery. Means remove the tumor. And I may give chemotherapy after surgery. That is called adjuvant chemo. Okay, adjuvant means post-operative. For locally advanced, I can't straight do surgery. So first I will downstage it by giving chemotherapy. So first I will give neoadjuvant chemo. Make it small. Then if it becomes small, I will do surgery. For metastatic, I will do palliation. Okay, palliation means improve quality of life. Nothing else to be done. Right? Like put a stent or do a feeding jejunostomy, something like that. Just do palliation. Not pollination, palliation. Let's not fertilize things. Right? Now, based on this, I will do the treatment. And there are two surgeries we need to know for esophagus. Actually, it's not two surgeries, there are two approaches. Because the problem is esophagus starts in the neck, then chest, then abdomen. So whenever I want to resect the esophagus, it goes like this from the neck, then in the chest, then in the abdomen. This is how the esophagus is there, and here is the stomach. So when I want to remove the esophagus, I have to go through different body cavities. And wherever is the tumor, let's say tumor is over here, I will remove 10 centimeters above and 5 centimeters below. That is the margin. So the margin of resection for esophagus, proximal margin should be more than 10 centimeters. Distal margin should be more than 5 to 10 centimeters. Depends on the location. And of course, I will also remove the lymph nodes. So when I remove such a big esophagus with the lymph nodes, you will call it a radical surgery, like a radical esophagectomy. So you will call this radical esophagectomy. removal of esophagus with margin along with the lymph nodes. Now the problem is how to remove so much esophagus. If I only want to remove the distal esophagus, not from the neck, only chest and abdomen, I take 2 incisions. This is called double approach of Ivor-Lewis. You can see there are 2 incisions. One is in the abdomen, one is in the right chest. This is called Ivor-Lewis. If I want to remove full esophagus in the neck also, we have to go all the way up. Then I have to take 3 incisions. That is called Meckel or triple approach. Right, that is called a Meckel or triple approach. Abdomen, right chest, that is Ivor-Lewis, and left neck incision. And after doing all the resection, I have to put something in place of the esophagus. The best thing to put in place of the esophagus is a gastric pull-up. That is the ideal conduit, right? That is a gastric pull-up. That is the ideal conduit. So this is how I will do resection and anastomosis. Fine. So this is what you should know. After this, I will give chemotherapy. Okay. This is how you're going to treat C esophagus. Now it's quite simple. Yes, job is done. Esophagus in your pocket. For stomach, it's even easier to understand because stomach is only in the abdomen. Stomach is only in the abdomen. So for stomach, the margin, if the tumor is here, usually it is in the antrum. That is the most common site. It is the antrum. Here I will have to go 5 centimeters proximal and distally till duodenum. So proximal margin 5 centimeters, distal margin till duodenum. That is the first part of duodenum. Right. And you will remove the lymph nodes, which you will call as radical gastrectomy. Okay, that is called as radical gastrectomy. Now the lymph nodes that you are removing, they are given some numbers. This is D1, D2. D1, D2 is not duodenum. D1, D2 is the extent of lymphadenectomy. Don't say first part of duodenum, second part. It is not that. In D1, I will remove lymph nodes belonging to stations. The station numbers 1 to 6. In D2, I will remove lymph nodes belonging to station 1 to 6 and 7 to 11. Okay, it is 1 to 6 and 7 to 11. This is D2. And this is what is preferred. Means you are removing 1 to 11 in short. Okay. Means in D2 you are removing 1 to 11. This is D2 lymphadenectomy. This is preferred. And after this gastrectomy, lymphadenectomy, I will do a anastomosis. What is the name of the anastomosis? Very good. You do a GJ, gastrojejunostomy. Simple. Okay. And after that, you give chemotherapy. So that's how you will treat CA esophagus, CA stomach. 15 minutes, you have studied 2 of the most difficult cancers in your life. In the next 15 minutes, you will study the other 2 difficult cancers. They are actually 1 only. Okay, they are actually 1, they are not 2. That is colon and rectum. And both of these are adenocarcinomas. Okay, both of these are adenocarcinomas. Like stomach only. So risk factors are also similar. Smoking, spirits, sepsis, diet. Sepsis here means what? Sepsis here means what? Sepsis here means if the gut bacteria change. There is a change in the gut bacteria. What diet will increase or decrease the risk? What diet will increase or decrease the risk? Diet which is low in fiber, low fiber diet. Or you are consuming too much of red meat. You are constipated. Many of these things you will be like, all these risk factors are there in me, including smoking spirits. Gut bacteria you can't see, but all this will be there in you. Smoking spirits, low fiber, red meat, constipation. Right. So these are the risk factors. Pre-malignant lesions for colorectal cancer are 2 which you should know. Very important. One is ulcerative colitis. It is a type of inflammatory bowel disease. Crohn's risk is much lesser. Risk of Crohn's causing cancer is much less. Ulcerative colitis, much more. And colonic adenomas, adenomatous polyps. Okay, so no, not hamartoma. Hamartomas are not non-neoplastic. Adenomas are neoplastic. Okay, so these are the risk factors. Then they ask you most common site. You can see this is the image from Bailey. Most common site, sigmoid colon and rectum. So if I ask you most common site overall, you will say rectosigmoid. Okay, that area, rectosigmoid is the most common site. Now, what you need to know pathologically, tumors on the right side, that is cecum and ascending colon, they have a shape like this. Tumors on the left side, they have a shape like this. Okay, so right-sided tumors are, yes, cauliflower-like or exophytic. They are cauliflower-like or exophytic. So they will present with more of bleeding. Okay, they will present with bleeding in stools. What is that called? Bleeding in stools. Other name, don't say malina. It is not malina, it is hematochezia. Okay, malina is upper GI bleed. This is lower GI. This is hematochezia. Left-sided tumors have apple core-like. They are more like apple core, constricting. So they will not present so much with bleeding. They will present more with a constipation or a change in bowel habits. Okay, no, malina means black stools. It is not clots, it is black stools, black tarry stools because of upper GI bleed, that is malina. So here he will get a change in bowel habits. Okay, and if it's a CA rectum, what unique symptom will the person get if it's a CA rectum? He will get blood in stools and some other symptoms. He will get bleeding. And yes, very good. He will get tenesmus. Tenesmus means he gets the urge to pass stools. He will get spurious diarrhea. Very good. Early morning spurious diarrhea. So these are some of the symptoms. So any elderly smoker male with these kind of symptoms, you are going to think of colorectal cancer. Okay, in any elderly smoker male. So these are also going to be seen in ESM. Okay. This tumor can spread to many things. It can spread to adjacent organs, lymph nodes, and hematogenously, most commonly, where does it go? Most common site of hematogenous mets, liver. 50% of the liver mets come from colorectal cancer. Okay, because of portal vein. Very good. So GI cancers go to liver. Urinary cancers go to urinary cancers, kidney, prostate, lungs or second vertebra. Very good. Now you got the logic. Bateson's plexus. Okay, Bateson's plexus. Fine. Now, patient comes with blood in stools. The first step is not going to be colonoscopy. The first step here is going to be stool examination. And in stool, you will see blood or RBCs. Okay, in stools, you will see blood or RBCs. Any patient with blood or RBCs in stools, here then you will do colonoscopy with biopsy. Okay, so here I have written IOC. Don't ask IOC. It will be colonoscopy with biopsy. Wherever the tumor is, you will find it on colonoscopy. Now I want to know spread of the tumor, depth of invasion. For colon, it's not EUS, it is CECT. Preferable to EUS. For rectum, it is MRI. Preferable to EUS. Okay, so esophagus and stomach, it was EUS. Colon, it is CT. Rectum, it is MRI. Okay, so that's how you will know the TNM stage. The distant mets, you know, it will be PET scan. That is the same. And tumor marker also, here there is a tumor marker that is CEA, carcinoembryonic antigen. This is commonly done. What is the role of the tumor marker? Why to do CEA? Role of tumor marker. Yeah, very good. Excellent. It is for recurrence. It is for monitoring. If you know this much, then your thinking is very good. It is prognosis. It is not diagnosis. It will tell me, has the tumor come back? Very good. Now, these some instruments you should know. Our famous one, this one. This is a rigid sigmoidoscope. Okay, it looks like a proctoscope, but it has an insufflator. This is rigid sigmoidoscope. Has a length of 25 centimeters. And this is a flexible sigmoidoscope. It has a length of 60 centimeters. Okay, this has a length of 60 centimeters. Colonoscope looks the same. Okay, colonoscope looks the same. It has a length of 160 centimeters. Just some numbers you should know. Even gastroscope, upper GI scope looks the same. Only it is having a smaller lumen. Right? When you do this, you do the TNM stage, and T, I told you, this is same as stomach. Like 90% same as stomach. 90%. Few differences are there here and there. Otherwise, it's the same. Like if you want to know T1A mucosa, B submucosa, muscularis, subserosa. Now in rectum, serosa is not there throughout. Okay, in rectum, there is not serosa everywhere. Some part of the rectum is extraperitoneal. So in rectum, T3 is invasion of mesorectum. Mesorectum is the mesentery of the rectum. So if the tumor invades the mesorectum, it is still going to be T3. Fine, and mesorectum is the mesentery of the rectum. So that will also be counted as T3. Right? So these are some of the simple points you should know about the T stage. Otherwise, it is same as stomach. And this is something they used to ask before Duke staging, where Duke said, don't do all this TNM. This is before TNM. Dukes A invading mucosa, submucosa, or Dukes B invading muscularis. Duke C spread to lymph nodes. This is the original, the OG Duke staging. Okay, mucosa, submucosa, muscularis, and lymph nodes. There is a D, but it is not given by Dukes. There is a D also, that is hematogenous mets. But here Dukes ne nahi diya tha. Dukes said only these three stages are required. Quite an easy stage. Okay. Now, when you do all this, you get the TNM stage, you determine the treatment. Treatment, I already told you how you're supposed to think. You already know the pattern of treatment. That if it's an early cancer, you will do surgery plus minus chemotherapy. Okay, adjuvant chemo. Alright, surgery plus minus adjuvant chemo. Hematogenous spread. No, not hematemesis कैसे होगा यार? Hematemesis is in upper GI problems. So, if it's an, where did I write? Oh, sorry. Hematogenous. It means my brain is thinking faster than my hands. Okay. Brain is in a racing mode compared to my hands. And see, I'm trying to write slowly because you pass comments about my handwriting, na? So I'm writing a little slow. That's why. Yeah. Now come to advanced. If it's a colon cancer, then you will do the same. You will shrink it neoadjuvant chemo. Okay, first you will give neoadjuvant chemo. If it gets shrunk, you will do surgery. If it's rectum, you can give neoadjuvant chemo also along with radio. Both can be given. Chemo, radio, both are possible. Then you will do surgery. For metastatic, you will do palliation. So everything is the same as GI cancers. Only for rectum, you have one more extra treatment possible, that is radiotherapy. Okay. That is radiotherapy. Now come to the surgeries. Surgeries obviously are different, otherwise everything else was the same. How to determine the resection margin for colorectal cancers? Yes, the resection is based on not the margin alone, it is based on the vascularity of that area. you do vascularity based resections. If they say margin, you can say 5 centimeters. Okay. If they say it is more than 5 centimeters, but in reality it is much more than 5 centimeters, you are going to follow the logic of vascularity. Like if the tumor is on the right side, cecum and ascending colon, somewhere here, you look at the vascularity of that area. This is the abdominal aorta. This is the abdominal aorta. This artery here, superior mesenteric artery, it will give one branch over here, ileocolic, one branch over here, right colic, and one branch to the transverse colon, that is middle colic. And middle colic will split into two, left and right branches. For tumor on the right, I will ligate ileocolic at the origin, right colic at the origin, and sometimes the right branch of middle colic. Sometimes. So these three are going to be ligated. So for tumors of cecum and ascending colon, you ligate ileocolic at the origin, you ligate right colic at the origin, at the root, and you ligate sometimes the right branch of middle colic, only the right branch. Okay, and then you resect everything with the lymph nodes. That is called as right hemicolectomy or radical right hemicolectomy. Okay, that is a radical right hemicolectomy. So you resect all this. And then you do the anastomosis, ileum to transverse colon, ileocolic anastomosis. However, if the tumor is little more distal, let's say the tumor is here in the transverse colon, then you will ligate all these three arteries at the origin. Okay, all the three, ileocolic also, right colic also, and middle colic main. So all these three you ligate at the origin. That is called as extended right hemicolectomy. Okay, that will be extended right hemicolectomy, where you are ligating all the three. Then you should say, sir, why not ligate SMA at the origin? Can I ligate superior mesenteric artery at the origin? No, why? Why no? Instead of ligating the three individually, yeah, very good, because jejunum and ileum are other arteries also, which will also go. They are not going here. Huh? Jejunum, ileum, full small bowel comes from SMA. So don't imagine too much. Okay, so here I will ligate ileocolic plus right colic. If you have so much anatomical knowledge, na, I don't think you should struggle in the exam. Okay, I don't think you should struggle in the exam. If you have so much of anatomical knowledge, then 2-3 subjects are already done. Anatomy, surgery, little ortho, little radio, all get done. You know, that is a big chunk of your exam. So when I do this kind of a ligation, ileocolic, right colic, and main middle colic, and I resect, it is called as a extended right hemicolectomy. Okay, and then you do the anastomosis. The third is if the tumor is on the left side, that is descending colon or sigmoid colon. This comes in the distribution of left or inferior mesenteric artery. So SMA part is done now. It is inferior mesenteric artery. IMA gives only 3 branches: left colic, sigmoid, and superior rectal. Only 3 branches are there. So most of the times I will ligate left colic, sigmoid, sometimes the superior rectal also. So here I can ligate IMA at the origin also. Here it is possible. But usually it's not needed, depends on the location. So here I will ligate left colic plus sigmoid artery, and sometimes superior rectal artery. Sometimes it may be ligated at the origin. Now these are all at the root. So instead I can ligate them at the IMA itself. This is called as left hemicolectomy. Okay, this is called as left hemicolectomy. And then I do the anastomosis. So the 3 surgeries for the 3 different locations are going to be right radical, extended right, and left hemicolectomy depending on the location. These are vascularity based resections. And after that, you do the anastomosis. Whatever part is left proximal to distal. Okay, simple. So this is how you're going to treat colon cancers. Then you go to rectal cancers. A rectum is a little difficult to operate on. It's a little challenging. Now, here you need a margin. Proximal margin for rectum is 5 centimeters, which is okay. Everywhere in GIT it is 5 centimeters only except esophagus. Distal margin ideally is 2 centimeters. Ideally. So if the tumor is in the upper part of the rectum, high lesion, let's say tumor is over here in the upper rectum, you go 5 centimeters proximal, 2 centimeters distal, resect everything and do the anastomosis. This is called as anterior resection. Anterior means you are going from the abdomen only. Okay, this is called as anterior resection of rectum. Short form is AR. And you will do an anastomosis. Okay, so you do anterior resection with anastomosis. But if the tumor is lower down, then what's the problem? If the tumor is lower down, it is very near the levator ani muscle and near the anus. If the tumor is here, within 2 centimeters of the sphincter, because from here the sphincter starts. So if it's very near the sphincter, there are two problems. One is this lower part, I can't remove from the abdomen. I will remove it from below. So I have to go from the perineal side also. Second thing is when I do this much of a resection, since the sphincter is gone, I cannot do an anastomosis either. So this is called as abdominoperineal resection. So if the tumor is very close to the sphincter, within 2 centimeters of the sphincter, because that is my margin, I have to do abdominoperineal resection, also known as APR. And here I will do a colostomy. I cannot do an anastomosis because the sphincter is damaged, so I will have to do a colostomy. Means you bring the colon out on the abdominal wall and you have to put a bag there. Okay, that 5 centimeter is from the anal verge, but see, anal verge is different for everybody. The length of the anal canal varies from person to person. This length, it varies from person to person, isn't it? Some of us have 3 centimeters, some of us have 5 centimeters. So you can't really count from anal canal. It has to count from the sphincter, that is the anorectal ring. Okay, right. आई बात समझ में? So this is how you will treat colorectal cancers. See, I told you, 20 minutes, you have done 2 more very difficult topics. These are the tough topics. आगे के topics are not that tough. And these topics are very high yield. 2 questions will come from this. Okay, at least 2 questions. So now you can answer some of the questions. And more than thinking how much marks through this, you should think if I am studying this or revising this, how much time it will take to revise it. Thereby, how much time it will take or how much sacrifice is gone for other subjects or other topics. You should think like that. कि बाकी सब्जेक्ट्स कब पढ़ूंगा अगर इसी में 10 घंटे लगाऊंगा तो नहीं लगना चाहिए. So elderly male with progressive dysphagia, first to solids with weight loss. What is the IOC? It will be scopy with biopsy. See, they had not even given manometry. Yeah? Name of classification used for advanced gastric cancer. This is Borman. Okay, this is Borman. Dukes is TN. It's like TNM. It is for staging of colorectal cancer. It is Dukes. It is staging of colorectal cancer. Borman is that, where it tells you the different layers based on the layers or based on the appearance, that is exophytic or ulcerative or infiltrative. That is Bormann type 1, type 2, type 3, or diffuse. Yes, that is Linitis plastica, correct. And Japanese is early gastric cancer. What is Lauren? What is Lauren classification? It is a microscopic classification or pathological classification, which divides stomach cancer into intestinal type and diffuse type. Okay, this is all core pathology. Just giving you the explanation for the options. Okay, answer this, and I've put this very nice table for you because when I was teaching in the mission classes, now someone had asked some question. किसी ने एक सवाल पूछा था उस टाइम, उसका explanation है ये टेबल में. So constriction of the esophagus at 25 centimeters from incisors. The mnemonic is cricopharynx or pharyngoesophageal junction 15. Arc of aorta, left main bronchus 25. 15 plus 25 equal to 40. That is diaphragm. ठीक है? So 15 plus 25 equal to 40. So here it will be arc of aorta. Someone had asked, what if both options are there? Left bronchus or arc of aorta? So that answer is over here. You see now, this is the answer. If they say 25 centimeters, go for arc of aorta. If they say 27 centimeters, then go for left bronchus. Don't think I don't listen to what you say in mission classes, huh? Including the crap that you say most of the times. But sometimes you ask things which make me also think. So then I remember. So I don't just come with the same class, same PPT in every class. Okay? Okay. Okay, see, Avinash, then you should be happy. I'm remembering. Anyways. Now come to the benign conditions. That is achalasia. Remember, it is not achalasia cardia. It is achalasia of the esophagus. Achalasia means tighteness, cannot relax. Okay, does not relax. And who gets achalasia? This will be seen in younger patients. Females more than males. One of the syndromes associated with achalasia is Algrove, also called as triple A syndrome. A for Algrove, A for achalasia, adrenal insufficiency, and alacrimia. Triple A syndrome. Chagas disease, not very common, not seen in India, also known as trypanosomiasis. These are some of the risk factors. Now, how will you know a person is having achalasia? Clinically, usually a middle-aged female or a young female presents with a dysphagia, and this dysphagia is more to liquids, at least initially. She also has regurgitation, she also has weight loss. This is the triad of achalasia. Dysphagia, regurgitation, weight loss. Okay, this is the triad of achalasia. To this triad, if I add heartburn, person says I also get retrosternal burning. Then I get a severity score, symptomatic severity score, that is called Eckhart score. Okay, that is a symptom severity score that is called as Eckhart score. These four are the components. They are given a score based on severity. So patient comes with dysphagia, regurgitation, weight loss. It could be malignancy also. So the first investigation that you will do will be first step. Many times they have asked this. First step, second step, third step, fourth step. Yeah, don't mark this. Okay, please don't do this. This you will do only if you don't have endoscopy. Okay, only if you don't have endoscopy. So this is going to be barium swallow. Okay, this is going to be barium swallow. Now, what will tell you on barium swallow? Many times they ask, what screen stuck? Slide stuck, screen stuck, screen stuck, slide stuck. कौन नहीं दिख रहा? I am back. Now you can see, right? कुछ लिखा ही नहीं था मैंने. I don't know why you are wondering I have written something. I have not written anything. So only if you don't have endoscopy will you go for barium swallow. Now what will you see on barium swallow? No, UGI लिखा ही नहीं है मैंने. कुछ नहीं लिखा अभी तक. That is in the next slide. I have not gone there yet. What will you see on barium swallow? See the first image. You are seeing a gradual or a smooth tapering. This is achalasia. Okay, smooth tapering, not smooth filling defect. Somebody was asking me, sir, filling defect. Filling defect is not achalasia. Filling defect means tumor. Okay, here you are seeing smooth tapering. Second image, you are seeing abrupt tapering over here. That is called shouldering with irregular filling defects over here. This is in CA esophagus. Okay, in CA esophagus, you will see irregular filling defects. Okay, you will see irregular filling defects. Abrupt tapering, shouldering sign. And the third one, here what you are seeing, S-like configuration. This is called as corkscrew esophagus. It is seen in a diffuse esophageal spasm. This is diffuse esophageal spasm, in which you will get a corkscrew esophagus. Fine. This is also a motility disorder only. So these are the three barium images you should know. But nonetheless, in today's day and age, for achalasia, you don't have to do barium. The first step will be endoscopy only. Only if I don't have endoscopy will I do barium. First step will be endoscopy. It is not a diagnostic test. It is done to rule out malignancy. Okay, it is to rule out C esophagus. And then the IOC, of course, is going to be manometry. What will I see on manometry that will tell me it is achalasia? In manometry, what will I see? It is given as per Chicago classification. You have the different types, type 1, type 2, type 3. But what do you see? One is you see 100% absent or ineffective peristalsis. Okay, you will see absent or ineffective peristalsis. Second is you will see high pressure in lower esophageal sphincter. Okay, you will see high pressure in a lower esophageal sphincter. Short form I am writing LES or lower esophageal sphincter. Okay, this is actually type 1 achalasia. Okay, this is actually type 1 achalasia. Now the treatment, if it's a very mild or patient is unfit, you can give these drugs, calcium channel blockers, or you can do Botox, not Botox of the face, Botox of the lower esophagus, or you can do an endoscopic dilation. These are treatments in today's day and age not very popular. Definitive treatment is going to be Heller's myotomy. Now, what do you do in Heller's? You cut the muscle. How much myotomy do you do in Heller's? What is the extent of myotomy? The distal esophagus or lower esophagus. The myotomy in lower esophagus should be 6 to 7 centimeters. That is how much muscle you are going to cut. And the cardia muscle, gastric cardia, is going to be 2 to 3 centimeters. So you have to cut muscle of the gastric cardia also, approximately 2 to 3 centimeters. So it is a cardiomyotomy. Okay. Endoscopic dilation is not the foolproof treatment. So I would still say go for Heller's. If person is symptomatic with dysphagia, go for Heller's. We don't do dilation in clinical practice. And for type 3 achalasia, you do POEM. POEM is per oral endoscopic myotomy. Okay, it is per oral endoscopic myotomy. What you are seeing in the second image, where the endoscope goes in the submucosal plane and does the myotomy. Okay, yeah, mucosa is not cut. Mucosa is not cut in any. Okay, it is not cut in any. Only here, little mucosa has to be cut, little bit, just to enter in the subcutaneous plane, in the submucosal plane. Little bit has to be cut here. How will you know in type 3 you will see spasms? Type 3 achalasia is also known as spastic achalasia. So the manometry will show esophageal spasms. Fine. Heller is abdominal, yes. Heller is abdominal. It's a laparotomy or laparoscopic procedure. Okay. Now come to GERD. Again, easy topic. GERD, what you must be getting? Acidity, acid reflux. The acid goes into the esophagus and it causes ulcers and erosions like you can see here. You get these kind of erosions. Okay, this is not Barrett's, huh? These are erosions. What you are seeing in the first image, this is normal. This is how your normal esophagus looks. This is the esophagus, the pink, light pink. These are the stomach rugosities. And this junction, where the esophagus becomes the stomach, it is known as the Z line, also known as the squamocolumnar junction, right? Squamocolumnar junction or the Z line. And now you are seeing across the Z line, there are all these erosions. So this is acidity or GERD. Now you will know how person will present. You must be getting it. You get heartburn. Okay, you will get heartburn or retrosternal burning. You may get epigastric pain. And there is one symptom which comes very late symptom. That is regurgitation. Other name for regurgitation? No, don't say pseudoachalasia. Pseudoachalasia means dysphagia hota hai bhai usme. It is also known as volume reflux. Also known as water brash. This is a very late symptom. If you get volume reflux, means the acid comes in your throat. No, belching means dakare aana. Belching means to burp. Okay. Volume reflux means he will say acid comes in my throat, not just burn here. That is a very late finding. That means all the sphincters have become so weak, right? So these are the typical symptoms. Sometimes you get some atypical symptoms. Do you know any atypical symptoms of GERD? Unusual symptoms. Very good. One is cough. It can trigger asthma. Cough, asthma, laryngitis, dental problems. These are also due to GERD, but these are unusual symptoms. Okay, atypical symptoms. Now, what will you do first step for diagnosis of GERD? First step, of course, will be UGI-scopy. How do you grade the severity of GERD? What grading? Like what you see here, there are some erosions. How do you grade it? It is graded by Los Angeles. Very good. You have a Los Angeles grading. So for achalasia, it was Chicago. Here it is LA grading, Los Angeles. Rarely you have to do this test, 24-hour pH study. That is the gold standard. But here gold standard means you don't have to do it in everybody. So the gold standard is 24-hour pH study. But I don't need to do it in everybody. Okay, it's not a must. It will only be done if the person is planned for surgery or other indication, very good, if he has atypical symptoms or yes, not responding to PPI, normal endoscopy. Patient has a normal endoscopy, even though he's having symptoms or he's having recurrent symptoms. Means you're not sure something is wrong. You're not sure is it due to GERD. When I want to break the tiebreaker, that is this 24-hour pH study. It's not a must. So if you get acid reflux, you don't have to undergo it unless one of these indications are there in you. And what you will get is a Demister score. If the score is more than 14.7, what does it imply? What is the implication of the Demister score? That means symptoms are due to acidity. Okay, symptoms are due to GERD. That's what it tells you. The symptoms match the timing of the acid reflux. That is the implication. Okay. So that is GERD. What is the treatment of choice? Very good. It is not surgery. Treatment of choice. It is not surgery. Treatment of choice is medical management. Medical plus lifestyle. Means don't smoke, don't have alcohol, don't have spicy food, oily food, don't go to bed after eating. That is the treatment of choice. Surgical indications are only if he gets complications or recurrent symptoms. Intractable. Okay, if it is intractable GERD or he starts getting complications. Tell some complications. लगता है आप लोग सब ले चुके हो इसलिए आपको पता है. Yeah, Barretts, hiatus hernia, they are the complications. So what surgeries do you do? This is the first oldest surgery where this LES, lower esophageal sphincter area, GE junction area, you make it tight by wrapping the fundus of the stomach around it. So the fundus is taken around it and wrapped tightly so that now the acid can't go up. So you are tightening the GE junction using the fundus. This is called floppy Nissen fundoplication. You are wrapping the full stomach 360 degrees. It's a 360-degree wrap. Floppy Nissen. Okay. The problem is if it is a little tight or if there is edema, the person will get short-term dysphagia. Okay, person gets short-term dysphagia because of edema. It will last for about 3 months. He can also get gas bloat. He will say, I am not able to burp. The air is stuck in my stomach. That is called gas bloat syndrome. To prevent these complications, they make the wrap a little less tight, like you do toupee. Toupee is not going 360, he is little less, so he is 270 degrees posterior. Okay, 270 degrees posterior. Or you can do door. Door is a name, it is not D.O.R. It is DOR door, where you do 180 degree anterior. Okay, it is 180 degree anterior. So these are some of the partial wraps. Partial wraps, obviously, the main thing is the dysphagia will be less. There is a chance of the disease recurring, but dysphagia nahi hoga. At least he won't say food is getting stuck now. Okay, that is the main advantage. Now come to hiatus hernia, where the stomach goes through the diaphragm into the chest. And there are these different types. Anterior posterior says no, there is no difference. Posterior is more physiological compared to anterior, but let's not go there. Now, what is type 1? Sliding type. Here the GE junction gets pulled up. Okay, there is a pulled up GE junction. This is the one which is associated with GERD. And this is the most common type. That is type 1. In type 2, rolling type, GE junction is normal. You can see here, it is below the chest only, below the diaphragm. It has not gone up. Only the fundus has gone up. This is seen in people who are elderly, who have diaphragmatic weakness. Okay, this is seen in people who are elderly. Whether diaphragm is weak, so the fundus has gone up like this. Then you have the mixed type, which is a combination. Yeah, rolling is also known as paraesophageal. Other name for rolling is paraesophageal. Right? This will usually be asymptomatic, but here there is risk of the stomach getting twisted. There is risk of gastric volvulus. Stomach may twist. And mixed type is a combination. What is the investigation of choice? IOC. First step will be endoscopy only. This is the IOC. Investigation of choice. CT with oral contrast. If this is not there in the option, then? If it is not there in the option, then only go for barium solar or barium meal. Okay, what is the treatment for hiatus hernia? Treatment for hiatus hernia? It will be surgery. Anytime in your life you see the word hernia, go for surgery. It's very simple. Hernia means surgery. Okay, so that is one complication. Second complication, easy complication, is Barrett's esophagus, where what is going to happen here, this is your normal GE junction. You can see the epithelium or the GE junction or the Z line has migrated. It is basically a columnar metaplasia. Okay, there is a columnar metaplasia or an intestinal metaplasia. Right, so some of your esophageal epithelium gets intestinal epithelium. And what is this intestinal epithelium going to be characterized by? It should contain mucus secreting goblet cells. Why did this happen? Why did this happen? Why did you get Barrett's? It is due to long-standing GERD. So the acid caused the squamous epithelium to become columnar. So it is an acid-induced complication. So person will have symptoms of GERD. Yes, it is reversible. If there is only metaplasia, it is reversible. No, foveolar cells are different. These are goblet cells. Okay, not foveolar cells. I think you're talking from some mock exam. That's why it's coming. So that was the odd one out. Okay, it is reversible if it is only metaplasia. Now, how to diagnose it? You will do UGI-scopy, in which you will see this. Now, don't call this GERD. You will see this. Your GE junction is getting projections. So there are tongue-like projections on endoscopy. Whenever you see tongue-like projections, it means it is Barrett's. But you want to know, is there any dysplasia? You are asking, is it reversible? Dysplasia is not reversible. So you want to know, is there any dysplasia? So for dysplasia, you don't take one biopsy, you take multiple biopsies. 4-quadrant multiple biopsies at 2 centimeter intervals each. So 4 biopsies at 2 centimeter intervals. This is called as Hiatal biopsy protocol, right? This is called as Hiatal biopsy protocol. This will tell you, is there any dysplasia? Then you determine the treatment. If it's only Barrett's, it is reversible. If there is no dysplasia, then just treat the GERD. Maybe do a fundoplication or give PPI and do endoscopic surveillance. Okay, and do endoscopic surveillance. And this surveillance should be frequent. It should be every 3 to 5 years. Okay, every 3 to 5 years are not 3 to 5 times a year. Every 3 to 5 years. If there is low-grade dysplasia, dysplasia has to be removed. So you will remove it either by doing endoscopic resection. That is called EMR, endoscopic mucosal resection. Or you can do endoscopic radiofrequency ablation. And here your surveillance will be even more frequent. Here the frequency will be 6 monthly. Means every 6 months. Okay, not 6 times per month. Every 6 months. And if it is high-grade dysplasia, you will do a multidisciplinary discussion. Okay, you will discuss your dean, your HOU, HOD will all meet and discuss what action has to be taken over you. Okay, they will decide what action has to be taken. And then you will have to do a resection either endoscopically or surgically. Fine. EMR or RFA दोनों नहीं हो सकते. That won't be the case, don't worry. Yeah, adenocarcinoma, it is a risk factor for adenocarcinoma. The dysplasia shows a risk of adenocarcinoma. वो तो मैं पहले बता चुका हूँ सी esophagus के risk factor में. Okay, answer this. Answer this. The squamocolumnar junction is located proximally. What is the most likely problem? It is a sliding hernia. Okay, easy questions. These are the kind of questions that come. Till when is surveillance done? Till there are 2 negative biopsies by pathologist. 2 negative biopsies. नहीं, cancer होने तक नहीं. Till you get 2 negative biopsies, you will keep doing surveillance. Please explain last question. Squamocolumnar junction is gone proximally. Means this. Squamocolumnar junction. GE junction. So it is type 1. ये धूप बाहर से आ रही है और कहाँ से आएगी धूप? Wait. I will adjust it. Don't worry. Dhoop will go. All these marks that you are seeing, they will go. Don't worry. As the sun passes. अभी 11 बजे है ना, और कितने 1000 से ज्यादा बच्चे आए हैं, सब देख रहे होंगे. Anyway, my face you will see till 6 o'clock. Why are you worrying so much? Where will I go? I am sitting in an air conditioned room. Imagine you are sitting in Delhi ka 5 degrees. Yes, Maithili, you understood it right. I'll not get up and move it. In previous question, what would be changed? Achalasia is not an endoscopic diagnosis. It was a manometric diagnosis. It will be diagnosed on manometry, not on endoscopy. Okay. Now come to infantile pyloric stenosis, VIMP topic. This is due to the tightness or hypertrophy of the pyloric sphincter, but this will not present in childhood. Means it will not present at birth. It will present a little later, usually in a child who is 4 to 8 weeks old. That is why correct name is infantile. It is not a at birth condition. And the child will present with a projectile non-bilious vomiting. Okay, it will be projectile, it will be non-bilious. Any child who presents with a non-bilious vomiting in the first few weeks of birth, okay, in the first few weeks of birth, could be a pyloric stenosis. It is not congenital. The correct name is infantile. You will examine the child, you will feel a mass in the right upper quadrant when the baby is relaxed. Okay, it is an olive-shaped mass felt in the right upper quadrant in a relaxed baby. Okay, olive mass. And when you give the child a test feed, you will see visible peristalsis from left to right on giving a test feed. It will be seen on the abdomen. Okay, all PYQs. More in male children, more if mother took erythromycin is very unusual in today's day and age. आजकल नहीं होता है. So what will you do? IOC is this. This is a PYQ image. You will see, you will do USG. The pylorus will be very thick. The thickness will be more than 4 millimeters. Okay, the thickness of the pylorus should be more than 4 millimeters. So USG is the IOC. What is this image? What do you see here? What do you see here in this image? What is the name of the image? This is a barium swallow or barium meal. Okay, don't make a child who's vomiting, don't give him barium to drink. It is just for theoretical purposes. This appearance is called mushroom appearance. Okay, this is called as mushroom sign. You can see here, this is the narrow area, and then the barium is going into the duodenum like this. That is called mushroom sign. Again, the other is the image over here. This is an X-ray. Again, don't do X-ray and all. This is an X-ray. And what you are seeing is single bubble appearance. Okay, this is single bubble appearance in pyloric stenosis. Double bubble, duodenal atresia, triple bubble, jejunal atresia. Okay, you must have studied in radiology, but we will diagnose it on ultrasound. That is the IOC. Now, because the child is vomiting a lot, he will end up with the most important metabolic problem: hypokalemia, hypochloremia, alkalosis, metabolic alkalosis with aciduria. Okay, with aciduria. Duodenal atresia will cause bilious vomiting at birth because the atresia is there since birth. So the child will vomit from the start. It is circular more than longitudinal. More than longitudinal. It is circular more, but both are affected. It's not only circular. Treatment of the condition, treatment of choice is this surgery. You are going to cut the muscle. This is Ramsted's pyloromyotomy. Okay, this is Ramsted's pyloromyotomy. Okay, this is infantile pyloric stenosis. Very easy condition. This kind of question should come. You will get the answer. Okay, answer this. Little light has gone. See, I tried. Any timeline when to do after the electrolyte problems are resolved? क्वेश्चन पढ़ने की भी जरूरत नहीं है, इतने बार क्वेश्चन पढ़ा. Anyways, patient with difficulty in swallowing both solids and liquids. What is the image suggestive of? Please don't say CA esophagus. This is not CA. This is a smooth tapering. So this is achalasia. If I ask you what is the next step, what is the answer? Bird beak will be the best answer. Why are you doing endoscopy? Was there this picture in real exam? I have not given the real exam, so I don't know. But it was similar picture only. Similar. Okay. Now come to this peptic ulcer disease. Easy condition. Who gets peptic ulcer and where are they located? Most common site. It is duodenum, first part, and lesser curvature of the stomach. Okay, first part of duodenum and lesser curvature of the stomach. These are the two common sites. Now, why does someone get peptic ulcer? Important risk factors. One is smoking. Other is NSAID. And third is H. pylori. How do you get H. pylori and where does it go? It goes and sits in the antrum. Okay, it comes feco-orally. It sits in the antrum and it does two things. One is it produces toxins like CAG, CAGA, and VACA, VACA. These toxins cause the ulcers. Second is it will produce urease, which also leads to the ulcers. Okay. Now, what you need to know, it's good to know Johnson's classification based on location. If you don't know the full classification, it's okay. The at least bare minimum thing you should know in this classification are type 2 and type 3. These two types. Type 2, type 3, which are located either here in the lesser curve near the pylorus or in the pyloric area, type 2 and type 3. These two peptic ulcers, they are going to be linked with high acid levels. Why do I need to know this? What is the logic? Because in type 1, the acid levels are normal. In type 4, the acid levels are normal. Why do I need to know this? Type 2 and type 3. Acid hypersecretion. How does it matter? Yeah, because only in type 2 and type 3 gastric ulcers will I do acid lowering treatments. And what will I do for type 1 and type 4? What to do there in type 1 and type 4? Okay. No, it's not PPI. It's something else. But first you diagnose it. First step for diagnosis is going to be UGI-scopy. It will show you where the ulcer is. And to prove there is H. pylori, you will do a antral biopsy. Okay, you do a antral mucosal biopsy. This is what you should know. This is what they will ask in the exam. I'm waiting for this question to come. You do a antral mucosal biopsy and you put it on the slide. This is called as, yes, rapid urease test. If the slide from yellow becomes pink, there is H. pylori in the mucosa. Okay, slide became pink or red. There is H. pylori in the mucosa. For diagnosis of H. pylori, this is what I do during endoscopy. Okay, we don't do breath test and all. The breath test is not for diagnosis, it is for follow-up. This is done on endoscopy. What is the treatment of choice? Treatment of choice for peptic ulcer? It is PPI. And if there is H. pylori, you will give H. pylori eradication. If it is there. This is the treatment of choice. So even in GERD, it was medical management. Here also it is medical management. Surgery will be done only if it is intractable, recurrent ulcers, or there are complications. Otherwise, it will always be medical management. Now, if I am doing surgery, this is where you need to know the treatment. If I am doing surgery for gastric ulcer, which is type 1, type 4 Johnson, that is these types where the acid levels are normal. J नहीं है वो I पूरा आया नहीं. So here you are not going to do a acid lowering surgery because acid levels are normal. Here you are going to do ulcer resection. For duodenal ulcers and Johnson type 2, type 3 ulcers, this is where you are going to do acid lowering surgery. Okay, so acid lowering surgery are for duodenal ulcers and for Johnson type 2, type 3 ulcers only. So what are the surgeries that you do for acid lowering? Two types. One is you can do vagotomy. Other is you can do antrectomy. Or you can do combination, vagotomy and antrectomy. Because vagus controls the gastric acid release. So if I cut the vagus, the acid will reduce. I can cut the vagus at the origin, means over here. So if I divide the anterior and posterior vagus at the GE junction, that is going to be truncal vagotomy. But the problem is, if I cut the vagal trunk, the pyloric innervation is gone. And then the pylorus will not relax. It will become very tight, like how you guys go in the exam. You become like a pylorospasm. Same way your brain goes in spasm. So you need something to calm you down now. You will start saying some mantra. That is called drainage procedure. Basically something to relax. It's needed, huh? Spasm, yes. Spastic paralysis. So whenever I do truncal vagotomy, I will require a drainage procedure. This is what happens to students who study too much. In the exam, they get confused. You studied surgery from me and other places and here and there and here and there, and in the end, you studied from me, revised from somewhere else. All confusion. Then you will wonder, you will try to remember some mnemonic. It will not work. Okay. So whenever you do a truncal vagotomy, you will require some drainage. Example of drainage procedures like a gastrojejunostomy. Because now the pylorus is not opening. So you have to join the jejunum over here. So now the food will go straight into the jejunum. So though truncal vagotomy is a good procedure, acid lowering is good, complications are high. Okay, remember, the more you do, the more the complications. One of the complications, you will see it later, is dumping. You will see it later. Okay, so doing too many things will always keep you, confused in your mind, which is why it is smarter to do highly selective vagotomy. Smarter. Don't run in FOMO. Don't live in FOMO. FOMO finishes us all. So what I do here in highly selective vagotomy, I divide the individual branches, not the trunk, the individual branches, where they are entering the stomach. Means study the IMPs. Study from limited sources, but properly. And spare the pyloric nerves. So if you are sparing the pyloric nerves, you won't go into spasm. You don't go in spasm, you are relaxed. Exam will be relaxed exam. So you spare the pyloric nerves. and this will not require drainage. And because you don't require drainage, it has very less complications. You will be happier in life. See, you will miss out on some questions. The recurrence will be little higher, obviously. Some nerves will be left, but you will be at peace. Okay, you will not make silly mistakes. When you say silly mistakes, it is because of confusion in your mind. So you don't want to make silly mistakes, you do limited things. Some things you won't get, but that's okay, right? It's not a big deal. Yeah, there will be less acid secretion, but it will still be a little bit higher compared to a truncal vagotomy. Truncal vagotomy ke aage, here the risk of recurrence is a little higher, right? Or you do antrectomy, means you remove the distal part of the stomach, which produces the gastrin. You remove that, means you excise this part of the stomach. That is called antrectomy. And after antrectomy, if I do this anastomosis, gastroduodenostomy, it is called Billroth 1, where I do a gastroduodenal anastomosis. It is called Billroth 1, but this is very difficult to do, which is why nowadays what you will prefer to do is a Billroth 2, that is called GJ, gastrojejunal anastomosis. Here also there is risk of dumping, because here also food will go straight into the jejunum. So dumping risk is there, which is why antrectomy and truncal vagotomy both have high complications. But if I ask you which has the most power, which will have the least recurrence, it is this combination combined. The recurrence is the least, but side effects are also high. So least complications, but more complications, but least recurrence is going to be truncal vagotomy with antrectomy combination. But if I ask you least complications, little high recurrence, it is highly selective vagotomy. Here the side effects are the least. Recurrence is little higher. Of course, it's little high, not very high. 2 to 10% is not a lot, but this is the most well tolerated. Patients are quite okay because you didn't have to do any drainage procedure. They don't get that much dumping. It is the best tolerated procedure, highly selective vagotomy. In today's day and age, which of these procedures is actually done? If I ask you, what is actually done in today's day and age? What is the answer? None. Very good. Yes, none. None of these are done. In today's day and age, this is done. Okay. In today's day and age, because medicines are very powerful compared to these surgeries. These surgeries don't have that much benefit. The indications are very limited in today's day and age. Okay. And a little bit about dumping. Early dumping, which happens almost immediately, it is due to a rebound hypotension. So patient eats certain foods, and after eating those foods, he gets bloating, fullness, lightheadedness. That is called early dumping. It is because of hypotension after certain foods. Late dumping is because of hypoglycemia. What you must be getting now. Correct. It is because of hypoglycemia, rebound hypoglycemia. But this takes little time, 1 to 3 hours after meals. The triggers are similar, symptoms are different, timing is different. So here you get symptoms of hypoglycemia, tremors, fainting, tachycardia, sense of impending doom. That is late dumping. Okay, the management for both is the same. You have to do dietary modification. Okay, that is going to be dietary modification. Yes, yes, you will get time. Breaks will be time, don't worry. You will get time breaks, don't worry. I will not kill you. I don't want to kill you, give you pressure source. And I don't want you to be exhausted at the end of 6 p.m. Okay, because I want you to attend Dharma also. And then after that, revise at night. So patient is offered various surgical treatments. Which of these has the least side effects? Least side effects will be highly selective vagotomy. Okay. It is highly selective vagotomy. Dumping will happen because the food has quickly gone in the jejunum. So if you had a sweet liquid like a milkshake, okay, which has a lot of osmolarity, if I had a lot of milkshake, the blood from my mesenteric vessels will go in the jejunum. So I will get a plasma will reduce. Plasma has gone in the jejunum. Okay, so now my blood volume has reduced. That will cause hypotension. This happens immediately. Hypoglycemia will happen after some time. If I again have sweet liquids like a Coca-Cola, whatever sugar is there, it went in my blood. I got a sugar spike. It caused an insulin spike, and that insulin caused a rebound hypoglycemia. Okay, there are no metabolic problems. It's not a metabolic condition. It's a physiological condition. A full table, no. You just need to know the IMP points that I have told you, relation to meals, aggravated by, relieved by, these kind of things. Small frequent meals will help. You have to avoid the triggers. Whatever triggered the dumping, that has to be avoided. It will require only dietary modification. So, patient had 10 beers, after which he started binge. After that, he started vomiting. He got upper GI bleed. This is Mallory-Weiss stare. You will ask me, sir, what is Boerhaave syndrome? What is Boerhaave syndrome? In Boerhaave syndrome, there is a spontaneous esophageal perforation. Okay, the esophagus bursts in Boerhaave because you are intoxicated. The sphincters don't open. You vomit against closed glottis and the esophagus explodes. So there is a spontaneous esophageal perforation in Boerhaave. And because of this, the person will get chest pain because the esophagus starts leaking in the chest. He gets chest pain. He gets retching. And some of the air goes in the chest wall. He gets a subcutaneous emphysema. Okay, this is a life-threatening condition because esophagus has burst. Yeah, he can get shock also. Yes, eventually. This is called macular triad. Okay, this is called macular triad. This will require emergency surgery. To confirm, you will do CT. CT is the confirmatory test, and this will require surgery. Mallory-Weiss tear is okay. You must have gotten it. No problem. It is a tear of mucosa at GE junction. Okay, it's only mucosa tears. The esophagus is not burst. It is a tear of mucosa at GE junction. So because of that, he gets hematemesis. I'm writing hematemesis, not hematogenous, hematemesis. And this is usually self-limiting. Okay, so if this happens to you, don't worry. The bleed, it's a mucosal tear, nothing happens. If it's too much, then get endoscopy done. Why will we get everything? Who will pass this exam and have 10 beers? Not me, right? You will only do it. You'll only pass exam and have 10 beers, na? Who will get it then? That's why I say no. Why do we do CT? To confirm that there is a leak. CT is the investigation of choice for Boerhaave. Okay, who drinks 10 beers? Let's not go there. Who drinks 10 beers? If he is unstable, then directly surgery. Yes, but usually should not be unstable. Should not be. But yeah, you have to know it is leaking in the chest. That's why. Now come to peptic ulcer perforation. Easy condition. It's one of the important complications of peptic ulcer disease. Where does the perforation occur? It is in the anterior D1 ulcers. Okay, anterior D1 ulcers. Posterior ulcers bleed. Anterior ulcers perforate. So this will lead to peritonitis. When the ulcer will perforate, he will get peritonitis. So because of peritonitis, how does he present? He will come with acute abdominal pain. So they will give you a scenario. Patient who has history of smoking or NSAID, something like that, has now come with acute abdominal pain. It is likely to be a perforation. there will be cardboard-like rigidity on palpation. Right, cardboard rigidity or generalized tenderness. Some word like this will be given. First step, you are going to stabilize them and you will do X-ray. So first step will be stabilize and X-ray. This X-ray many times they have asked you. Many times. So this is the right dome and the black thing below is the free air. This is the left dome of the diaphragm. This is the free air. So you will see free air under the diaphragm. That is the diagnostic finding. So you are looking for free air under diaphragm, also called as pneumoperitoneum. If free air is present, what will you do? And many times students fight with me over this. If there is free air under the diaphragm, cupola sign is one of the signs like free air. Cupola sign, Wriggler sign, you will study in radiology. If free air is present, straight away go for surgery. And in surgery, what will you do? You do Graham's omental patch repair. Okay, the name of the surgery is Graham's omental patch repair that you are seeing in the image. This one. You put the omentum on the perforation and stitch it. But if I don't see free air, then what to do? I am suspecting perforation, but free air is not seen, then you do CT abdomen. Okay, because this is the best test. It is the IOC. And if CT shows free air, then also you go for surgery. So students always ask me, sir, if patient is stable, should I do CT? Its answer is no. If I see free air, I don't need to do CT. Because wherever is the perforation, you are going to do surgery. Okay, so it's not a must to do CT. Can it call hollow viscous perforation? Yes, it is hollow viscous only. Yeah, there is a difference between Grams and modified Grams, but I don't think you should know that. I mean, that is a little too much. IF is if, it's not a short form. It's the word if present, if absent. There is a difference between Grams and modified Grams, but let's not go there. I mean, बहुत complicate हो जाएगा फिर बिना reason. So barium image is done and you are seeing this. This is a narrow terminal ileum and the IC junction is pulled up. You are seeing a pulled up IC junction. Narrow terminal ileum, ileal stricture. This is called as string sign. Pulled up IC junction, narrow terminal ileum, string sign. This is ileocecal TB. Okay, this is ileocecal TB, quite simple. So few points about intestinal TB, then I'll give you a little break. Cantor is in Crohn's. Cantor is in Crohn's. It is not here. Most common site of intestinal TB. Where does it normally occur? Most common site. It is the IC junction. How does it reach there? How does it reach there? It is a secondary TB because of swallowed sputum. You had a pulmonary TB, you cough and you swallowed the sputum. It went in your intestine and it got stuck in the IC junction and that's where it entered and caused the tuberculosis. What are the types of intestinal TB? What do you normally get? What you are seeing in this image, what are these? You normally get ileal ulcers. And these ulcers, as you can see, the typical appearance, these are transverse ulcers. Okay, transverse. So when they will heal, one of the complications that will occur is stricture. What you saw in the earlier question, you will get a ileal stricture. That is one problem. Sometimes these ulcers can also perforate. So you can get ileal ulcer perforation also. What is the other way in which you get the tuberculosis? Other manifestation? Very good. The second type is called hyperplastic sickle. And sometimes you can get a mixed type also. So the second type is called hyperplastic sickle, in which you get thickening, lymphadenopathy, fibrosis. What other complications can occur? because of tuberculosis. Other complications, very good. You can get peritoneal TB. You can get peritoneal TB, where you will get adhesions or ascites. Okay, adhesion, ascites. Fourth, you can get perianal fistula. Very good. So these are some of the complications you can get, and you can get the same complications in Crohn's disease also. So TB and Crohn's are 90% of the similar presentation. So how will the person present? If he is stable, means uncomplicated, he will have chronic diarrhea, pain, weight loss. And in this case, what you will do? Chronic diarrhea, pain, weight loss. How will you diagnose the condition? First, you will do stool exam. Stool will show pus cells. That's it. Nothing else will be seen. Then the IOC is going to be colonoscopy with biopsy. You see the ulcers, you do a biopsy, and you send it for TB test, TB culture, or TB MGIT, or you send it for gene expert, CBNAT. That will tell you it is a tuberculosis. This is how you will differentiate it from Crohn's. In Crohn's, all these tests will be negative. In Crohn's, you will have to do biopsy where you will see transmural inflammation. If he presents an emergency with acute abdomen, then what will you do? Then you can't do colonoscopy with biopsy. In that case, what you will do? If it is there, pulmonary may not be active, but it has come from the lungs only. So here, first you will do X-ray, and then if required, you will do CECT. And this person may require surgery. Depending on the complication, he may require surgery. Fine. Will there be pus cells in Crohn? Yes, it's inflammatory bowel, so there will be pus cells there also. X-ray finding depends on the complication. Like if he is having stricture, you will see air fluid levels. If there is perforation, you will see free air under the diaphragm. So it depends on the complications. Fine, cool. XCS surgery. Fine. So let's take a short break. It's 11:39. Let's be back by 11:55. Okay, string sign is in Crohn's also. उसमें भी मिलेगा आपको. Fine. Hello guys, I hope now you can see all the components of my face. Trump is giving me dhamki. Obviously, I get scared. Right. Okay, let's start. Many things are still to be done. So we were on intestinal TB. Now let's go to appendicitis. Now, who gets appendicitis? Typically, some of you must have gotten appendicitis. It is usually seen in teens or early 20s. What is the most common risk factor? What is the most common risk factor? Why do you get appendicitis? What is the risk factor for it? Arre? No, don't say male and all. It is because of hypertrophic Peyer's patches, which cause obstruction of the base of appendix. You get a GI infection, the Peyer's patch undergo hypertrophy, and they cause obstruction. What is the most common site of appendix? Anatomically? Most common anatomical site? It is retrocecal. 70% are retrocecal, means it is behind the cecum. Right, it is retrocecal or behind the cecum. So many times the clinical signs are not very clear cut. The typical clinical presentation is you will get right iliac fossa pain. That's how usually you will get it. It starts at the umbilicus, migrates to the right iliac fossa. You will have vomiting and some fever. What is this called? Very good. It is called Murphy's triad. Where do you see Murphy's sign? This is called Murphy's triad. Where do you see Murphy's sign? It is a cholecystitis where you press in the right upper quadrant, ask him to take a deep breath, and he winces in pain. That is cholecystitis. That is a diagnostic sign of cholecystitis. This is appendicitis triad. Pain in the right iliac fossa, vomiting, fever. When you will palpate, you will get tenderness at the McBurney's point. That is the point of maximum tenderness. Okay, that is McBurney's point. It is on the right spino-umbilical line. 2/3, 1/3. Okay, on the right spino-umbilical line. That is your McBurney point. It will be somewhere here. 2/3, 1/3. Okay, 2/3 from the umbilical side. Then you get Bloomberg sign, that is rebound tenderness. The first two signs are the most important signs. These are the ones that you look for clinically. Tenderness and rebound tenderness. Then some rare signs like Rovsing sign where you press in the left iliac fossa and he gets pain. Okay, you press in the left iliac fossa, he gets pain in right iliac fossa. That is called Rovsing sign. And then there is psoas sign where he gets pain on hip extension. Okay, you extend the hip, he gets pain. This is also seen in retrocecal appendix. Okay, pain on hip flexion is obturator sign. That is the reverse. If you flex the hip and he gets pain, that is obturator. IOC in children is going to be ultrasound, which will show dilated, thickened appendix. The appendix diameter is more than 6 millimeters. What you can see here, this is the appendix. It is very thick. And there will be edema in the wall. Any inflammation, you will see edema. Okay, that means there is an inflamed appendix. But in adult, you don't rely on ultrasound. In adult, you rely on CECT. Because you also want to rule out tumors of the appendix causing appendicitis, because adults don't get appendicitis normally. So you want to rule out tumors. IOC in pregnancy, this is not always required. So normally ultrasound is enough. But if the woman is in the 3rd trimester and it is missed, then in that case, the IOC, it's not ultrasound, it will be MRI. Okay. It is not ultrasound, it is MRI. But it is not always required. Ultrasound many times is sufficient. Then you come to treatment. So if the person has appendicitis, obviously the treatment will be appendectomy. That is a treatment of choice. Nowadays, it is done laparoscopically. But if he gets an appendicular phlegmon, you understand what a phlegmon is, right? Where the appendix gets covered with the omentum. It's very badly inflamed. Maybe it is perforated, and then the omentum will go and cover it. That is called appendicular phlegmon. In that case, you do what is called as conservative management. Ostner-Scherin regime, that is conservative management. And later you may do an interval appendectomy. You should know the incisions of appendectomy, of course, the easy ones. The open appendectomy, like if you become a surgery resident, this is what you will learn first. It is also known as the McBurney incision or the gridiron incision. The correct name is MacArthur. Okay, MacArthur is the correct name, but in many places they call it McBurney. I don't know why. It is a muscle splitting incision. Okay, it is a muscle splitting incision. It is at this area only. This is the McBurney point. You take an incision like this. It is centered at the McBurney point. So you split. Which muscles are you splitting? Which muscles do you split? All. Yeah, all the muscles in the flank. External oblique muscle, internal oblique muscle, transversus abdominis muscle. They are split. But if I don't get enough exposure, I cut those muscles. That is called as Rutherford-Morrison. It is a muscle cutting incision. Okay, the problem with muscle cutting incision is there is risk of nerve injury. Which nerve will get injured? The risk of injury to which nerve will get injured? Iliohypogastric nerve. That's why you avoid cutting the muscle, because there is a risk of injury to hypogastric nerve, which will weaken the lower abdominal wall. He will get inguinal hernia. Then you have Lance's skin crease incision. It is a cosmetic incision. Okay, it is a cosmetic incision, right? Also called as bikini incision. Correct. Cosmetically appropriate, or you can say inappropriate also. वो भी बोल सकते हैं. It is inappropriate sounding at least. Most common early complication of open appendectomy is surgical site infection or wound infection. Most common late complication is adhesions or adhesive obstruction. Though these sound unusual, they are seen, which is why to prevent these complications, nowadays we do lap appendectomy. In lap appendectomy, none of these complications occur. Okay, there it is simple. Okay, so see, understand, whenever there is acute abdomen, either I do X-ray or USG. If indicated only, I will do CT. It's not a must. If I have any diagnostic problem, then like an obstruction, I will do CT. But if I see free air, I don't need to do it. Fine. So these are some of the complications you should know of. And this is the nerve which gets injured in open appendectomy. And what you should know as an FMG student, VIMP, is this image. Because you will confuse this image with one image you have mugged up in all the PYQs. That is this image. Okay, that is this image. So please understand, this is not Meckel's diverticulum. This is appendix. Now, how to know it is appendix? This what you are seeing here, this is cecum. How do you know it is cecum? You can see this band over here. That band is called tinea coli. When I was teaching in the mission classes, one student says, sir, दोनों images compare करके बताओ. This is tinea coli of the cecum. Second is, this is a dilated, this is an inflamed appendix. This yellow thing you are seeing, that is the mesoappendix. Okay, that yellow thing you are seeing, that is the mesoappendix, the mesentery of the appendix. Okay, compare it with this. This is not having any mesentery. Where is the mesentery here? In fact, it is coming on the anti-mesenteric border. This is Meckel's. It is on the anti-mesenteric border. It is coming from the small bowel. It is not coming from the cecum. Like what you are seeing here, this is small bowel. How? This yellow thing is the mesentery of the small bowel. So it is an anti-mesenteric diverticulum of the small bowel. So this is Meckel's. Okay. Don't call this Meckel's. This similar image came in INI-CET also. They gave an image of a hernia containing something like this. Students didn't know whether it was Meckel's or whether it was appendix. Appendix is called, what is that? Amine hernia. Meckel is called litter hernia. They couldn't identify it because they were confused. Is it appendix or is it Meckel? Now you will not make that mistake. Okay. So side by side, you are preparing for NEET PG also. This is McBurney point. Okay, easy question. A man presented with symptoms of nausea, vomiting, and fever. He was diagnosed with appendicitis, posted for emergency appendectomy. This was found incidentally. This is Meckel's diverticulum. Okay, please understand. It is a anti-mesenteric. Means the mesentery is on this side. It is coming on the other side. It is an anti-mesenteric diverticulum. If they ask you treatment of carcinoid, they should not. If they ask you carcinoid, the treatment of carcinoid is en bloc excision or radical excision. En bloc means radical removal. Means you have to remove lymph node also. It is en bloc excision. En bloc means radical, means remove tumor with a margin with lymph nodes. So what is Meckel's? It is a remnant of which structure? Which embryological structure is it a remnant of? Alvarado should not be asked. I don't think so. It is a remnant of vitelo-intestinal duct. It is a duct that connects the intestine or the ileum to the umbilicus in utero. Normally, the duct will disappear. If some part remains patent, little part, it will form a diverticulum like this. Okay. Then it has the rule of twos. It is a congenital true diverticulum. You understand the meaning of true diverticulum? True means what? It contains all the layers. Okay, it contains all the layers. Omphalomesenteric vitelo-intestinal is the same. Almost the same. More or less. But the correct name is vitelo-intestinal. It is located on the ileum, 2 feet proximal to IC junction. Somewhere in the ileum. And the mucosa, apart from it containing intestine, it may contain ectopic mucosa. Means it may contain ectopic gastric epithelium and sometimes ectopic pancreatic epithelium. Obviously, gastric is the most common. So if it contains gastric epithelium inside over here, if it contains, it will produce acid. The acid will go in the ileum, you get ileal ulcers. And those ulcers will cause bleeding. So if it's a child, he will present with a PR bleeding, also known as other name for PR bleed. Other name for PR bleed? Hematochezia. No. Again, don't say malina. Hematochezia. Adult should not contain the epithelium. So adult, it will be found incidentally. Or if it gets inflamed, he will get diverticulitis, which will mimic appendicitis. Okay, it will mimic appendicitis if it gets inflamed. Right. So in a child who has a PR bleed, to diagnose it, you do this test in a child. That is called technetium-99 scan. What are you seeing in the scan? This is the gastric epithelium, and this little other hot spot you are seeing in the right iliac fossa, that is the ectopic gastric epithelium. So it is not telling you it is Meckel's, it is telling you there is ectopic gastric epithelium somewhere else. That's how you know this is the Meckel's diverticulum. In an adult, you won't do the scan. In an adult, you will do CT scan. What is this image? This one. What is this image? Don't say it is CT scan. This is a barium meal follow through, BMFT. Like you did barium swallow, barium meal for esophagus and stomach. Here you have given him barium and taken the X-ray after 6-7 hours. So the barium has gone from the stomach, duodenum into the small bowel, and you are seeing this diverticulum. This is Meckel's diverticulum. Okay. And then the last part is the treatment. This is the easy part. If it is found by chance, then what will you do? Barium enteroclysis means you put a tube in the small bowel and then give the barium injected. He does not drink it. If it is asymptomatic incidental, then leave. If it is symptomatic or complicated, then you will resect it. Okay, then you resect it. Fine. And when you resect it, this is what do you see here? What has happened over here? This is also Meckel's. Again, see, this is small bowel. This is the mesentery of the small bowel. This is the anti-mesenteric diverticulum. Okay, this is an anti-mesenteric diverticulum. In workbook, it is in pediatric surgery. Yeah, it has become ischemic. Correct, it has become ischemic. Okay, answer this. Patient with history of constipation undergoes imaging. What does it suggest? What is the imaging that is done here? What imaging is this? Since you are all giving the answers because you have mucked up the question. This is barium meal follow through. No, it's not barium meal follow through. You फेंकते हो, फेंको मत. This is barium enema. Okay, what you are seeing here, this big thing below, this is a rectum. Okay, someone was saying, isn't this anal canal? No, no, no. Anal canal is not seen. Rectum will be somewhere here in the pelvis. Uske niche kahin hoga anal canal. This is all small bowel. So this is barium meal follow through only, and this is barium enema because the enema will go from the rectum into the sigmoid colon and the descending colon, and you will see these diverticuli. Okay, so this is barium enema, and these diverticuli that you are seeing, this appearance is known as sawtooth appearance. Okay, this is sawtooth appearance of sigmoid diverticuli. Fine. Yeah, these are false diverticuli. These are seen because of increase in pressure. They only contain mucosa. Yeah, IOC is CT. No, no, no. IOC for sigmoid diverticuli is colonoscopy, not CT. They are seen on colonoscopy. If they are complicated, then you will do CT. Like if there is diverticulitis. Okay. Now come to rectal prolapse. It is usually seen in elderly people, or another risk factor is malnutrition, weakness, something like that. Elderly, malnourished, or obstetric trauma. Okay, obstetric trauma. Basically something that makes the pelvic floor muscles very weak. Okay, the pelvic floor muscles very weak. I don't know how you are seeing this as an apple. ये कौन सी एप्पल है? आप लोग किधर किधर से खाते हो ये सब? हाँ, it's not apple. It is prolapse rectum. Okay, and it is getting strangulated. It's looking quite scary. Now, whenever rectum prolapses, you have to push it up surgically and fix it. Either you push it up from below, perineal procedures. These are preferred in elderly, unfit patients. Okay, elderly, unfit patients. Where you can do this procedure, you take a stitch. After pushing the prolapse back, you take a stitch, purse string stitch, that is called Thiersch's anal wiring. You tighten the anus with a steel wire. Earlier it was a steel wire. Now you use nylon tape. So you push the prolapse and you take a stitch circumferentially, purse string stitch. And you make it tight. Obviously, anus can become too tight. Then he may get constipated or obstructed. Right? So not very commonly done nowadays. What is preferred if you are doing perianally is you can do Altemeyer. It is preferred for strangulated prolapse, where you resect the rectum from below. So whatever this prolapse which has come out, with a circular stapler, you just cut it out. So this is preferred for strangulated prolapse. It is a type of rectal resection, but it is done from below. And then this third image that you are seeing, this is Delorme's procedure. This one, where you take stitches like this, plicating stitches. So it is also known as Delorme's plication. So these three surgeries, Thiersch, Altemeyer, Delorme, are done from below. But if the person is relatively young, and he is fit, then you would prefer to do abdominal procedures because they have a much lower recurrence. Okay, much lower. You can do open procedures like this you are seeing. Some names you should know. One is called Ripstein. Other is well. These are procedures where you go in the abdomen, pull up the rectum and fix it with a mesh. So you are doing a mesh rectopexy. Nowadays it is done laparoscopically, that is called as laparoscopic ventral mesh rectopexy. What does ventral mean? Why am I saying ventral mesh rectopexy? Aage, what is aage? Ventral means anterior, means what? What kind of mesh? Polypropylene mesh. Underside. Okay, this image that you're seeing, the mesh is anterior or posterior in this image? The image that is there, it is anterior or posterior? This is posterior. In laparoscopy, you put the mesh anterior. Okay, it will come over here. That is anterior. Anterior to sacrum, nahi, anterior to rectum. Okay? Fine. Good. Now come to intestinal obstruction. VVIMP topic. Acha, uska anterior. Obviously, it's a rectal prolapse, na? You're doing mesh rectopexy. So if you're doing rectopexy, the context will be in context of the rectum and not some other like sacrum becrum se kuch sambandh nahi hai. It is in context of the rectum. Mesh is like a glue. No, mesh is like your hernia mesh. Same. Polypropylene mesh. Not a not glue, hernia mesh. Okay. Now come to paralytic ileus. It is a functional intestinal obstruction. It is not a mechanical obstruction. It's a functional problem. It can affect any part of the bowel. Okay, any part. The most common risk factor is post-surgery, post-laparotomy. So you underwent a laparotomy for some disease. Post-operatively, you get this problem. Some electrolyte problems associated with it. Hypokalemia. Remember, I taught you in the mission classes, GIT, surgery, electrolyte, hypokalemia. Okay. 99% of the times you will be right in GIT. Now, how will the person present? No, don't use bethanechol neostigmine. Someone said this in the QR classes also, the revision classes. No, bethanechol neostigmine is for pseudo obstruction, not over here. Paralytic ileus, maybe don't use it. Okay. Paralytic ileus management is very different. So patient will have history of laparotomy 2-3 days back. He's still in the hospital. You will use vomit. He will have vomiting, distension, constipation, obstipation, but he will not have any pain. There is no colicky pain. That's how you know it is not mechanical. It is functional. There is no colicky pain. Bowel sounds are absent. In contrast, in mechanical obstruction, like a tumor stricture, there will be colicky pain. There will be hyperperistalsis, high-pitched bowel sounds. Here, the bowel sounds will be absent or weak. To investigate, irrespectively, the first step will always be X-ray. Because I want to know, is it mechanical or is it actually paralytic ileus? In mechanical, you see this step ladder pattern. So you will see step ladder air fluid levels in mechanical. And paralytic ileus, no step ladder, just dilated bowel. So there is no step ladder. And here you can see gas has gone all the way into the pelvis, means gas is in the rectum. So you see air in rectum. So on X-ray, I can differentiate the two conditions. If it's a paralytic ileus, the treatment is going to be conservative. Okay, usually in 2-3 days, things will get better. Nilpar oral, Riles tube, potassium, IV fluids. He will be okay. If I see step ladder pattern, like you see in this image, here what will you do? Here the next step, VVIMP point is going to be CECT abdomen. Okay, and then decide the treatment. So here it's not necessarily conservative. Here it is CT. CT will tell you why is there an obstruction. Okay. So very important point, don't make a mistake over here. This is where you will get screwed. If there is free air, you can do surgery. If there are air fluid levels, you have to do CT. Okay. Pregnant lady, how to treat appendicitis? If it is severe, you do appendicectomy. Treatment of appendicitis is appendicectomy. Mechanical ileus means mechanical obstruction. This means it's a mechanical obstruction. This is a paralytic ileus. Right? Now intussusception, bowel has gone into adjacent bowel. It has caused a constriction from outside. Paralytic, normally no. Normally no. See, a small bowel, mechanical means small bowel obstruction. It means the same thing. Small bowel obstruction में ही air fluid levels दिखते हैं. It is a type of mechanical obstruction. Okay. Now, who will get intussusception? Usually it is seen in children. It is the ileocolic type or the ileocecal type. Why does it occur? Why does it occur? Due to hyperplasia of Peyer's patch. Same thing. Lymphoid follicles are the problem. Due to hyperplasia of Peyer's patch. So the child got gastroenteritis, Peyer's patch became hypertrophic, or he took rotavirus vaccine, Peyer's patch became hypertrophic, and it started the intussusception. Ileum went into the cecum. In an adult, it is going to be colocolic. Some part of the colon went into the adjacent colon. And it is due to tumors, benign or malignant. Could be a polyp, could be a cancer. Right? But most of the times it will be seen in children. So when will the child present? He will present at 6 months to 12 months, weaning period. After he got gastroenteritis, he starts crying in pain. He starts lifting his legs towards his abdomen, and the stools are red currant jelly. Okay, he gets red currant jelly stools. And when you will examine the child, there will be empty right iliac fossa, which is called sign of Duns. Okay, which is called sign of Duns. There'll be a sausage mass around the umbilicus. Okay, so clinically you have an idea. It is an intussusception. First you will do X-ray. Then you will do USG. You can do CT. You can do barium enema also. All three are okay. Radiology teacher will say barium enema. In practice, either of them can be done. Okay, if you ask radiologically, they will say barium enema is the IOC. But I think that's stretching it a little too far. What will USG show? You can see over here. Seen on USG or CT, donut sign or target sign. Okay, donut sign or target sign. On barium enema in this image, you are seeing this typical appearance. This is called claw sign. Now, the important part is the treatment. Very important. If the child is stable, then you don't have to do surgery. You can give a high pressure enema. Okay, you can give a high pressure enema, also called as hydroreduction. Okay, hydroreduction. You can give with air, you can give with barium, but it has to be with some force so that the enema fluid goes and pushes the intussusception out. But if the child is unstable, if there is ischemia or any complication, then you will do surgery. Okay, and in surgery, you can reduce the intussusception, see if it works, or you may have to do a resection and anastomosis. Whatever is possible. If it is ischemic, obviously you will reset. If it is not ischemic, you try to reduce it. Okay, no, coil spring sign is another. Barium or air, either of them can be used. Okay, either of them are okay. Right, then come to sigmoid volvulus. What is unique about this sigmoid volvulus? What happens here? Sigmoid has become long, elongated, redundant. What happens when it gets twisted? You get a closed loop obstruction. Very important point. Any volvulus is a closed loop obstruction. Closed loop means no entry, no exit. It is stuck. Neither can things come inside, nor can things go outside. This will dilate. It will become ischemic, gangrene, perforation. So it is a true surgical emergency. Ischemia is very fast. Okay. So an elderly patient with history of chronic constipation. So you'll have chronic constipation. He now comes with distension of abdomen and obstipation. You understand what is obstipation? So now he will have distension. He will have obstipation, means he will say, I can't pass motion. I can't even pass flatus. Neither flatus nor stools. First step will be X-ray. X-ray will show coffee bean appearance. What is the other name of this sign? Apart from coffee bean? Bent inner tube sign. Okay, if they want to trouble you, they will put this bent inner tube sign. IOC is going to be CECT. So if he is stable, you have to do CT because you want to know, is the twist complete? Is the sigmoid already ischemic? Because if he is stable, there is no ischemia, then what will you do? If there is ischemia, then what you will do? If no ischemia, then what will you do? No, don't say, yeah, how do you decompress it? How do you rotate it back? Flatus tube, you do colonoscopic decompression. Or you can put a flatus tube. Preferred treatment is going to be colonoscopic decompression. Means put the colonoscope, suck the contents. Once the contents are sucked, it may untwist spontaneously. If there is evidence of ischemia, you will do surgery. What will you do in surgery? Untwist it and remove it. That is called a sigmoidectomy. Okay, you can untwist it and do a sigmoidectomy. Fine. After sigmoidectomy, you can do a Hartmann procedure, plus minus Hartmann. Means after sigmoidectomy, if you don't want to do the anastomosis, you can do Hartmann. So this is the descending colon. This was the sigmoid colon, which became ischemic, and this is the rectum. Now you have done the sigmoidectomy. Sigmoid is removed. Now either you join it, if possible, either you join the two ends, but if you can't join the two ends, then you can stitch the rectum, leave it there, and bring the sigmoid or the descending colon out as a stoma. This is called Hartmann procedure. Okay, close the rectum and do a colostomy. This is not what we did in APR. Remember, APR में ये नहीं किया था. In APR, it was a permanent colostomy. There the rectum anus was removed. Here rectum is there inside. So don't call this APR. This is not APR. Okay. This is sigmoidectomy with Hartmann. This is a temporary colostomy. Here the rectum is there inside. Okay. Fine. See, if you study like this now, you will become experts in surgery, not just for exam, but overall, you will have confidence. Otherwise, you will say, aisa to vaisa. You will mix up anything and everything. They are very different things. They are very different. Hartmann is not a part of APR. Okay, it can be done for rectal cancers which can't be treated. Okay, fine. Exam पहले निकाल लो. ठीक है, फिर देखना क्या करना है. Lads is done in midgut volvulus, not sigmoid volvulus. That is midgut, where there are Lads bands. Anyways, what do you mean by fistula? Do we need to spend time? Yes, you can, not here, but you can read Finch's classification. It's not required here, but you can do it. So what is a fistula? It is a complication of perineal abscess. First, you got a perineal abscess. It bursts and it may form a fistula. Okay, it's a complication of a poorly treated or untreated perineal abscess. Now, the fistula is nothing but a tract, and the way in which the tract goes, it is given by Park's classification. Depends on the direction of the fistula tract. Because now you should see here, This is internal sphincter. This is external sphincter. Okay, here also internal sphincter, external sphincter. And these red lines, they are the fistula tracts. So if you see here, the fistula tract is going from the anal canal between the two sphincters and opening over here. Okay, so most of the tract is between the two sphincters. So what would you call this? This is Parkes type 1 or intersphincteric fistula. So the image A, this is Parkes type 1. Okay, this is Parkes type 1, also known as intersphincteric. This is the most common type. Okay, this is intersphincteric. And overall, this is the most common type. 40 to 50% of fistulae are intersphincteric. This image was asked in NEET PG this year. However, sometimes the fistula tracts, they go through the external sphincter and come out like this. They are crossing the sphincter. This is Parkes type 2, also known as transsphincteric. Okay, this is Parkes type 2, transsphincteric. This is the second most common. Type 1 most common, type 2 second most common. And both of these together are put under the category of low fistula. Low means they are below the pelvic floor. Now see the third one. Sometimes the fistula tract goes above the external sphincter and then comes down. So it went above the external sphincter and then came and opened. This is Parkes type 3. This is suprasphincteric. And the fourth type, it's not an anal fistula, it's a rectal fistula. You can see over here, it is starting in the rectum. This is the rectum. It's starting in the rectum and opening out like this. So this is type 4. It's actually a rectal fistula. It's not an anal fistula. This is called as extrasphincteric. And obviously it's quite rare. Rectal fistula are very rare. And these two together, type 3, type 4, they are called as high fistula. Okay, so usually we get type 1, type 2. Patient will present with history of abscess and he will come with some wound like this from which some liquid is coming out. So he will come with a discharge from the perineal area. Okay, that is how he will present. What is the IOC? It is going to be MRI perineum. Okay, the IOC is MRI perineum. And the treatment, if it's a low fistula, one of the two surgeries can be done. Either you do fistulotomy or you do fistulectomy. Okay, fistulotomy or fistulectomy. Like you are seeing in this image. You have put a probe in the fistula and you have cut it open. So if you just cut it open, it is ootomy. If you excise the full fistula tract, it is called fistulectomy. Either of them can be done. And nowadays there are new procedures you should know. One is called lift. Ligation of intersphincteric fistula. Then you have waft. Video assisted anal fistula surgery. And then you have a FLAC. Fistula laser assisted closure or fistula laser closure. Okay, so these are the newer treatments. They are usually done for low fistula only, usually. For high fistula or complex fistula or infected fistula, where surgery is not really possible, you do something which will prevent the sphincter from getting injured. You put this thread inside the fistula. This thread is called seton. What thread is used in seton? What is the thread made up of? If there are some Ayurvedic threads, the one that you are seeing, it is called Shar Sutra. But everywhere you won't get Shar Sutra, so you can put nylon also. Nylon thread also is possible. Nylon is your ethylene suture material. Any thread can be used. Basically, you need a thread which will go through the fistula and it will cause inflammation, irritation, fibrosis. And after some days, you cut and remove the thread out. Okay, it's a non-surgical treatment. Fine, but obviously they are preferred for places where you can't do surgery because they have a higher recurrence. So this is not ideal treatment. It looks so easy, just put the thread inside, but it's not ideal. It will have a higher recurrence. Right. What are hemorrhoids? What do I mean by hemorrhoids? Mudvyad. Yes, giving Marathi words. Why don't fistulotomy for high? It will traumatize the sphincters. In high fistula, the tract is crossing the levator ani. It will get traumatized. So it's unsafe. You can do it and repair the muscles, but it's unsafe. What are hemorrhoids? These are dilated superior hemorrhoidal veins. Okay, these are dilated superior hemorrhoidal veins. That's why they are also called as internal hemorrhoids because they originate above the dentate line. How will the person present with hemorrhoids? He will have these bulges. They are dilated veins. He will present with a painless bleeding in stools. What is this described as? Yeah, it is hematochezia, but how is it described? How does the blood come? Is it mixed with the stools? It is not mixed with the stools. When he defecates, few drops of blood fall. It is described as splash in the pen. Okay, it is described as splash in the pen. Few drops of blood fall when he defecates. It is basically the hemorrhoids getting eroded and few drops are falling. Some of you must have gotten it also. It is typically painless. If it becomes very big, they will start coming out also. How do you confirm the diagnosis? IOC. What is done here? How have I seen these hemorrhoids? You do proctoscopy. What is the prerequisite for proctoscopy? What must you do before you do proctoscopy? First, do, per rectal exam. First, do digital rectal exam. Because I can't do proctoscopy in painful anal disorders. If there is any painful anal disorder, like a anal sphincter spasm because of a fissure, I can't put the proctoscope. So first see if the finger goes. If finger is not going, don't put the proctoscope. Okay, then don't put the proctoscope. Lafda ho jayega. Now when I do the proctoscopy, the hemorrhoids have a typical location that you should know. They are usually going to be seen over here at 3 o'clock, 7 o'clock, 11 o'clock. Okay, 3, 7, 11. These are called as primary hemorrhoids. Okay, so I see them on proctoscopy, then I have to decide, do I need to treat it? And that treatment is decided based on the grade. हाँ, पहले तो हमेशा उंगली करते हो ना, हमेशा से, नया क्या है उसमें? So if it is a grade 1 hemorrhoid, it is one which is entirely inside the anus. It has not come out of the anus. And if it is asymptomatic, do nothing. Just treat the constipation. No need to do any surgery. Then someone will ask, if it is grade 1, how did you diagnose it? If it is grade 1 asymptomatic, how will you diagnose it? Nahi, bleed nahi na. It is found by chance. Means you did proctoscopy for some other condition and you found the hemorrhoid. Okay, that is grade 1 asymptomatic. If it is grade 1 symptomatic or grade 2, so it is grade 1 symptomatic, means it is bleeding, or grade 2. Grade 2 means it comes out but goes back by itself. In that case, you will have to do some treatment. Either you do sclerotherapy, some treatment will be done. Either you do sclerotherapy or you can do banding. Okay, this image has been asked before. This device is called Barrett's band ligator. ये image पूछ चुके already. This is a PYQ image. Okay, you can see The bands are attached over here. You hold the pile mass and you fire it. So it will go and sit on the pile mass. What does it do? The band, when you put it on the pile mass, what will happen to the pile mass? It will become strangulated, ischemic, and then it will fall off. Okay, it will cause ischemia of the hemorrhoid. However, if it is grade 3, means it comes out but has to be pushed back, or grade 4, where it remains outside. These are very high grades. Here you don't do minimal invasive treatments. Here you'll have to do proper surgery, open surgery. Either you do stapled procedure, either you do stapled hemorrhoidopexy, or you do open hemorrhoidectomy, also known as stapled hemorrhoidopexy or open hemorrhoidectomy of Milligan-Morgan. Okay, of Milligan-Morgan. If I'm doing stapled procedure, the name of the stapler, this one that you're seeing in the image, no, they look the same, but please understand, this is a very thin device. It's just a tube. Stapler is a very bulky device. This is a circular stapler. Okay, this is a circular stapler. You can see this triangular tip. This is the anvil of the stapler, in which you will hold the pile mass and fire the stapler. Okay, a stapler is a very bulky device. Huh? See how it has gone into the anus. This has to be done under anesthesia, spinal anesthesia. It can't be put just like that with local anesthesia. No, it's a very big device. It will dilate the anus significantly. Okay, it can't be done in local anesthesia. Okay, fine. Ferguson is closed. Close means after the hemorrhoidectomy, you close the mucosa. That is a Ferguson. Always painless hemorrhoids. Unless they are complicated, they will be painless. Unless they are complicated, they are painless. Okay. किसी किसी को easily होगा. किसी किसी को. I wonder why he said that. Does grading have any name? No, at least I don't know the name. Maybe there is. I don't know the name at least. Now come to inguinal hernia. The most common type is the indirect inguinal. What is the defect of the indirect inguinal? It is a deep ring, which is a hole in the fascia transversalis. So overall most common type, indirect. Direct hernias, the defect is Hasselbalch triangle. Who gets direct hernias? Who gets direct hernias? It is seen in elderly, usually elderly people with weak muscle. So indirect hernias can be seen at any age. Indirect, anybody, even a child can get it. But direct hernias, 99% of the times will be seen in senior people with the muscle weakness. Femoral hernias, the site of the defect is the femoral ring. It is below the inguinal ligament. Okay, it is below the inguinal ligament. Right? So these are the three hernias we should know based on the defect. Then some hernias are named based on the content. Like this first image you are seeing, this is called Richter hernia, where just a part of the bowel wall is the content. Okay, just a part of the bowel wall forms the content. That is called Richter hernia. If two loops of bowel form the content, it is called as Maddel hernia. So Maddel is like the opposite of Richter. Two loops of bowel form the content. Okay, that is called Maddel. Amide is if it's an inguinal hernia where the content is appendix. Okay, inguinal hernia where the content is appendix. Later is a hernia where the content is Meckel. Okay, so these are some named hernias you should know. Please understand they are named based on the content, not based on the defect. Now, how does a person present with a hernia? This will be a painless groin swelling. And typically the swelling will be, it will look like this. It is usually painless. Some discomfort may be there, but typically the person will say when he lies down, the swelling reduces, it goes back. And when he stands or he coughs, the swelling bulges. Okay. So the hallmark findings are reducibility, means the swelling reduces when he lies down, and cough impulse. When he coughs, the swelling bulges. If you see these words in the exam, it means it's a hernia. Okay, it means it's a hernia. ये types भी आएंगे. Yes, ये types ही आएंगे. आते हैं. Now, how to know clinically whether it's a direct or an indirect hernia? See, femoral will be in the thigh. Direct or indirect कैसे पता चलेगा? How will you know? Direct hernias usually remain in inguinal canal. Okay, usually they remain inguinal. Indirect hernias enter the scrotum. Right, indirect hernias can enter the scrotum. That's how you know. Now, when you see any inguinal hernia, you have to report it using the EHS. This is also a PYQ. Don't think I am saying this just to teach you extra thing. This is a PYQ. EHS for inguinal. So when you report an inguinal hernia, already you're laughing. पहले से, I wonder how many more fingering you're gonna do. So when you report a hernia, first thing you will see, is it a primary hernia? Then you'll write the letter P. Or is it a recurrent hernia? You write the letter R. You look at the defect. Is it a direct defect? You write the letter M. Indirect L, L for lateral. Femoral F. And then you measure the size of the defect. Now there will be some defect here. Sorry. Obviously, you can't measure it with a tape. So you put your finger inside it and see how many fingers are going. One finger breadth, two finger breadths, three or more. Okay, three or more you count as three only. Don't put more than three fingers. And one finger breadth is approximately 1.5 centimeters. Approximately. So when I'm reporting a primary direct hernia, 3 centimeter defect, P for primary, direct will be M, not D. 3 centimeter defect will allow two fingers. So it will be denoted as PM2, not PM3. Fine, that's how you denote. So that is your EHS. Fine. This is how you're going to report the hernia. This has been asked once. European Hernia Society classification. Where I'm not laughing here. What did I do? Now come to treatment. All hernias require treatment. At least inguinal hernias require treatment. So you can either treat it by open repair or by laparoscopic repair. In open repair, there are three surgeries you should know. One is herniotomy. It simply means dissecting and excising the sac. You're going to dissect and excise the sac. That is called herniotomy. Where do you do this? Where is it used? It is used in congenital hernias. Congenital inguinal hernia. Okay, or even congenital hydrocele. So congenital inguinal hernia and congenital hydrocele. This is where you just excise the sac. You don't do any mesh in congenital hernias. Okay, children may you don't put mesh. Mesh is put only in adults. Right? Second way to repair a hernia is herniorrhaphy, where you repair the posterior wall with local tissue in the vicinity. Like you can do Bassini repair, Stoldice's double breasting repair, or Desarda repair, which is an Indian repair. Don't need to know too many details of this, at least know the names. These are types of herniorrhaphies. In herniorrhaphy, you have not put any mesh. There is no mesh. Which is why, since you are pushing and pulling tissue, these repairs don't work in the long run. They are under tension. Okay, they are under tension, like how you are right now. Exam is close, you are under tension. In mission classes, you are very relaxed. Now you are under tension. So you are a herniorrhaphy. Okay, you have no mesh, no bridge anymore. But earlier on, you are hernioplasty, tension-free repair, in which you put a mesh. It is tension-free. Obviously, you prefer to be tension-free, na? So hernioplasty is the preferred repair. Correct, it is a preferred repair. Now, in hernioplasty, you put the mesh. Here, the mesh that you are seeing, this one, this is a proline mesh or a polypropylene mesh. Okay, this is a proline or a polypropylene mesh, right? It is placed on top of the fascia transversalis, on top of the defects. So this is going to be an onlay mesh. Okay, onlay means defect ke upar. Like you will ask me, sir, onlay, inlay, sublay, it's all over here. Okay, you can see it over here. That this is for ventral hernia, this is not inguinal, but the logic is the same. That if the hole is over here and the mesh is on top of the defect, this is onlay repair. If the hole is over here and the mesh is just inside the defect, it is called inlay. Here the defect is over here and the mesh has been pushed below the defect. This is a pre-peritoneal sublay. Okay, this is pre-peritoneal. And the fourth is the mesh is placed intraperitoneally, which is called IPOM. So these are the different places where you can put the mesh. I always tell simple rule. If I see open mesh repair, you can simply say only. Okay, it's not 100% accurate, but in the exam, you can make out. You can make out now this is open repair. You can see there is an incision here or artery beatery is being used. Na? You can make out it's open repair. Na? Open is only. This also you can make out na, this is open repair. Pura khol diya hai na sab. So this is gonna be only. Okay, pre-peritoneal, they will not show image. Pre-peritoneal is very hard to make out from image. It's difficult. Don't mark pre-peritoneal. Okay. Now, when we do only repair like a Liechtenstein's repair, since I am putting the mesh on top, some problems can happen. The most common complication is going to be chronic pain. Mesh causes a lot of inflammation. Person gets a lot of pain post-operatively and it persists for more than 3 months. The most common nerve injured in open repair, many times you must have studied, it is ilioinguinal. Okay, it is ilioinguinal. Remember, in open appendectomy, okay, in open appendectomy, it was iliohypogastric. That nerve is higher up. Here it is ilioinguinal. Don't do ulta. Ilioinguinal only will come in inguinal hernia. Name is telling you. Inguinal. Hernia is what? Inguinal. So inguinal hernia, ilioinguinal nerve. Fine. But if I want lesser post-operative pain, I do laparoscopic repair. In laparoscopic repair, where is the mesh placed? In TAPP, TEP. Where do I put the mesh here? TAPP, TEP repair. Here the mesh is sublay or pre-peritoneal. Means over here in this plane. Peritoneum के ऊपर. It is placed over here. Defect के नीचे, but peritoneum के ऊपर. Pre-peritoneal. So here also the mesh uses proline only. So it is a sublay repair. Some landmarks you should know for your MCQs. Which is the most common mesh? Proline mesh. Inguinal hernia is proline. Now, two landmarks you should know. One is called triangle of doom. That is a medial triangle. Like you can look at this image. This is the midline. Pubic symphysis is over here. This is medial. And then you are going here laterally. Okay, this is medial to lateral. One triangle you can see is this. This is called triangle of doom. It is bounded medially by vas deferens, laterally by testicular vessels, and it contains the iliac vessels. Okay. So medial limit, vas deferens, lateral limit, testicular vessels, and the content is external iliac vessels. If the external iliac gets injured, it will spell doom for the patient. That is why it is called as triangle of doom. Most common hernia overall is indirect inguinal. Overall, male, female, indirect inguinal. Inguinal ही होता सब में. Others are quite rare. If I ask you second most common hernia, then which is the second most common hernia after inguinal? No. Direct, indirect. If I count as one, उसके बाद. No, not femoral. Femoral you will never see in your life. If you see one, the full hospital surgeons come and see, oh, femoral hernia, femoral hernia. No. It is incisional hernia. Okay, second most common is incisional. Then the others come. Diaphragmatic hernia, they are rare. Femoral to hospital में news हो जाएगी. Oh, you are operating femoral hernia. I want to see. I have seen only 2 in my life. Only 2. Both were in my residency. One was an intraoperative diagnosis. One was pre-op. Okay. एक तो we thought it was inguinal, turned out to be femoral. ऐसा था. Intraoperatively we realized, oh, femoral hernia. One was proper femoral. Okay. Anyways, so this triangle here, this medial triangle is triangle of doom. It is called doom because iliac arteries can get injured. Lateral to it is this triangle. This is called triangle of pain. This is bounded medially by the testicular vessels. And laterally by the iliopubic tract. Iliopubic tract is nothing but your inguinal ligament. This structure here. So this is testicular vessels here, iliopubic tract here. This is your triangle of pain. It's called triangle of pain because it contains nerves which run in that triangle. Okay, it contains nerves which get injured in that triangle, like the lateral cutaneous nerve of thigh, anterior cutaneous nerve of thigh, femoral nerve. These are all big nerves. And femoral branch of genitofemoral. Okay, femoral branch of genitofemoral. These nerves run in that triangle. Which of these nerves normally gets injured? It is the lateral cutaneous nerve of thigh. Okay, so open repair, ilioinguinal nerve. Laparoscopic repair, lateral cutaneous nerve, which runs in this triangle over here. It will get injured. So when I am doing dissection, these are the areas where I have to be careful. Okay. Okay. So these are some landmarks you should know. You will get question from this only. So when I am doing inguinal hernia repair, open repair only, laparoscopic repair is sublay. Sometimes for some other hernias like ventral hernias, I do IPOM repair. This IPOM is only done for ventral hernias. You understand ventral hernia? What does it mean? Ventral means what? Ventral कौन सी hernia होती है? No, don't say it. What is a ventral hernia? Yeah, like incisional, umbilical, paraumbilical. They are called ventral hernias. So for these hernias, I do a IPOM repair. IPOM is intraperitoneal mesh. What mesh do I put in IPOM repair? Do I put proline mesh? See, I can't put proline mesh. You see, this is IPOM image. If they show a laparoscopic image, obviously this is not open surgery. This is laparoscopy. You can see there is a trocar. This is an instrument which has gone inside, long instrument. You can see some intestine over here, omentum over here. So this is a laparoscopic repair. If you see laparoscopic repair, mark IPOM. This mesh that I'm putting here, this IPOM mesh, it's not your normal mesh. Okay, the mesh that is used in IPOM, it is a composite or a double mesh. Okay, it is called a composite mesh or a dual mesh. It has 2 different layers. The layer on the inferior surface, this layer, should be made up of Teflon or collagen so that intestine does not go and stick to it. The other layer has to be polypropylene. So it has two components. That is why it is called dual mesh. Okay, आया समझ में? So in IPOM repair, you can't use proline alone. It has to be proline which is coated with some other non-adhering material. And it has to be put correctly. You can't do ulta. You can't put proline niche. If proline faces down, it's a disaster. Then the intestines will go and get stuck to it. Fine. Answer this question. So this is a PYQ. 6 months after abdominal hysterectomy, patient got this swelling at the scar site, which was initially reducible. Now it is irreducible and tender. What has happened here? What is the swelling? Which was reducible before. This is a incisional hernia. Post-operative incisional hernia. You can see it was reducible. The fact that it has become irreducible means now it has become complicated. Maybe obstructed, maybe strangulated. Now it has gotten complicated. Obviously, you'll have to do emergency surgery. So this is a bowel strangulation. If they ask you next step, answer will be surgery. Okay? This is an emergency situation. Why doesn't direct hernia? No, because direct hernia has the covering of fascia transversalis. So it cannot stretch so far inside. Indirect hernia is going through the fascia transversalis. Okay. Again, lap is sublay or IPOM. IPOM is always lap. Sublay can be either. That's why don't go for sublay. I mean, from an image, you can't make out it is sublay. It's very difficult. No, 5-minute break. Why you want? Take lunch break, na? After we finish hepatobiliary. After hepatobiliary. No, no. Direct and indirect, the repair is the same. It is mesh repair. Direct or indirect, it doesn't matter. Okay, fine. Now let's go to hepatobiliary. Easy topic, not that hard. And especially if you have done it before. First is hydrated cyst. Few points you should know about it. The parasite is Echinococcus granulosus, also known as dog tapeworm. Okay, that is a parasite, Echinococcus or dog tapeworm. The definitive host is the dog intestine. Intermediate host who gets the hydrated cyst is the sheep. Man is the accidental host. If man gets hydrated, it will be the dead end of the life cycle. Life cycle will get over. So the parasite is not happy to come into you. Okay. Don't feel, oh no. The parasite will feel, oh no, I have entered you. It's his misfortune. Okay. And after liver, the next common site is the lung. Second most common. So liver followed by lung. Oh no, yes. Parasite will say, oh no, more than you. Because where will he go now? Person will present typically, he will present with a right upper quadrant pain with a hepatomegaly. There will be palpable enlargement. Hepatomegaly will be there. Whenever you get any scenario of hepatobiliary disease, first step will always be liver function test. Here it will be normal and USG abdomen. Okay, I hope all our thumb rules are kind of coming back in your memory. Right? You are getting the thumb rules. Upper GI, lower GI, acute abdomen, hepatobiliary. Now, USG abdomen most of the times will diagnose it. Like you can see here. It's usually diagnostic. You will see floating membrane or water lily appearance. Okay, if you have doubt, you can do CT. This is CT image, multiseptate, honeycombing. So hydrated is a very classical CT or a USG diagnosis. Okay, it's a very classical USG or a CT diagnosis. So you have to classify it not for the diagnosis. The name of the classification is Garbi. What is the purpose of the classification? Why do I need this classification? Garbi plays Garba. It is to look at the activity. Okay, it is not for diagnostic purposes. It is for activity. kind of like severity, you can say like that. Now, if it's an imaging diagnosis, FNAC and biopsy are not required, they are contraindicated. I don't want any of this to spill, so don't do FNAC or biopsy. So the diagnosis is imaging. First do ultrasound, if required do CT. Now how to treat? The treatment depends on the Garbi classification, on the activity. If the cyst is inactive, asymptomatic, basically if it is calcified, that is Garbi class 5, then just do surveillance, nothing needs to be done. Calcified cyst, surveillance. But if it is active, symptomatic, first give albendazole, okay, for 3 to 4 weeks. And after the albendazole course is over, the treatment of choice is pair procedure. Okay, this is not a surgery, it's a minimal invasive procedure. This is done under image guidance, either USG or CT guidance. You puncture the cyst with a needle, aspirate the contents, then put a scolicidal agent like a hypertonic saline, and you re-aspirate it. So puncture, aspirate, irrigate, re-aspirate. What does this mimic, this treatment? What does this mimic? Puncture, aspirate, inject, re-aspirate. Does it mimic some treatment we have done somewhere else? Stone. No, no, no. IND. There is no incision. Pheko mat. Stone. Albendazole is for 3 to 4 weeks, not only once. Lavage. No, no, no. Urethral rupture. उसमें ऐसे किया था. Puncture, aspirate, puncture, aspirate. No, no, no. It is like sclerotherapy. क्या यार कुछ भी फेंकते हो ना आप लोग? It is similar to sclerotherapy. Like you did sclerotherapy for hemorrhoids, you will do it for varicose veins, same like that. Okay, it is like sclerotherapy. Similar. Only here you are injecting a scolicidal agent, not a sclerosant. That's the only difference. Fine. So easy to do pair. If pair is contraindicated, where can you not do pair? If the cyst is inaccessible, it's very deep. If it is an inaccessible cyst, very deep or near important structures, or it is multiseptate, honeycombed, or if there is cystobiliary communication. Okay. I hope whatever you're writing in chat is out of memory and not because you have the notes open. I hope so. If it is out of memory, then you are happy. Okay. Then you are happy. If any of these contraindications is there, then you will have to excise the cyst. If present, do a pericystectomy. That is a surgical removal. Fine. Very good. Notes open. Okay. So you are revising it. If your notes are closed, then this is a mental revision of your memory. Very good. So this is going to be the treatment of hydrated cyst of liver, IMP topic. I predict one question from hydrated cyst will come in your exam. Either surgical or microbiological. Okay. You can write over your prediction. Hydrated cyst. It's not, I'm not giving you a leak of a A&D question. Huh? Don't say matlab ye A&D mein A&D is over, finished. Need to remember Garbi from radiology side maybe, not from surgical side. In surgery, no, but maybe in radiology, if it has been told to remember, then fine. If it's calcified, then nothing to do. You can leave it. Okay. Now come to coledochal cyst. It is a congenital disease. It's a congenital biliary dilation. Who gets coledochal cyst? Typically. Who gets coledochal cyst? Typically. It is seen in young Asian girls. Typically, it will be seen in young Asian. आप Asian में आते हो, even though you may be international, you are still Asian only. You may have studied internationally, right? Okay. So it is seen in young Asian girls. Now, the cyst can occur at different sites, which is given by Todani. So Todani said different parts can be dilated, and based on that, he gave the different types of colorectal cyst. Like in type 1, it is a fusiform CBD dilation. In type 2, it is a diverticular CBD dilation. In type 3, it is intraduodenal CBD dilation, also called as choledococele. So the first three types are local types. Type 1, fusiform. Type 2, lateral diverticular. Type 3, intraduodenal. Which of these mimics an accessory gallbladder? Which of these cysts, when you do imaging, it will look like person has two gallbladders? It is this type 2. He has one gallbladder here. This looks like a second gallbladder. That is type 2. अभी तक पूछा नहीं है ये question. So these are the three local types. Then you have type 4, type 5. In 4A, it will affect intrahepatic and extrahepatic bile ducts. It is all diffusely dilated. Intrahepatic plus extrahepatic. In 4B, it is only extrahepatic. In type 5, it is only intrahepatic. That is also called as Caroli disease. So these are the 5 types. Of course, the most common is type 1. They all will behave differently, but at the end of the day, the treatment is going to be surgery for most of them. So how will it present? Young Asian girl will present with jaundice and lump. So someone who is a 5-6-year-old girl who gets jaundice, she gets a lump in abdomen. You will wonder, why is there a lump? Why did it occur? Why is she having jaundice? This jaundice is obstructive jaundice. So you will investigate. What will you do first? First step. First do LFT USG. Okay, thumb rule of hepatobiliary. Then confirm it is a choledocal cyst by doing MRCP. Okay, MRI, MRCP. Fine. So you will confirm the type of the cyst based on MRCP. That is the investigation of choice. Now you have to remove the cysts most of the times because this is a pre-malignant condition. There is increased risk of cancer, cholangiocarcinoma. So if it is type 1, which is only CBD dilation like this, you can excise it. Similarly, for type 2, you can excise it. So type 1 and type 2, treatment is very simple. You will do excision and you have to do some kind of joining. Maybe join it to the jejunum. After excision, you can join it to the jejunum. That is called as hepatic duct jejunal anastomosis, hepaticojejunostomy. If it is type 4B, this also you can try to excise and do the anastomosis, means join it to the jejunum. So even for type 4, that is 4B, you can do excision plus reconstruction. It is possible. For 4A and 5, it's not possible because in 4A, it is involving the liver also. So in 4A and 5, the liver will also have to be removed. So there your reconstruction is not some joining, you will have to do a liver transplant. So for 4A and 5, you will have to do a hepatectomy plus liver transplant. Short form I'm writing, LTX means liver transplant. Type 5 is same as 4A. Okay, but the most interesting that they will ask you is type 3. That is intraduodenal this time. Since it's intraduodenal, it's very hard to remove. So what I do is I put an endoscope and I cut the cyst and the sphincter from the duodenal side. So I do ERCP and I cut the cyst wall. I don't excise it. So for type 3, the treatment is ERCP with sphincterotomy and you cut the cyst. Okay, this is unique, which is why this is the one they are likely to ask you in the exam. No, diagnosis will be on MRCP only, but MRCP will tell you it's a type 3. It will not be the treatment. Treatment will be after MRCP, you do ERCP with sphincterotomy. Fine. Is it common in India? Yes, it is common. Asia to India aa gaya na. It's common in India. I've seen 3 patients of colorectal cysts. They were all young girls. They all came from pediatrician. The pediatrician sent the patients to the surgeon. I've seen 3 colorectal cysts. Not in my residency, after my residency, in my practice. They were all type 1 only. None of them were type 2, type 3. 4, 5 तो नहीं पूछते. They'll be diagnosed much earlier. Okay, so what you are seeing here, this is the distal part. So this is type 3. Okay, fine. Now come to cholecystectomy landmarks that you should know. Okay, landmarks of cholecystectomy. That when you are doing a lap chole, you need to know some things that you see. Like normally when you go inside, this is what you see. This is the liver, and I've pushed up the gallbladder. And my area of interest is this area. Okay, that area is called as hepatocystic triangle. Okay, old name Kalos or Callet, not used anymore. I mean, it is something different. The triangle that we should know is hepatocystic triangle. It is this big triangle, the bigger one. This is the hepatocystic triangle, this one. You can see in this image also. It's a very nice diagrammatic representation. So this big triangle, the hepatocystic triangle, it is medially bounded by common hepatic duct, laterally by the cystic duct and the gallbladder, and inferiorly or superiorly by the inferior border of liver. This triangle, people call it Callets, but it is not Callet. And this contains the cystic artery. Okay, this contains the cystic artery. If I want to call Callet's triangle, it is a smaller triangle. Okay, the Callet's triangle, it is the smaller one. People use it interchangeably, but it is not actually the same. Okay, the smaller triangle is the Callet's triangle, where the cystic artery forms the upper limit, not the inferior limit of the liver. Okay, nonetheless, so these are the 2 names you should know. Nonetheless, when I am seeing this area, this is the hepatocystic triangle. Now the problem is I can't make out where the triangle is, where the CBD is. It's all looking the same. It's all covered with fat. So what I do is, when I start dissecting, I first look at this sulcus over here, Ruvier sulcus, and I make a horizontal line, imaginary, through the sulcus. That is called as R4U line. And you are going to dissect above the R4U line. Okay, so you always dissect above the R4U line. R is your Ruvier sulcus. 4 is segment 4B of the liver. That is where the gallbladder lies. And U is umbilical fissure. You can't see the umbilical fissure in the image. Okay. Right. So these are the structures you see. You make a horizontal line, dissect above. Don't dissect below. Why do you not dissect below? Don't go below. Don't go below. Why? What will happen? You may injure CBD. Risk of CBD injury. So you don't want it to happen. So you don't go below the R4U line. This is a landmark surgeons use in surgery. So you stay above the line. Somewhere here will be the R4U line. Uske नीचे नहीं जाना. Okay, stay above it. Now once you dissected it, you will see this. Segment 4B is a segment of the liver where the gallbladder lies. Once you have dissected it, it looks like this. This appearance where you are seeing 2 tubular structures. The smaller inner one, this is the cystic artery. The bigger one, which is going from out, is the cystic duct. When you're seeing these 2 tubes enter the gallbladder, that is called as critical view of safety. Okay, that is called as critical view of safety. This view is a must. It's a prerequisite. Only when this view is visualized, now you can proceed with cholecystectomy. If you don't get this view, you see 3-4 ducts entering, and then you start tying them, cutting them, then what can happen? If I don't get the critical view, then what can happen? Bleeding. Anything else? If I don't follow critical view of safety, what is the implication? There can be injury to other structures. Most important, there can be bile duct injury. Okay, which we will study soon. So the main implication of not getting this view is there is risk of bile duct injury. That is the most important. Fine. Okay, answer this. So patient came with pain in right hypochondrium. AST, ALT are normal. What is normal AST, ALT? Bilirubin is 6 mg/%. Alkaline phosphatase is little elevated. So normal AST, ALT should be less than 35 to 40. Okay, less than 35 to 40. So here it is normal. Bilirubin should be 1 mg/%. Here it is 6. So he's having hyperbilirubinemia. Person is having some hepatic disease. What will be the next step? It will be USG. So I told you, first step will always be USG LFT. Right? So whenever there is a hepatobiliary disease, thumb rule I am writing for you is going to be LFT and USG. Then you decide what you're going to do next. When to do MRCP. ALP there was borderline. Up to 180 is normal. If the LFT is deranged, like alkaline phosphatase is raised, bilirubin is raised, means you are thinking there is a biliary obstruction. Okay, you are thinking there is a biliary obstruction, obstructive jaundice, or CVD is dilated. Maybe there is a stone, or maybe there is a tumor or a stricture. I don't know, but there is some problem in the bile duct. I will do MRCP. Okay, I will do MRCP. Choledochal cyst. Ultrasound will show dilated bile duct. MRCP. For some places, like CVD stones or bile leak, if it is seen on earlier imagings, I will do ERCP. Okay, remember ERCP is to treat. It is not to diagnose. ERCP is to treat. So first confirm by doing USG MRCP. To treat, you will do ERCP. Okay, so if in this question, just saying, these were the findings, then I said, I'm just going one step ahead. I said USG showed dilated CVD. Dilated CVD with gallstones. Then what will you say? There are gallstones and CVD is dilated. Then you will do MRCP. Okay. If MRCP showed CVD stones, you did MRCP, CVD stones were seen, then you will do ERCP. Understood? The pathway of investigations. This is the pathway. Some imaging has to show CVD stone only then. Okay. No, ERCP is not a diagnostic test. It is a therapeutic test. Earlier it was diagnostic. Fine. So first confirm what the problem is by doing MRCP. If it is something you can treat, then do ERCP. USG में stones नहीं आते हैं ना. USG में CVD stone नहीं आते हैं, gall stone आते हैं. You won't see CVD stones, not very easy. So it's unlikely that you will see CVD stones. Hemorrhoid also, but how you will suspect hemorrhoid, na? Then you will do MRCP, correct? No, that shadowing is seen in gallstones, not CVD stones. Okay, CVD stones are best seen on MRCP and removed with ERCP. Okay, I can't make it simpler than this. Huh? Now you can't mess up these questions, right? Now come to two more topics are left in hepatobiliary. Let's do that. Then I'll give you a lunch. One is bile duct injury, quite easy. So what is a acute bile duct injury? Where you are going to see cutting of some bile duct. Okay. So normally when I'm doing cholecystectomy, it is this area. That is the area of interest. If I cut some duct here, which I didn't recognize, person will start leaking bile. So in acute bile duct injury, the person gets bile leak. Right, he gets a bile leak. So by mistake, some duct was cut, which we didn't see. When will this manifest the leak? It will usually manifest on post-op day 1 or 2. Where the person starts getting, he's still in the hospital, he had a lap chole. Now he gets pain in right upper quadrant. He may also get fever. Why is he getting pain and fever? What is the cause of pain and fever? Yeah, wherever the bile is leaking over here, it will start forming a collection. That is called bilioma. That will cause pain, fever. It's like peritonitis. So you start getting pain and fever. The first thing that you will do is you want to confirm there is a leak happening. So you are going to do a USG abdomen. Of course, with LFT. USG will show collection. What will you do with the collection? USG shows collection. What will you do? Drain the collection. Either you put a pigtail catheter or you can do surgery, but you have to drain the collection. After the collection is drained, patient becomes okay. Now you want to localize the site where it is leaking from. For that, you can do MRCP or you can do ERCP. Okay, either of them are okay. And then you will know where it is leaking from. This is given by Strasberg. Usually the leak is from the cystic duct or one of the smaller ducts. Okay, usually. So the most common leak is cystic leak or some small duct leak. Chota mota duct is leaking. For that, I have done the imaging. If it is a cystic duct leak, then you will do ERCP and stenting. This is a PYQ. Type A leak, the treatment is ERCP and stenting. You just put a stent inside over here. The bile will flow through the stent, the leak will stop. These are low volume leaks. They are easier to manage. The other leaks, that is Strasberg B, Strasberg C, or Strasberg D. In Strasberg B, the right posterior duct is blocked. There is no leak in type B. In type C, the right posterior duct is cut. Okay, B for blocked, C for cut. And in type D, the CHD, common hepatic duct, is laterally cut. Okay, the common hepatic duct is laterally cut. Lateral injury. That is Strasberg D. For these types, ERCP stenting will not work. For these types, what you're going to do is, now these are difficult to manage. Here you will wait. After you've put the pigtail, wait for 2 to 3 months. And what will happen? It will form a stricture. And then you do a delayed repair. Okay, you do a delayed repair. So the problem is BCD leaks are difficult to manage. So here ERCP will not work because these are high volume leaks. So here you wait it out. Keep the pigtail, let him leak. After some time, the leak will slow down, the inflammation will reduce, then you do reconstruct. Okay. So this is, I have put it in a very simple way, management of acute bile duct injury. You will get the answer from this. In type B, there is no leak. Okay, there is no leak in type B. If HIDA is given, should we mark that? HIDA should not be given. HIDA is not very commonly done. In exam, either they will mention leak kahan se ho rahi hai or they will ask you like this question. See this. Before you ask the question, the question has come here. तुम्हारे क्वेश्चन का ही रेप्लिका है ये in exam FMG June 2022. So MRCP is showing leak from the cystic duct stump. What will you do? You will do ERCP stenting. Fine. If patient unstable, why should he be unstable? If he is unstable, laparotomy and drain the collection. If he is unstable, laparotomy and drain the collection. That means he is getting peritonitis. Yeah, INI 25 had 2 questions on bile leak. In fact, students didn't even remember that there were 2 questions. So ऐसे question आते हैं exam में. And they were quite easy. One question was exactly like this. It was 90% the same. Exactly like this. जिसमें students mark exploratory laparotomy because they didn't understand the question. B block है तो B will present only late. It will not present early, na? There is no leak. So in type B, there is no early presentation. Right? Now come to acute pancreatitis. Easy topic. Difference between acute and chronic. Acute pancreatitis is largely reversible. So whatever inflammation occurs, most of it will revert to normal. Most common cause of acute pancreatitis, it is biliary stones. So gallbladder stone went into the bile duct, obstructed the pancreatic duct, that is biliary. Most common cause of chronic pancreatitis is alcohol. And remember, chronic pancreatitis is irreversible. Whatever damage has happened will remain forever, right? That is chronic. Now, how does person present with acute pancreatitis? I'm talking about acute. He will present with epigastric pain, radiating to back, nausea, vomiting. Okay, epigastric pain, radiating to back. Clinically, you can easily make out. He will have tenderness. There will be history of binge drinking or history of gallstones. How will you confirm the diagnosis? Investigation. You will do serum lipase. It is preferable to serum amylase. Lipase is more sensitive, more specific. Only problem is it will rise after 12 hours. Okay, it peaks at 24 hours. So if it is done very early, it may be falsely normal. Then the imaging of choice, of course, is going to be CCT abdomen. And it will be done normally after 2 to 3 days of symptoms. 2 to 3 days of symptoms ke baad. If you do it earlier, you may underestimate the necrosis. So it is done after 2-3 days. Otherwise, the necrosis may be underestimated. There are some clinical signs you should know. This paramumbilical bruising, Cullen sign, flank bruising, Gray Turner sign. What do these signs imply? What is the implication of these findings? What is the implication? It means there is hemorrhage around the pancreas. So these are markers of hemorrhagic pancreatitis. So there was bleeding around the pancreas. The blood has tracked from around the pancreas all the way till the flank or to the umbilicus. Fox's sign is inguinal, bruising in the inguinal area or the inguinal ligament. That is Fox's sign. But these are very rare signs and they are not specific for pancreatitis. Here they are all acute. Whatever I'm talking about is acute only, but they are quite rare and they are not specific. Any bleeding in around the pancreas will cause this. Any bleeding, not necessarily pancreatitis. Fine. Now, if you don't treat pancreatitis, there are some complications that can happen. Like if he had an interstitial or edematous pancreatitis, sometimes he gets fluid leak, which can cause a fluid collection. It is called as acute peripancreatic fluid collection. If these fluid collections don't go away and they persist for more than 4 weeks, it is called as pseudocyst. Okay, so pseudocyst is nothing but a fluid collection. What does it contain? This fluid. What does a cyst contain? It contains pancreatic enzymes. It is amylase rich. So amylase-rich fluid collections, if it persists for more than 4 weeks, you will call it pseudocyst. Fine. However, if there is necrosis of pancreas and that leaks out, you get a necrotic collection. So fluid collection replaced with necrosis, it is necrotic collection. And if that persists for more than 4 weeks, it is called as walled off necrosis. Okay, it is called as walled off necrosis. So these are all types of local complications. Modified Atlanta, local complications of acute pancreatitis. If any of these complication is there, it means person is having moderate or severe acute pancreatitis. Okay, spider nevi are seen in cirrhosis. They are not seen in pancreatitis. Okay, don't mix them. That is seen in cirrhosis because of hyperestrogenic states. Fine. So these are some of the local complications. Why does person die in acute pancreatitis? Death due to sepsis. Due to, why is he getting sepsis? Why organ failure? Why ARDS? Why infection? Why? Peritonitis, necrosis, shock, bleed. I am in shock. Thank you. See, आखिर answer Dr. House ही देगा. It is because of infected necrosum. That causes sepsis. The necrosis got infected and the person became septic. Fine. That is the cause of death. Most of the times. आई बात समझ में? Dr. House savior, yes. इज्जत बचा ली. Now, if I want to know how severe the pancreatitis is, one way is to do CT. You get a CT severity score. That is one way. CT severity index. Other way is to look at the organ and the local complications. That is given by modified Atlanta classification. So, when will I say it is mild, when is moderate, when is severe? Mild means there should be no complications. Moderate means there should be local complications like fluid collection, necrosis, or so either there are local complications or he is having transient organ failure. Okay, he is having transient organ failure. Means it got okay within 2 days of treatment. Severe means he should have a persistent organ failure. Okay, it should persist for more than 48 hours. So if I want to label someone as mild, moderate, severe, either I look at his CT or I look at his organ failure function. Fine. The problem with these scores is you have to wait for 2 to 3 days. If I want to get the severity when he is come, like immediately at bedside, I can use this score. This is called BISAP score. It's a very good score to know about. BISAP score. The components are also given by the mnemonic BISAP. At least know the components. B for BUN, I is impaired GCS, S is SIRS, A is age more than 60, P is presence of pleural effusion. If 3 or more things are deranged, it is a severe pancreatitis. Fine. The advantage of this score is it can be done bedside and it can be done repeatedly, right? So that is BISAP score. So these 2-3 scores you should know. And the last point you should know is lipase amylase does not correlate with severity. So if there are 2 patients, one is having lipase 1000, other is having lipase 3000. I can't say the one with 3000 lipase is more severe. It's not like that. Okay. For these things, for severity, modified Atlanta, BISAP score, and CT severity. Fine. Last question, answer this. Then you can have your lunch break. Epigastric pain leading to back after alcohol binge, asked last year. Answer will be serum amylase. Okay, someone was asking X-ray. Those signs that are there, colon cut off, sentinel loop, They are old signs. We don't see them anymore. Colon cutoff sign, sentinel loop sign, gasless abdomen. They are some signs, but they are not specific. Okay, they are not specific. If serum lipase is there, answer will be lipase. पूछते हैं एक्सरे पर it's not useful. ठीक है? So please go have your lunch. It is 1:42 now. Till when will you be back? 2:25. Okay. 2:25 तक be back. Okay. Go have your lunch, then we'll continue with part 2. What? Okay, 2:15. Nice. अभी जो लोग चले गए उनको तुम बुलाना फिर. ठीक है. ठीक है, 2:15 तक आ जाओ. बट जो चले गए ना उनको तुम बोलना कि सर ने 2:15 बोला. It should not be that they come back and say, sir, you said 2:25. Then you see. अभी क्या दिख रहा है आपको स्क्रीन पे? क्या लिखा हुआ है टाइम? आई हैव रिटन द टाइम. कमाल है. ये गलत है. कैसे आप लोग इतनी आपत्तिजनक इल्जाम लगाते हैं मेरे पे? शी 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 शी। So much of accusations. Imagine. This is really Kalyug where we are living. है ना? तौबा तौबा तौबा। क्या करूं मैं? What more do I need to do to prove my loyalty, punctuality? ओके चलो काम शुरू करते हैं। फिर आप बोलोगे 2:15, 2:30, 2:45, 4। मेरी उम्मीद तो यही है कि आप लोग का टाइम से खत्म हो जाए, ताकि आपको एटलीस्ट, व्हाट अ कंपैरिजन इज दिस, माय गॉड। कंपैरिजन सीधा मुंह पे मेरे। एटलीस्ट बेटर देन। Every class, every break has been as per schedule, FYI. And today also they have given me time till 6. I will finish by 6. Then you can आराम से take a break and come for Dharma. 6 बजे तक हो जाएगा अपना, होपफुली। कोशिश करूंगा उससे जल्दी भी हो। Okay, anyways, let's start. It's 2:20. Okay, so let's start. Now we are left with general surgery, means trauma, uro, breast endocrine, and general. That's what is left. So let's do that. And some IMP topics are these that you should know. In FMG exam nowadays, they are asking a lot of chest trauma. This is one of the popular topics that you should watch out for. Right. Now let's come to trauma first. And the first thing that we do in trauma is primary survey. That is the ABCD of trauma. Okay, that is the ABCD of trauma, also known as primary survey, where you need to identify life-threatening injuries in this order. Okay. In this order, where the first component that you will check is A for airway. You also check and fix the cervical spine. So it is airway plus cervical spine stabilization. To stabilize the cervical spine, you should ideally apply a hard collar if it is available. Okay, you ideally apply a hard collar. What you missed till now was these people dissing me. That's what you missed, Meerab. They were passing comments about my lack of punctuality and comparing me with other teachers on my face. That's what you missed. This is where we are. I can't help it. सच में वही है, वरना मैंने खाली ABCD ही लिखा है अभी तक। Anyways, so when you are starting, the first thing you check is A for airway, and you stabilize the cervical spine with a hard collar. Now, what will tell you there is a problem with airway? Markers of airway obstruction. One is patient is unable to speak a sentence. Okay, he is unable to speak a sentence, or he is having stridor. There is stridor, or he's unconscious. Obviously, if he's unconscious, how is he going to speak? So any unconscious patient, you assume his airway is obstructed. If airway is obstructed, then what to do? You do some temporary things first, like try to open his mouth, remove any obstruction. Okay, open his mouth, remove any foreign body, or you can do chin lift that you can see in the image. Chin lift, head tilt, or you can give a jaw thrust. These are obviously some temporary maneuvers. You can see here, this is chin lift. The next one is the jaw thrust. So you can try these things. You can also put a oropharyngeal airway device, but these will only last for some time. If you can't solve the airway problem, you can see in the image, in head tilt, you are tilting the head. It is less aggressive. In a jaw thrust, you are pulling the jaw up. It is a far more aggressive maneuver. Okay, jaw thrust is, every patient will not cooperate for it. Right. But at the end of the day, if you can't solve the airway problem, you have to get a secure airway, that is going to be endotracheal intubation. So if you can't treat this problem, you have to do endotracheal intubation. And if you can't intubate, like he's having oromaxillofacial injury, so you are unable to intubate, in that case, you will have to get a front of neck access. Okay, you have to get a front of neck access, which can be in two ways. Either you do something temporary or you get something secure. Okay, so temporary, what can you do? Needle cricothyrotomy. It is temporary, it will work, it will stay in place for maybe 10-15 minutes. It will not be there for, days and all. It will work for short time. You can see in this is needle cricothyrotomy. This image was asked in NEET PG. They had asked what is true about this. Answer was it is a temporary airway. It will work for some time. Eventually, you'll have to get a secure airway. That is going to be tracheostomy. Right. So by doing this, you will get some airway relief. Remember, airway is the first thing you will check because airway will kill you the fastest. So airway obstruction takes the least time to death. Fine. Okay. Now then the second component is going to be B for breathing. What are you checking in B for breathing? Class started 2 minutes ago. 2 minutes. This is the first slide. I've only written these 2-3 lines. What are you looking for in B for breathing? You are looking for conditions like tension pneumothorax. Okay, you are looking for conditions like tension pneumothorax or cardiac tamponade. Basically, you're looking for chest wall movements. Then you go for C for circulation. You take the person's vitals, take 2 large IV lines, and you give him IV fluid bolus. And you should know which IV fluid bolus you will give. Which one? You will give 1 liter warm crystalloids. Okay, that IV fluid bolus you will give 1 liter of warm crystalloids, like a normal saline. Basically, if he's having tachycardia, hypotension, he may have had volume loss. That's why you're giving this. Further, you should also give tranexamic acid 1 gram over 10 minutes IV, ideally within 3 hours, if the pulse is more than 110 per minute. And this you can repeat also. The advantage is if I do it like this, if I give it within the first 3 hours, it will reduce mortality. This is according to the CRASH 2 trial. Okay, this is according to the CRASH 2 trial. Someone had asked what is the full form of CRASH. Don't need to know. Something randomized, something in trauma. Basically, there is a CRASH 1, CRASH 2, CRASH 3. 3 CRASH trials. Okay, but don't go so far. Just remember CRASH 2. That is the one we need. So that is A for airway, B for breathing, C for circulation. Then the fourth component is D for disability. Disability means what you are looking for. What is D for disability? Disability means neurological status. Okay, it is not assessment of fracture. Don't say fracture and all. It is neurological examination in which you check 2 things. One is GCS, other is pupils, that we will discuss later. And then the last component is E for exposure, in which you are looking for any external injuries. Okay, in which you are looking for any external injuries. They should be life-threatening injuries. So you undress the patient and you look for open fracture, vascular trauma, those kind of things. Only when you have done the A, B, C, D, E, are you going to move to the next step, that is secondary survey. Patient should be stabilized at the end of A, B, C, D, E. Cool. So you always follow this order, check these things and solve the problems. For example, when you're doing neurological assessment, one of the things that you do is the GCS or Glasgow Coma Scale, in which you should know the calculation. That is, you have to count or you have to measure 3 components. Best eye opening, best verbal response, best motor response, right? So how to check eye opening? If the eyes are open normally, he gets 4 points. It is spontaneous eye opening. If I call out to him, and he replies, he gets 3 points. Eye opening on verbal commands. But if he's not replying to me, then I give a painful stimulus. That is 2 points. But if he has no eye opening, which is what will happen to some of you by the end of Dharma, eyes are not opening, you get 1 point. Okay. Right now you must be in E3 stage, hopefully. Soon you will become E2, very soon. And by the time I finish, you will be in E1. Maybe in Dharma you will remain in E1. I don't know. Okay, then you will wake up again. Good. That's good. Okay. So remember, when you are doing any component, there is no zero. The least score is 1 point. There is no E0. Okay. So that's how you will compare. That's how you will measure eye opening. Then you look at verbal commands or verbal response. If I ask a question, how are you, couple? I am fine, thank you. He gets 5 points. He's oriented. But if I ask, how are you, Adarsh? And he says, I don't know. Maybe I'm okay. Not very sure. He's confused. He gets 4 points. Then I ask, how are you, Pratyush? And his reply is, last class में आशीष था. E2 में रहने की आदत हो गई है. You know, he will say something inappropriate, like you guys were saying when I started. Inappropriate. He gets 3 points. You know, I asked something and you say something very pointed, unrelated to what I asked. You are inappropriate. So most of the times, you are inappropriate. Yeah. In V2, you only make sounds. How are you, Rohit Sharma? Sounds. He gets 2 points. If there is no verbal response, he gets 1 point. Again, remember, there is no V0. And the third component, the most important, is the motor response. Remember, motor response has the best predictive value. Between these three, motor is the most important. It has the best predictive value. Right. So I will ask Raftar, raise your right hand. He raises right hand. He gets 5 points, 6 points. So M6 is he's going to obey commands. If he's just randomly moving in the bed, moving in his chair, doing things with his hands and legs, you know, putting his hands here and there, that is not M6. M6 means he has to do what I say. Raise the right hand, right hand. That gives him 6 points. Okay, but he's not doing what I'm saying. Then I will give him a pinch. And when I give him a pinch, if he localizes pain, he gets 5 points. If he withdraws to pain, he gets 4 points. If I pinch him, but he flexes his full body, that is decorticate, he gets 3 points, abnormal flexion. If I pinch full body becomes straight, he gets 2 points. That is abnormal extension or decerebrate. And if he does nothing, he gets 1 point. Here also there is no zero. So what I'm trying to say is, in none of the scores, there is no zero. Abnormal flexion means you give a painful stimulus and full body flexes. It's hard to imagine. Okay, but it happens. When the cranial control is gone, even small stimuli will give a full body response, exaggerated responses. That means brain control is gone. So till here, the responses are only where you gave the stimuli. But here after, the responses are becoming generalized responses. Okay? So that's how you're going to measure. And you add up the two, the maximum score is going to be E4, V5, M6 or 15 out of 15. Obviously, higher is better. But remember, you may say the least score is 3, but it's not necessary. If there is some component that you can't check, like if he's intubated, you can't check that he's speaking, isn't it? He can't speak if he has a tube. In that case, you don't write verbal response 0, you write verbal response is NT. NT means non-testable. Okay. And then when you get the full score, it tells you the severity. If GCS is good, if it is 14 or 15, it means the head injury is mild. So 14-15 tak score is okay. 14-15 is mild head injury. If it is 9 to 13, it is moderate. In some places, 9 to 12 is given as moderate, doesn't matter. But if GCS is below 8, this is a severe head injury. And whenever there is a severe head injury, you must do intubation. Because this person will not recover, his airway will get obstructed very soon. So below 8, intubate, right? That is one of the rules. So GCS is giving you so much information. And you can do it repeatedly. You can use it for monitoring the patient. Like when the class started, your GCS 14 by 15. By the time class will get over, you will be 8 by 15. Right? So you are getting so much information. You can use it even for monitoring the response. That when a patient came, he was 12 by 15. After 2 hours, he's 10 by 15. That means he's having a neurodeterioration, which is what happens to you when class is going on, right? You're neurodeteriorating. Same thing you can monitor in the patient. So that is your GCS. Apart from this, there are some extra things you can do in primary survey. These are adjuncts to primary survey. Okay, these are adjuncts to primary survey. Localized pain, withdrawal pain, दोनों हुआ, then you take the higher response, whichever is better, because it is best responses, no? If he is localizing on one side, withdrawing on the other, you take the higher one. You take M5, not M4, and there is no averaging out. Then there are some adjuncts that you can use to primary survey. Means may or may not use them. Not necessary. A, B, C, D you will do in everybody. So you can put some tubes, like you can put Riles tube. You can put Foley catheter. You can do some investigations. Like you can attach ECG leads. You can attach pulse oximeter. You may or may not use them. You can do some x-rays. Like you can do x-ray of neck plus chest. And this will be done in AP view, not PA view. You can do x-ray of pelvis. This also will be in AP view, not PA view. And some blood tests, routine blood tests, like complete blood count, blood group and all, and arterial blood gas. When you do ABG, you also have to look at the person's lactate. Okay, I always ask why lactate is important in trauma. Why it is important? Lactate tells me how much bleeding he has gotten because it tells me how much body is getting hypoperfused. Okay, the more he bleeds, the more hemorrhage, the lesser perfusion, the more the lactic acidosis. It's a marker of severity of shock, correct? It's a marker of shock, absolutely right. Okay, so these are some things that I may do. Apart from this, I may sometimes also do a special ultrasound that is fast, right? Fast or focused assessment by sonography in trauma. It's a special ultrasound. Do I do it in everybody? No, I don't need to do it in everybody. It is done usually in unstable patients. Okay, so you can say it is the investigation of choice in unstable patients. So बोल सकते हैं. Okay, but basically it's the only investigation you have in an unstable patient. But when do I do it? You can do it in abdo trauma or pelvic trauma, unstable patient. So abdo-pelvic trauma. And if you also want to look at the chest, you will call it E-fast. Okay, you will call it E-fast. Also looks at the chest. So it is used for thoracic trauma. That is called E or extended fast. Now, what is this fast or what is this ultrasound? Yeah, it is useful only in blunt trauma. In penetrating trauma, it is not that useful. Not useful in trauma due to penetrating injury. Not that useful. Okay, so what you do, it's a bedside ultrasound. You look at these 4 areas in this order. Okay, quickly in 2 minutes you will check. So first you put the probe at the epigastrium to look at pericardial fluid. Okay, you're looking at pericardial fluid. Right flank, you're looking for free fluid. If there is free fluid in the right flank, what does it mean? Why will there be free fluid here? Maybe there is injury to right kidney or to the liver or something else. Okay, to the right kidney or to the liver. Then you put in the left flank looking for free fluid. If it is there, maybe it is left kidney or spleen, colon, anything can be there. Look at pelvis for free fluid. If it is there, many reasons for pelvic free fluid. It could be hemoperitoneum, could be peritonitis, some perforation. So I am not very sure, right? And if you look at the chest, 5 and 6, so 5th and 6th, this is E fast. You look at the chest, it will look for pneumothorax and hemothorax. Okay, these are some of the things I will get an information of in fast. Now, what is the problem? This is where they'll target in the exam. If the fluid is less than 100 cc, it may be missed. Free air may be missed. It can't tell you exact organ. Is it spleen or is it left kidney or is it colon? It can't tell you what type of fluid you are seeing. Is it blood he is seeing? Is it bile? So all that you can't see. And it can't identify bleeding in the retroperitoneum. So these are all drawbacks, which is why I told you to say it is the investigation of choice is a little, giving it too much importance. It is the only thing that I have, right? Like, see, those of you who would not have done my mission classes or lab 2, who are coming for this class for the first time, you are using me like fast. Okay, in that case, I am like you're fast. You have nothing else, you are unstable. I will try to help you. But is it ideal? That is stretching it a little too much, na? Let's be honest. In your words, I will call it NGL. Okay, not gonna lie. So it can save you, but okay, it can save you maybe. So these are things which are done in primary survey, and these are the adjuncts. Now answer this question. Do all the mathematics. NGL. NGL is also a marker of chronic kidney disease. NGAL it is called in chronic kidney disease. It's a novel marker like cystatin C. Neutrophil, gelatinase, associated lipo something it is, liponectin. सुना है ना ये सब जो मैं बोल रहा हूँ? NGAL सुना ही नहीं तो फिर जाने दो. ये सब क्या बोल रहे हो आप सर? अनाप शनाप नहीं सुना है, फिर जाने दो. ठीक है फिर. Then you are safe. This class is exactly same as lab 2. Wow, that means I'm covering so many things. There I had 2 days. No. Anyway, so patient was intubated. If he's intubated, his verbal response is NT. It is non-testable. Opens his eyes on verbal command. So eye opening is E3. So answer is E3 VNT M6. Okay. E3 VNT M6. Eye opening on pain is E2. Right. After doing the primary survey, then you go to secondary survey. Actually, it's not the same as lab 2. There are some different things. Why you want to know pupil part is not that important. You look at the pupils and you see how many pupils are fixed. You look at the fixed pupils, how many are non-reactive, and then you subtract it from the GCS score. It is called GCS minus P. So if your GCS, for example, is 12 by 15, and let's say number of fixed pupils are 0, both are reactive. So it will be 12 by 15 minus 0. So your GCS minus P will be 12 by 15. If both pupils were fixed, then it would have been minus 2. 12 by 15 minus 2. Okay. ठीक है आ गया? Okay. GCS V3 हो गया था. Inappropriate. After doing primary survey, now when your patient is stabilized, okay, now when the patient is stabilized, you go to secondary survey. Remember, secondary survey will be done in a stable patient, where you take a detailed history. It is given by the mnemonic AMPLE. A stands for allergies, M is for medications. Important medications that you ask for are anticoagulants. P is past illness or pregnancy, L is last meal, E is events leading to injury. Okay, E is events leading to injury. So this, you take this detailed history, you do a detailed head to toe examination. And if you want to look at his back, then you have to turn him like this. This is called log roll technique, for which you need minimum 4 people, and ideally there should be 5 people. Okay, 3 people will turn him, 1 person will examine him. But ideally 4 people should turn him and 5th person should examine him. So this is log roll. It helps in examining the back. This can be done in primary survey also. If you have enough people, you can do log roll in primary survey ka E for exposure. Here also it can be done. E for exposure. Here also you can do log roll, but normally you won't have 4 people to do it. So by the time you do primary survey, fine. And after completing secondary survey, then you go to detailed investigations and treatment. What investigations are done in secondary survey, which should not be done in primary survey? CT scan, endoscopy, if applicable. These can be done. They are all a part of secondary survey, right? Answer this. Patient with RTA or chest and abdomen, BP is 70, pulse rate is 110, means he is unstable. Which of the following is the next step? Unstable patient, you would say fast. If in fast, if you see free fluid present in abdomen, then what is the next step? Free fluid in abdomen present. What is the next step? Answer will be surgery. Okay, answer will be surgery. So you will go in this order in blunt trauma to abdomen. No, if patient is stable, you don't need to do e-fast. It's not a must. जरूरी नहीं है. Means क्या? Free fluid हुआ तो भी क्या? It doesn't matter. You will still do CT scan. Fast and e-fast same. Like if you also look at chest, you call it e-fast. Resuscitate तो कर दिया ना यार. कर दिया ना resuscitate. Go for A, B, C ना. So C for circulation. Adjuncts are later. Anyways, fine. Now come to head trauma. Very important 3 head traumas that you should know. First is EDH, extradural, then subdural, then diffuse axonal injury. These are the 3 most important ones that you should know. Okay. Fast, not for penetrating. No, I think I said that. It's not for penetrating. It's not useful in trauma due to penetrating. Penetrating we will do later. Now, there are 3 injuries: EDH, SDH, DA. Okay. EDH or epidural or extradural, the mechanism will be, it will be moderate trauma. There will be fracture of the pterion bone and uske niche the middle meningeal artery will tear. There is a tear of middle meningeal artery. So the implicated vessel here is middle meningeal artery. There is tear of MMA. That's the main problem here. And when the MMA will tear, it will bleed, it will make a clot like this, which will cause a compression of the brain, right? Which will cause a compression of the brain. Now, what you should know is how the person will present. He will first be unconscious. This unconsciousness is for a few minutes, 2-3 minutes. Then he wakes up. Then he is fine. Then he is unconscious again. Okay, he wakes up, he's fine, then he's unconscious again. What is the reason for the first unconsciousness? It is because of a phenomena called concussion injury. You understand concussion? It's a transient injury, transient loss of consciousness. When he got hit over here, he became unconscious for a few minutes, that is concussion. Then he becomes fine. This fine period is called lucid interval. It is the hallmark of EDH. That is called lucid interval. And as the clot grew and started compressing, he became unconscious again. The second unconsciousness is because of raised intracranial pressure. It goes in this order. Fine. It is because of the effect of the clot. So if they ask you next step, the imaging will be plain CT here. So here it will be plain CT. It will show biconvex or white idli. Okay, it will be biconvex, it will be white. It will be a white idli, like you can see over here, because it is attached, the dura is attached to the sutures. So it cannot spread more. It can only go medially. It will compress the brain very fast. So this is going to be EDH. Treatment of EDH, decompression. How do you decompress? You can either put a burr hole or you can remove a piece of the skull and remove the clot. That is called craniotomy. Okay, either ways it has to be done. And ideally, it should be done within 1 hour. Okay, ideally, it should be done within 1 hour. What is this called? What is this called? Decompressing an EDH within 1 hour? No, craniotomy is a technique. It is called golden hour of trauma. In EDH, you have to follow this principle of golden hour of trauma. Okay. People used to say golden hour is for all injuries. It's not. In a tension pneumothorax, you can't wait for 1 hour. Na? Tension pneumothorax within minutes. Airway obstruction immediately. Right? But EDH ideally within 1 hour. The longer you wait, the more the chance of raising of intracranial pressure. That is EDH. Now come to SDH. SDH are of two types. One is acute, other is chronic. Why will I get acute? It is because of a high velocity trauma. So it is a high velocity impact. Why do I get chronic? It is because of a trivial trauma in elderly patients. Okay, trivial trauma in elderly patients. Elderly patients whose brain is atrophic, even with a trivial trauma, the veins can tear. Okay, so in both acute and chronic, there is a tear of the veins connecting the dura to the brain. So they are called as bridging veins. Okay, it is due to tearing of the bridging veins. Now in acute STH, the presentation is very simple. It will be like a EDH only, but there will be no lucid interval. So there will be raised ICP, no lucid interval. How does chronic SDH patient present? How will chronic SDH patient present? Unconscious, no. He will have long history, 1 to 2 weeks history. He will have headache, imbalance. Okay, there will be headache, imbalance. So it will be a long history. It will not be acute history. He may not even remember that he fell. Slowly, the clot will grow. Nonetheless, in both, the investigation will be plain CT. And what you will see here in SDH, the shape will be like this, concavo-convex or moon-shaped or banana-shaped. Okay, it will be moon-shaped or banana-shaped, concavo-convex. If it is white, it is acute. Okay, if it is black, it is chronic. So that's how you will identify the images you can see in this image. So please remember, EDH is only acute. Okay, SDH can be acute or chronic. There is no chronic EDH. ऐसा कुछ नहीं होता. And here also the treatment will be decompression. Okay, the clot has to be evacuated. Is it possible that I don't have to do evacuation? We will not look for source of bleed in SDH. No, we don't need to look for source of bleed. Source of bleed is in SAH, subarachnoid hemorrhage, because you need to know which aneurysm has burst. Do I need to do decompression in every case? No, I don't. If it's a small clot, you can let it be. It means bleeding has already stopped. Okay, it means bleeding has already stopped. Burr hole is for small clots, focal clots. If it's a big clot or if you can't get the hemostasis, then you will do a craniotomy. That you can decide during the surgery. The third is DAI, diffuse axonal injury. This is a high velocity trauma and it has one of the worst prognosis. Okay, high velocity trauma. Here you will get hemorrhages in corpus callosum. Okay, you will get hemorrhages in corpus callosum. So here when the patient will present, he will come with a poor GCS. GCS will be maybe below 8 also. And here CT is normal. This is diagnosed on MRI. To see the small hemorrhages, you have to do MRI. And this has a poor prognosis. Please don't do any decompression here. There is no treatment for diffuse axonal injury. There is no decompression here. ठीक है? आया समझ में? Okay. ऐसे ही रहने दे उसको, yes, ऐसे ही रहने दे उसको. Okay, no, you can't treat it. There is no treatment for diffuse axonal injury. Okay, you're all writing 111 BC, 1BC. BC sounds like some gali. Contusion is normally seen with SDH, high velocity trauma. Okay, what intracranial hemorrhage is shown here? You can see. Now you don't have to imagine. You can make out. See, EDH will be very small area like this. This has gone beyond the suture line. So this is a SDH. This is a acute SDH. Okay, this is a acute SDH. Fine. Okay. Now come to chest trauma. These are in SDH for both. Yeah, it's the same. You have to remove the clot if it is big. Right? Treatment एक ही है, evacuation for all, except diffuse axonal injury. उसमें you don't have to evacuate the clot. Concussion is a transient loss of consciousness. There is no problem in the brain. Contusion is a clot in the brain. Okay. Contusion will not happen in isolation. Contusion will be with other head injuries. Okay. Fine. Subarachnoid hemorrhage is a medical condition. I don't know why you're asking about SAH. It happens because of rupture of berry aneurysms. Sometimes because of trauma, where the person will get the worst headache of his life. It is called thunderclap headache. SAH is a very unusual condition. He gets thunderclap headache. And CT will show star of death sign. Someone said star of death for DA. It is here. It is for subarachnoid hemorrhage. And there the treatment is not decompression. It's not causing raised ICP. There the treatment is do CT angio, see where the bleeding happened, and depending on the aneurysm, either coil it or clip it. They are totally different. Don't say PCI. PCI is for cardiac, coronary. You have to do interventional radiological treatment. It is called INR, interventional neuroradiology. Okay. कुछ भी मिक्स कर देते हो आप लोग. स्टार ऑफ डेथ आपने DI में चिपका दिया, फिर मेरे को बोलते हो फास्ट जाओ, 1.2x करो, 1.5x करो. कमाल है. कोशिश करता हूं मैं 1.5x करने की, फिर आप लोग ही रुका देते हो. व्हाट टू डू? iPad 2. एनीवे, एक ही चीज समझी थी. ऐसे ऐसे मेरे बारे में भी ऐसे ही बोलते होगे आप लोग, आई एम श्योर. एनीवे, so that was head trauma. Now go to tension pneumothorax and chest trauma. Very interesting condition. Here there is a one-way tear of pleura, one-way flap. There is a one-way flap-like tear of pleura. So what will happen? When the person inhales, the air enters the pleural space. The lung collapses. But when he exhales, the air can't go out. There is no escape. So with every breath, the pneumothorax keeps becoming bigger and bigger. Lung keeps getting more and more collapsed. and it starts getting pushed to the other side, and it will go and push on the superior vena cava. Okay, it will cause a compression of the superior vena cava. So the problem here is with every breath, the pneumothorax becomes bigger. So because of this one-way flap-like tear, there is a growing pneumothorax. It keeps growing. And eventually, it will cause a mediastinal shift. These are your favorite words that you read. Tracheal deviation, mediastinal shift. And that will cause a compression of superior vena cava. And because of that, venous return will reduce, cardiac output will reduce. It is called as obstructive shock. So the main problem in tension pneumothorax is obstructive shock. So pneumo is there, but the problem is not the pneumo, the growing of the pneumo pushing against the heart and the SVC. Okay, that is called obstructive shock. So when I will examine the person, when I do the respiratory exam, the air entry will be reduced. It may be absent. When I will auscultate, I don't hear no breath sounds. Breath sounds will be absent or reduced. When I will percuss, because there is an extra air in the pleura, you get a hyperresonance. If I just look at these three findings, what does it tell you? If I just look at these three findings, what does it tell you? Hyperresonance and absent breath sounds. It tells me it's a pneumothorax. Okay. Any type of pneumothorax, you will get these findings. But now are the important. The BP will be reduced. There will be hypotension. The JVP will be raised. This tells me it is not a simple pneumothorax, it's a tension pneumothorax. These are the two findings which tell you tension. A lot of students have asked me question like, there are some PYQs. Neckline was inserted, patient collapsed. His BP is normal, but he has findings of hyperresonance. What is the diagnosis? Everyone said tension pneumo. That's not tension pneumothorax. That is simple pneumothorax. Normal VP, normal JVP is simple pneumothorax. For tension pneumothorax, the SVC has to get compressed by the mediastinal shift. Then it will become tension. And for that, there has to be a one-way entry. Air can enter, can't escape. No, mediastinal shift should not be seen, at least not in the early stages. But mediastinal shift is not the diagnostic thing. These two are the diagnostic things. Okay, so mediastinal shift is not a specific finding, right? So that is about tension pneumothorax. Now, how do you manage it? This is the important part. No, don't check BP roadside. Only look at the neck veins. BP you can't check roadside unless you are a GP who is going everywhere, you know. सवाल में कितनी आपत्ति आनी चाहिए ये चीजों पे you should raise objection and not me saying 215 then 225 then 215. That was not my doing. Anyways, so first step in management is going to be needle decompression. Put a big needle in fifth intercostal space in the mid-axillary line. Okay, fifth intercostal space in mid-axillary line. So when I will put the needle, it will allow the air to escape. So the tension will go away. Now it will only have a pneumothorax. The tension will go away. The shift will go away. Neck veins will become normal. Then I can confirm by doing a chest X-ray. And then I will put an intercostal drain. And when I put the intercostal drain, I will attach a underwater seal. Okay. Now my question is, till when do you put the needle? For how long? Obviously, needle will not remain there forever, na? So for how long should you keep the needle in place? 15 minutes. 15 to 20 minutes. No, air gone. So, but when you remove the needle, air will fill that space again. No, 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 no. Until you put the ICD. Very good. जिसने भी ये बोला है. Till you don't put the ICD, you have to keep the needle there. Okay, so ऐसा नहीं है कि needle डाल दो, घर भेज दो, बोलो कल आना ICD डालने. First, put the needle, then put the ICD, then remove the needle. Okay, आई बात समझ में? Because the ICD will then do the job of treating the pneumothorax. I hope you are getting the logic. And please tell me in this image, where is the pneumothorax? Right side or left side? ICD is intercostal drain. The pneumothorax is here. This is the pneumothorax. Okay, this little bit is the collapsed lung. This is the normal side. Okay, the part where it becomes very black, this is the pleural space or the pneumothorax. Okay. Second condition, easy condition, cardiac tamponade. Quite an easy condition. In cardiac tamponade, there is collection of blood in pericardial space. Okay, blood collects in the pericardial space, usually in the setting of trauma. If it is more than 50 cc, it will compress the heart from outside. It will cause compression of the heart. Okay, it will cause a compression of the heart, like you can see here. Blood is collected around the heart because of trauma, and the heart inside will not be allowed to have a diastolic filling. And because it can't have a diastolic filling, there is reduced diastole. What will it lead to? What is the effect of this? This will also cause obstructive shock. So both the conditions, there is obstructive shock. Okay, tension pneumothorax and cardiac tamponade. So here also you will get some similar findings, but here air entry is normal because there is no problem in the lungs, but you will hear muffled heart sounds. The heart sounds won't transmit because of the pericardial blood. There is muffled heart sounds. When you will percuss, it will be normal percussion, resonance. The BP here will be low, GVP will be raised because of obstructive shock. These three things together is called as Bextrade. Okay, muffled heart sounds, hypotension, raised GVP. This is called Bextrade. So cardiac tamponade also I can diagnose clinically. If I ask you first step, what is the answer? What is the first step? No, here don't put needle. Your first step is to confirm. First do E-fast. And after you have confirmed that there is a pericardial fluid, then you can do pericardiocentesis. Okay, you can do pericardiocentesis with a needle, or you can do surgery, thoracotomy and repair. Fine. Either of them are okay. The preferred answer in penetrating trauma is going to be surgery. So if there is a penetrating trauma, then the answer should be surgery. Penetrating trauma causing cardiac tamponade. Then the preferred answer is surgery. What image is this? What is this image? This is a CT. Okay. And you can see fluid around the pericardium on CT scan. How CT was done? Is CT required? So this is not a penetrating trauma causing cardiac tamponade. This is just a pleural effusion. Oh, sorry, pericardial effusion. This is not a tamponade. Tamponade is a clinical diagnosis. These things have to be there. Okay, that is just a pericardial effusion. Okay. The third is massive hemothorax. This is easy to understand. This is massive hemothorax if there is more than 1500 ml of blood in the pleural space. Why should so much bleeding be there? No, effusion ka treatment is treat the cause. There you have to treat the cause if it's a pericardial effusion. So why does so much bleeding happen? It is due to injury to intercostal artery. Okay, due to injury to intercostal artery. That is usually the vessel which is affected. It bleeds. If it is more than 1500 cc, you will call it massive hemothorax. What is the problem in massive hemothorax? He will die of hypovolemic shock. So here it is not obstructive shock. Okay, here it is hypovolemic shock. Right. Now, how will this person present? Here the air entry will be reduced because of the hemothorax. But here when you will percuss, the note will be dull. BP will be low. JVP will be reduced. Okay, here it is not raised. Here JVP is reduced. Because there is less blood will cause collapsing of the neck veins. Hypovolemic shock is the broad term. Hemorrhagic shock is one of the causes of hypovolemic shock. Okay. So if I am bleeding, it's hypovolemic due to hemorrhage. If I have a lot of vomiting, it is also hypovolemic shock only. So hypovolemic is the blanket within which you have hemorrhagic shock and other causes of hypovolemia. Okay. So don't make simple things difficult. Now one question. Can I get tension pneumothorax type findings here? Because here also lung is collapsing, na? Won't it go and cause compression of the SVC? It won't. Okay, it won't, because no, it's not that it's bleeding and the blood is going anywhere. No, it's not like that. The thing is, the bleeding will happen here. Once it becomes a lot, 1500, 2 liters, by then the person is dead. Okay, by then the person is dead. Before he gets the mediastinal shift, his blood will be over. There is no blood left for it to cause mediastinal shift. Okay, so don't say, sir, इसमें भी होना चाहिए mediastinal shift, because here also is bleeding. There it was air, here it is blood, but blood is limited. It will not cause a mediastinal shift. Not so much. Okay. You ask these questions, that's why I'm telling you beforehand. फिर आप बोलोगे कि अरे, you know. Anyways, what is the first step here? First step here is give him IV fluids because he is bleeding. Give him blood and blood products, tranexamic acid. See that he gets stabilized. Then confirm the diagnosis with a chest X-ray. Then put an intercostal drain. Now, when you put the ICD is not to treat the hemothorax. You look at the quantity of how much ICD output is coming. If there is more than 1500 ml of blood in the ICD, that means it's a massive hemothorax. Or if the output in the ICD is more than 200 ml per hour for 3 consecutive hours. Okay, 200 ml per hour for 3 consecutive hours. It means the bleeding is active. These persons will require surgery. Okay, these persons will require surgery. So between the 3 traumas, surgery will be done in penetrating cardiac tamponade or active bleeding if a person is having massive hemothorax. Okay, these are markers of active bleeding. If it's 200 ml per hour for 2 hours, you wait for 1 hour. Yes, you do. Or if it keeps increasing very rapidly, then also you can take the person for surgery. But for MCQ, this is the answer. If any of it is there, answer is surgery. If none of this is there, you can wait. It means bleeding has probably stopped. Okay. And this is how hemothorax will look. It looks like any other pleural effusion. This is where you will put the ICD. Okay. Yeah, surgery will be thoracotomy. Correct. Absolutely. Now, where to put the ICD? It is put in the space which is called triangle of safety. That space over here, that is called triangle of safety. Anterior limit is pectoralis major muscle. Posterior limit is latissimus dorsi muscle. Inferior limit is fifth intercostal space. And when you are going to put it, the site of the triangle on the affected side. Now don't say, is it only on the left side? It is on the affected side, the side where the disease is. So where it is going to be put? Just anterior to mid-axillary line. Okay, it is just anterior to mid-axillary line. And you will insert it along the upper border of the rib. Normally it will be fifth or fourth intercostal space, whichever space you are putting it in, put it along the upper border of the rib. Okay, so this is the space in which you are putting along the upper border. Okay, lower border will have the intercostal vessels. So put it along the upper border of the rib, and then you attach it to the underwater seal bag. Okay, answer this. It is 200 to 250. Okay, I am giving you the lower number. It is the safer answer, but it is 200 to 250. It's a range. Okay. Patient presents with history of RTA. There is absence of air entry, increased resonance, hypotension. What does this mean? It means he's having tension pneumothorax. Right. What will be the next step? Please don't say ICD. It will be needle decompression in the fifth intercostal space. Okay. A lot of people say, why not plan for intubation? Isn't airway more important than breathing? Why not intubate him first? Isn't airway more important than breathing? No point. Yeah, because there is no airway problem. Why the hell are you intubating him? His airway is normal. You intubate him, there is some airway problem. Here the problem is not airway, problem is breathing. So even if you intubate, it's not the solution. The solution is needle followed by ICD. आई बात समझ में? I am just telling you what people ask me. This is what they ask me. Sir, why not intubate? Airway is important, but airway is not obstructed. No. Right. Now come to abdomen trauma. It's not the most difficult compared to the other traumas. It's fairly easy. Now there are two aspects. One is blunt trauma, other is penetrating trauma. Most common organ injured in blunt trauma, most common in penetrating trauma. So in blunt trauma, most common organ injured is spleen. In penetrating trauma, it is liver. If I ask you in blast, what is the most common organ injured in blast? It is tympanic membrane followed by lung, followed by GIT. And if I ask you seed belt, then it is mesentery. Okay, seed belt trauma is going to be mesentery. See, I know what all goes in your mind because you have mugged up these 3-4 points. That's why I purposely put this blast. Purposely to blast your mind away. Okay. Now, no, I'm talking about primary blast, not secondary. Primary only. It's all primary. Now, what will make you think person is having splenic trauma? What are the markers of splenic trauma? In blunt trauma to abdomen, there should be fracture of left-sided ribs. In liver, there should be fracture of right-sided ribs. Because liver is just below the right ribs. Spleen is just below the left lower ribs. In kidney, there should be injury to flank. Okay, there should be injury to flank. Then you will think of renal trauma. In spleen, there are two clinical signs you should know the names of. One is called Kehr sign, Kehr. Other is called balance sign. Kehr sign, he gets left shoulder tip pain when you palpate the spleen. Balance sign is he gets left flank dullness. Okay, on percussion. So these are markers of splenic trauma. Liver trauma, there is no other marker. Underwater blast is GIT, yeah, because the blast will not hit your ears or your lungs. That's why. Because in underwater, lungs will not get the blast effect. It will go to your abdomen only. In kidney, one very important finding, if there is injury to kidney, the person will present with hematuria. Okay, abdomen trauma, hematuria equal to renal trauma. Okay, abdomen trauma with hematuria equal to renal trauma. Fine. Now, how to manage the patient if he is unstable? Chalo, this you can tell, it's quite simple. Unstable patient, abdomen trauma, blunt injury. What will you do? First do E-fast. And if E-fast is positive, then do surgery. If he is stable, then what you will do? If he is stable, do secondary survey. Means do his detailed examination. Then do CECT. And based on CECT, you will decide. Okay. On CECT, you will decide what needs to be done. You look at the grade of injury, the AAST grade. If the AST grade is a low grade, 1, 2, 3, then just observe. If the AST grade is a high grade, grade 4, grade 5, then you will either do surgery or you will do angioembolization. Okay, angioembolization. Hollow visceral injury, overall CT करना है. Overall मतलब stable patient में CT करना है. Surgery can be either laparoscopy or laparotomy. Both are possible. In today's day and age, even laparoscopy is possible. CCT किस चीज का? एब्डोमेन का. हाँ, और किस चीज का करेगा यार एब्डोमेन ट्रॉमा में? If hollow visceral perforation, what you will do? You will do surgery. Okay, hollow visceral perforation means he'll have free air or something. AAST is the name of the grading system for organ injury. American Association of Surgical Trauma. They tell you how much is the grade of injury of spleen, liver, kidney and all. Okay, but don't need to memorize the grades. It's little complicated, not that important. That's why I'm not mentioning it here. Now, what is this that you are seeing? What is this thing you are seeing in the image? PYQ, Pringle technique. Where do you do it? When is it done? It is done for liver injury or liver bleeds. Okay, where you are applying this clamp. What is this clamp doing? What is the role of this clamp? What are you clamping? What are you clamping? This clamp you are applied. What are you clamping with this? You are clamping the hepatic artery and the portal vein temporarily. Okay, you can clamp it for 15-20 minutes. So you apply this clamp. What will happen is the hepatic artery and the portal vein get clamped. So wherever it was bleeding in the liver, at least for that time, the bleeding will stop. And then you will be able to see, okay, there was a tear over here. From where it was bleeding, you can stitch it. And that's how you control the liver bleed. Yeah, if it still bleeds, these are not the sources, then the bleed is probably some retrohepatic vein. That is true. Okay, so in a very simple way, in half a page, you can manage blunt trauma to abdomen. CBD is getting clamped, but that's not the aim. That's not the aim. Yes, obviously CBD is a part of it. You're not wrong. But the aim is not to clamp the CBD. The aim is to clamp the hepatic artery and portal vein. Now come to penetrating trauma. How to manage a patient with penetrating trauma to abdomen. Any person with penetrating trauma who is either unstable, gunshot, impaled object. You understand impaled object? Impaled means knife was put and it was stuck there. Evisceration means organs are coming out. Or peritonitis. If anyone present, no need to do E-fast. Straight away take for surgery. Okay. No need to take for E-fast. Straight away take for surgery. If none of these are present, means he is stable, no object is stuck, no organ is popping out. There is no peritonitis. Then what to do? Now tell next step. Don't jump for CT. Do a wound check. Check his wound. Check the site of the stab. Do a wound check. And see what is happening at the wound site. If it's a deep wound, or you are suspecting peritoneal breach. If it's a deep wound or you're suspecting peritoneal breach, then in that case do CT abdomen. Okay, now I have to mention CT abdomen. I will not write just CT. Then do CT abdomen. If it is superficial, means only skin and all is cut, then just suture the one. No need to do anything. Okay, एकदम ही simple way में बता रहा हूँ. These are all very complicated topics and you will always make a mess of these things. Don't make a mess of these things. Okay, easy questions you have to get right. They should be in your pocket. That's how you clear any exam. And your exam has become increasingly hard. So I don't want you to make a mess of the easy questions. Hard questions, you make a mistake, it's okay. No problem. Easy questions should be in your pocket, right? You're spending so much time and energy. You better make use of it, na? है ना? So why are you taking so much effort sitting for my class since 10 o'clock? Why? So it should bear some fruit. है ना? Right. What is this instrument with which he has clamped this area? What is the name of this instrument? No, this is not a Satinsky. No, this is a DeBakey clamp. This is called a DeBakey vascular clamp. It looks a bit like hemostat, but it is not a hemostat. They are very thin instruments with which you can compress the artery. Okay. You cannot use your normal artery forceps and all. They will crush the artery. These are soft clamps. This is a DeBakey clamp. It has a nice, angulation over here. Okay, it will not harm the artery because you are clamping hepatic artery. If clamp is too hard, it will crush it. फिर क्या, hepatic artery portal vein is finished. Then you know what you'll have to do, na? If hepatic artery portal vein gets traumatized, you know what you'll have to do, na? Jail. Array, what will you have to do at that time? Jail. Run. Bye bye. No, you'll have to repair hepatic artery and portal vein. Disaster. And if you can't repair hepatic artery portal vein, you'll have to give a new liver to the patient. नया liver कहाँ से लाओगे? अपना liver देना पड़ेगा फिर. Okay, that's why we have these clamps. They are softer clamps. Anyways, now come to the last part of trauma. That is bladder rupture and urethral rupture, your favorite topics. See, I have pre-drawn it so that you don't imagine anything. Otherwise, you will say penectomy and all is none. That's why I drew it before only. So when will bladder get rupture? Bladder rupture happens on full bladder. If the bladder was full and you got a trauma, you will get a bladder rupture. Urethral rupture will happen when the bladder was empty. So if you got abdomen trauma and the bladder was empty, bladder will not burst, urethra will burst. Okay, so let's make it simple. It's not that hard. First, do bladder rupture. Now see, what injury will cause bladder to burst? Two ways, very simple. First is if the injury is over here, hypogastrium. Okay, hypogastric injury, the injury will go like this. It will hit the roof or the fundus of the bladder. So what will happen here? Hypogastric injury, fundus will tear, peritoneum will tear, urine will leak here in this. This is going to be intraperitoneal rupture. Okay, and name itself tells you if there is intraperitoneal rupture, he will get a peritonitis. Right. Second scenario, injury is a little lower down. Over here, this is pubis. The tear will happen over here in the lateral wall. Where will the urine go? It will go here in this area. It will collect over here around the bladder like this. What is this structure I have drawn? That thing over there that I have drawn. What is that? This. Yeah, that is a pelvic floor. Very good. Pelvic floor. So urine can't go below it. Urine will be above the pelvic floor around the bladder in the cave of Barretts. This is called as extraperitoneal rupture. And in extraperitoneal rupture, there is no peritonitis. Okay, quite simple. So bladder rupture, I think you should not have any problem with. Should not cause any problem at all. Intraperitoneal rupture, site of injury is hypogastrium. Okay, it's a hypogastrium injury causing a tear of the fundus. Fundus will tear. Will blood be seen at urethral meatus? No. So in bladder rupture, no blood is seen at urethral meatus. That is an urethral rupture. Abdomen here will show rigidity because of peritonitis. Okay, there will be no other findings. In extraperitoneal rupture, the injuries to the pubis causing a tear of the lateral wall. Okay, now I don't think it should cause much problem. Huh? There is tear of the lateral wall. Blood at meatus will be no. Abdomen will be normal. Where does the urine leak? Where does the urine leak? It leaks in the perivesical space, which is called cave of Barretts. Okay, which is called cave of Barretts. Now, what will make me think person is having bladder rupture? He got an injury. The bladder burst. Patient will come and say, I am not able to micture it. He is unable to micture it, but there is no blood at meatus. How do you prove bladder has burst? How will you prove bladder has burst? So what you will do, you will put a Foley's catheter. You will inject a contrast and see is it leaking. If it leaks up, it is intraperitoneal. If it leaks in the side, it is going to be extraperitoneal. Simple, not that hard. You do this test. The name of the test is retrograde or ascending cystogram. Okay, if you want to see the bladder, you will do cystogram. Please don't say micturating cystogram. Huh? He is not going to be able to micture it. You are injecting it directly into the bladder. So this is an ascending or a retrograde cystogram. It looks like this. See the first image. This is the catheter. You put the contrast in the bladder. It is going here. So this is likely to be intraperitoneal rupture. Likely. You see the second image, contrast is leaking over here. Likely to be extraperitoneal rupture. No, you won't do NCCT. You can do CT cystogram. Okay, you can do the same thing instead of taking X-ray. You can do CT also, but it will be a CT cystogram. Means you have to catheterize, push the contrast. That has to be done. And then either you do X-ray or you do CT. This will tell you whether it's intra or extraperitoneal rupture. Why do I need to differentiate the two? Why do I need to differentiate the two? Treatment is completely different. Intraperitoneal rupture, he has peritonitis. So here I have to do laparotomy and repair. So treatment for intraperitoneal rupture is surgery. But for extraperitoneal rupture, the leak is happening over here. This area is not possible to operate on and stitch. Very difficult. So for extraperitoneal rupture, I just wait it out. You wait for 8 to 10 days. Okay, you wait for 8 to 10 days. It heals by itself. Keep the Foley's there. Let it heal by itself. No need for surgery. Then you will be like, sir, what about the urine which is leaked out? That will get absorbed. Just keep the catheter, it will get absorbed. See here, there is no peritonitis. So here you can wait. In intraperitoneal, peritonitis was the reason you had to operate ASAP, right? So simple way, you can differentiate the two conditions, intra and extraperitoneal ruptures. Now the more fascinating one is urethral rupture. And in urethra, there are two places where it can get ruptured. One is this prostatomembranous urethra, that is called as posterior urethra. Other is this curved urethra, which is called bulbar, which will eventually become the penile urethra, right? So the two places of rupture, posterior and bulbar, they are the two common sites. Penile urethral rupture is very rare. That will happen during catheterization. Otherwise, it won't rupture. By trauma, it won't rupture. Now, how do these urethra rupture? First, injury should happen when the bladder is empty. The first site of injury is over here, pubis. So if there is a pubic trauma and the bladder was not full, it was empty, the injury will go and hit over here. Urine will start leaking. Not that much, but some urine will leak. So this will look like a extraperitoneal bladder rupture, but it's not that much leakage. This is your posterior rupture, where the urine is leaking in the same cave of Barretts. Little urine is leaking. Second injury is very different. Here the injury came over here in the perineum, right? This injury, polastride or a manhole cover, straddle injury, all those where the perineum got injured like this. So when there is a perineal trauma, the force will go and hit the bulbar urethra and urine will start leaking here in the superficial perineal pouch. From here it will go into the subcute of the scrotum, maybe into the penis as well. So the two urethral ruptures, posterior and bulbar, are extremely different. Like they have nothing really in common, barring one finding. They are entirely different. Like you should not be confused between them. In posterior urethral rupture, there is a pubic injury. There is tear of posterior urethra. Anything else tears in posterior urethral rupture apart from posterior urethra? Along with puboprostatic ligament. Very good. The puboprostatic ligament will also tear. And because this ligament tears, the prostatic attachments become loose. So you get what is called as floating prostate. The most important thing, blood-eyed urethral meatus will be present in both. Okay, in both, blood-eyed meatus will be seen. Abdomen will be normal. Other finding will be floating prostate on rectal exam, also known as floating prostate, also known as Vermeulen sign. Right, this is posterior rupture. Bulbar rupture mechanism is different. It is a perineal trauma, like a fall astride injury, straddle injury, and all. And here, when there is a perineal trauma, abdomen will be normal, but you will see a perineal hematoma. That's where the injury happened. You may see scrotal swelling. Urine goes in the superficial perineal pouch. So you will see scrotal swelling, penile swelling. No. In perineal trauma, bladder can't burst, like it's so far. If it's a fall astride injury over here, bladder will not burst. For bladder to burst, the injury has to be in the abdomen, not perineum. Perineal trauma will only cause bulbar urethral rupture, nothing else. Now, how to identify what type of injury is this? Not in thigh, difficult to go till the thigh because the leak is not so much. Now here, since he is having a urethral rupture, if there is blood at meatus, I can't do cystogram, means I can't catheterize. No, I can't do cystourethrogram. What I'm going to do is I will just put the tip of the catheter in the urethra and inject the contrast and see where it leaks. Okay. I cannot catheterize him fully, just the tip. So here what I do, put the tip of the catheter in the urethra and inject contrast. This is called as retrograde or ascending urethrogram. Okay, retrograde or ascending urethrogram. This is your favorite image. Everybody asks me this. So what have I done here? Put the tip of the catheter, inject the contrast, see how it is going. Now first see the parts before you say anything else. Micturating कैसे होगा? How will he micturate? If the urethra is burst, how is he going to micturate? It's not possible. And how do you put the contrast in the bladder for you to do a micturating cystourethrogram? This is easier. Directly inject the contrast, take an X-ray. Now see, this curved urethra is the bulbar urethra. The straight urethra is the prostatomembranous urethra. Okay, now you get one idea. Now see these images. Contrast is going like this and it is leaking here in the vertical straight urethra. So this is likely to be posterior rupture. Likely. See the second image. Contrast is going like this. It is leaking in the curved urethra only. It has not gone only into the straighter urethra. So this is likely to be bulbar rupture. Likely. But don't just go by the image. The images can be difficult. Look at the history. History will be more suggestive that perineal trauma will be bulbar. Fine. Now, how do you treat it? Do I have to differentiate the two? Vermeulen sign is when I do per rectal exam, the prostate moves because the ligaments have torn. That is called floating prostate. Do I need to differentiate the two for treatment? Actually, no. Treatment is more or less the same. What will I do here in both? I will first do a suprapubic cystostomy, SPC. So first do suprapubic cystostomy. At least he gets a urinary diversion because right now he can't micturate. So first do SPC. Then you wait for 1 to 3 months. So you wait for 2-3 months. So what will happen? Whatever was the tear, whether it was bulbar or whether it was posterior, it will form a stricture. You repair the stricture. Like, what else did you manage like this? What other condition did you manage like this? आज ही पढ़ा जो bile duct injury. You manage bile duct injury the same way. First you put a pigtail, drained the bilioma, then you did a delayed repair for bile duct of Strasbourg PCD. Esophageal corrosive injury is also similar. Okay, similar. So this is like Strasbourg 234. Okay, you let the stricture form. In the emergency, don't do anything to the injury. Later, aram se do a stricture repair. That's how you will manage it. Okay. Now, these topics are going to be a lot easier to understand and get the answer. Bladder mein he cannot micturate, but you can catheterize him, na? It's easier. And when you will catheterize him, the urine will comes in the normal pathway. Here the problem is you can't catheterize. That's why. Because there's a urethral rupture. Is there any IOC? IOC is these are the IOCs. Retrograde ascending cystogram, retrograde ascending urethrogram. Okay, answer this. I feel if you attend today's class properly, you won't have to revise surgery again. You'll need maybe 3-4 hours more of revision closer to your exam. That's it. 3-4 hours more. Just go through PYQs and our notes. Then you are sorted. Right. So your first line tells you the answer. He fell in the manhole, injured his perineum. Blood at the tip of meatus, swelling of perineal region, penis and scrotum. This is going to be bulbar urethra. whichever notes you have made. Why you said likely? You can't confirm from the image. Images are not very clear. If there is a lot of leak, like you see here, so much is leaking, I can't exactly make out where it is leaking from. That's why. The way to confirm is from the history. History is the best way. Okay. So now come to breast endocrine. So we are left with breast endocrine urology. So first do breast endocrine. Most important for your exam is breast abscess and some things from breast cancer. Of course, they are important. Answer this. Let's do the easy part first, then I'll give you chota break. I know you're reaching your 1 hour 30-minute window. I'll give you small 10 minutes break. But let's do a few more slides then. So there are two things you can see here. What is this finding? And what are the findings in the side? The first thing, this is nipple retraction. Okay, first thing is nipple retraction. The second finding, this is pseudo-orange, PDO. Now, nipple retraction happens because of infiltration of lactiferous ducts. Pseudo-orange is because of involvement of subdermal lymphatics. Okay. If there is involvement of Cooper's ligaments, you get dimpling. Okay, you get dimpling. So, any patient who comes with a breast lump, what will tell you it is a breast malignancy? Seen in, first tell the golden words, who gets breast cancer? Multiple or single is a clinical diagnosis. This is seen in elderly, I write full form here, elderly women. Okay, this is seen in elderly women. Smoking, I would not add, it's not that important. It is a risk factor, but not that important. There are other risk factors, nulliparity and all. Now, what will tell you it is a breast cancer? Elderly woman who comes with a lump, which is growing very fast, rapidly growing. Like she will say in 2 months, it has grown 5 times its normal size, or 5 times it was before. Rapidly growing, it is hard in consistency. There will be bloody nipple discharge. It will make you think it is a malignancy. Bloody nipple discharge in an elderly woman is usually malignancy. If a young patient presents with bloody discharge, what will you think? What condition is this? It will be a ductal papilloma. This is a benign condition. Huh? So young patient with bloody nipple discharge is duct papilloma. How do you treat duct papilloma? Treatment. Just completing it over here. Treatment of duct papilloma. Excise the papilloma. How? It is called as microdocectomy. Means excise just that duct. Microdocectomy. That is the treatment of ductal papilloma, not wide excision. It's a benign condition. Okay. So coming back to breast cancer. Patient comes with a lump, big lump, fast lump, bloody nipple discharge. Then some findings which will tell you it is a malignancy. Like if Cooper's ligaments are involved, you will get dimpling. Usually this will happen if 1 or 2 Cooper's ligaments are involved. If many ligaments are involved, you get what is called as puckering. If lactiferous ducts are invaded, nipple gets pulled in. Subdermal lymphatics invasion, you get pseudo-orange. Between these three, which is the most important clinically relevant finding? Ductectasia is Hadfield procedure. Someone has written in chat. Pseudo-orange is the most important finding because this will affect the T stage. Okay, this affects the T stage. So this is the most important finding. Which lymph nodes does breast cancer spread to? It's to which lymph nodes? Most of the times it is axillary. Any other? Any other? Very good. Internal memory. So these are the two groups of lymph nodes to which the tumor can spread. Hematogenous. It goes to lumbar vertebra. Okay. The teaching is most common malignancy with lumbar vertebral mets in females is breast. In males, it is prostate. Okay. So bone mets, breast and prostate, the two most important malignancies. So patient comes with these findings: pudgy orange, nipple retraction, breast lump, growing very fast. What to do? What do you do first? Yeah, here also Bateson only. What is the first step? PI. First step is going to be triple assessment. What is the diagnostic accuracy or positive predictive value of triple assessment? It is 99.9%. Means if I do these three things, 99.9% I will get the diagnosis. Okay. So what are the three things that you do? First, you do history and exam, which you just did. You do imaging. In imaging, you can do mammogram. Commonly, you will do mammogram. It is a low dose X-ray. The radiation is very low. And it is taken in two views: craniocaudal view, mediolateral oblique view. You can see here. This is the craniocaudal view of the two breasts. This is the mediolateral view. If you see a lesion, it will be given as some dangerous findings will be given. Like these are the dangerous findings of lesions on mammogram: microcalcification, irregular border, wide halo. These are dangerous features. Now, if the woman is more than 40 years and she has a lump, you will do mammogram. If she is less than 40, you will do sonomammogram. Okay, very important. So in younger patients, sono is preferable, not because of radiation. It is just better. Okay, it is just better. Because younger women have denser tissues, it will show a lot of artifacts on mammogram. Second is, in all women, normal patients, ideally annual screening mammogram should be done. Okay, ideally. So any woman with a breast lump, if she is more than 40, do mammo. Less than 40, do sono mammo. Okay. But then when will I do MRI? It is done in patients who are high risk BRCA positive, in whom I want to do early screening because they will get cancer at a young age. So by the time they are 25 years of age, I will start screening them with MRI. Or if you are suspecting scar recurrence, women with implants, women with diffuse calcification, these are some other reasons. So MRI, obviously, it is the best imaging. But I don't need it in every patient. In most patients, I manage with the mammogram. In some, where any of these indications exist, that's where I will do a MRI breast. That is a part 2. Part 3 is tissue diagnosis. How to do tissue diagnosis? Which breast cancer has more risk by smoking? Invasive ductal. Invasive ductal, Mondor's disease, ductectasia are all linked with smoking. BRCA में USG कर सकते हैं, but I want a much more sensitive test because the chance of cancer is very high. That's why. For tissue diagnosis, the best test to do is core biopsy, which I do with this device. This is called true cut biopsy needle or true cut biopsy gun. This say I take the biopsy. Okay. So the test of choice will be core biopsy, not FNAC. Okay. So these are some of the investigations you do. The staging and treatment part we'll do in some time. Let's take a short break, last break, then we'll do the staging. Okay, please be back by 4:10. Okay, this is the last break. Then you will go till the end. Hello guys, welcome back. Shall we move on? Are you ready? Yes. Okay, we are in the last lap, last leg of the race for me. For you, Dharma is also there. Right? So after doing all the investigations, now you will do the TNM staging. And in the TNM staging, of course, they love asking one of the favorite topics for the exams, that the T here is not like your GI cancer, T1, T2, T3, T4, mucosa and all. Here the T stands for tumor size. Size means maximum diameter. Okay, size means maximum diameter. Where T1, T2, T3 up to 2 centimeters, 2 to 5 centimeters, more than 5 centimeters. What they love asking is your T4 stage. That is their favorite one. Where in T4A, tumor is invading chest wall. When will you say tumor is invading chest wall? How do you know it is chest wall invading? It is fixed to the ribs, intercostal muscles, serratus anterior. If any of these words are there, you will think of T4A. Fixity to pec major does not affect the T stage. T4B is skin invasion in the form of ulceration, peau d'orange, satellite nodules. What is not included in skin invasion? Dimpling, puckering. Someone was asking how to know dimpling, how to know puckering. Dimpling is single Cooper's ligament, like a dimple. Puckering is like wrinkling. Many ligaments are affected, but it doesn't affect the T stage. So dimpling, puckering, nipple retraction doesn't matter. Only peau d'orange is counted. T4C is where you have both A and B. And T4D is inflammatory breast cancer, where you have erythema, means the skin is inflamed, or you have a large amount of peau d'orange, more than 1/3 of the skin. Right? So these are the markers of inflammatory breast cancer. And inflammatory breast cancer, of course, has the worst prognosis. It is the worst type of different types of invasive breast cancers. Right? So that is the T stage. Now, as always, we do one test on the T stage where I say the tumor is 4 by 2 centimeters and fixed to the pec major. What is the T stage? Okay, 4 by 2 is not 8 centimeters. 4 by 2 means maximum is 4. It will be T2. Okay, pec major does not affect the T stage. Now I say it is 4 by 2 centimeters, but it is fixed to serratus anterior. It is fixed to serratus anterior. Now what is the T stage? So 4 by 2 means T2. Serratus anterior means T4A. Answer is T4A. Okay. To the same, if I add, it is also showing skin ulceration. To these findings, I am adding skin ulceration. Now skin ulceration means T4B. So you will say, sir, T4B is the highest, but no. 4A plus 4B equal to 4C. Okay, so answer becomes T4C. Watch out for this. Okay. Please watch out for this. 4A plus 4B, dono hai. Dimpling is not in any TNM. Not counted. Puckering, nipple retraction, not counted. Fine. Then the end stage, only know N1 is ipsilateral mobile. N2 is ipsilateral fixed axillary. N3A is infraclavicular and N3C is supraclavicular. Only know this much. Okay. N3C is supraclavicular. It goes in this order. Okay, the order is like this. From axilla to infra to supra. So mobile axillary, fixed axillary. So N1, N2A. N3A infraclavicular, N3C supraclavicular. Okay, that is the end stage. This is the only cancer whose end stage you should have little idea about. Now, after doing this, you come to the treatment. Treatment now is very easy because you have done so many cancer treatments. Nipple retraction, dimpling, not skin involvement. No, it is not going to be counted as T4B. It is not. Only these are counted. Okay. So how to treat breast cancer? You already know if it's an early cancer. Early means T1, T2. Some T3 is also included, N1. Sometimes even T3. So what will you do? You will do surgery. Then you will give chemo, adjuvant chemo. Now in breast cancer, you may also give radiotherapy. It's also possible. You may also give hormonal therapy. Tamoxifen can also be used. So there are 4 components in the treatment, even if it's an early breast cancer. If it's LABC, then you follow the same dictum, neoadjuvant. Chemo, downstage it, make it small, then do surgery. Then later you may be able to give radiotherapy if possible, and you may give hormonal therapy. So here it is all the treatment modalities are going to be used. And if it is metastatic, you will do palliation. Okay, you will do palliation. So these are the treatments. Logic is the same. Now, when I say surgery, I have 2 choices in surgery. One surgery is MRM or modified radical mastectomy, where what are you going to remove is entire breast. It's a mastectomy, so full breast will have to be removed, including the nipple areola complex. Short may I'm writing, nipple areola complex will also be removed. And since it's radical, means you also have to remove the lymph nodes. So you will remove axillary lymph nodes. Which lymph nodes are you not removing? Which lymph nodes are you not removing? Internal mammary. Okay, internal mammary are in the chest. They are not removed. Any other that you are not removing? Which were there in the staging? 4th, 5th, nay. Clavicular, supra, infra. Those are also not removed. Only axillary are removed. Okay, or कोई नहीं निकालना. So you remove all this, but it is modified. Means there must be an OG. There must be a OG radical, which you have modified. So what will you preserve? You are going to preserve pectoralis major. This is not removed. You are going to preserve the ribs. In the OG, this was also removed. Okay. Most common complication is going to be it's going to be seroma formation. So since you have done so much of removal, dissection, lymphatics get injured, some fluid will collect, that is called seroma. Most common nerve injury is intercostobrachial nerve. But if this gets injured, it's not such a big deal. Little sensory loss will happen in the chest wall. If patient presents with an arm swelling within a few weeks, what does that mean? Arm swelling within few weeks. It means he's gotten lymphedema, not lymphangiosarcoma. It means he's gotten lymphedema. If he presents with nodules after several years, like you see in this image, after several years, not in the early post-op period, this is lymphangiosarcoma. Okay, this is cancer of lymphatics, lymphangiosarcoma, also known as Stewart-Treves syndrome. Okay, also known as Stewart-Treves syndrome, right? So these are the components of MRM. In MRM, you are removing everything, the full breast, the nipple, the axilla. Now, if the woman has a chota sa breast cancer, she's come early, and you tell her, I will remove your full breast, she may not be okay with it. So the alternative to early breast cancer MRM is BCT. Okay, that is the alternative, that is BCT. Now, what to do in BCT? Why is it called breast conservation therapy? It's because you don't remove full breast, you do a wide local excision. Okay, you do a wide local excision with a 1 centimeter margin. Cross margin is 1 centimeter. So breast is conserved. Second thing is, you have to decide whether to remove axillary nodes or not. Compulsory nahi hai. It's not compulsory. Should I remove or not? You have to see. But the third component is you have to give radiotherapy. It is compulsory. Okay, it is not optional. Any patient in whom radiotherapy is not possible, you cannot do BCT. For example, if the person is pregnant, then BCT is not possible because you can't give radiation. Then your treatment becomes suboptimal. Any person who has received chest radiation before, prior chest radiation, पहले से ही ले चुके हैं, then you can't keep giving radiotherapy. It is a contraindication. Person has connective tissue disorders like SLE. You can't give radiation. Second thing is, I can't do BCT if wide local excision is not possible. Like let's say tumor is very big. In big tumors, how to do wide local excision? Breast will not be conserved. So wide local excision is not feasible like large tumor. It is 6-7 centimeters. The breast is small. Multiple tumors, multicentric tumors, diffuse tumors. In these times or in these scenarios, it's not possible to do wide local excision. So these are the simple way to understand where you can't do a BCT. Okay, these are the contraindications to BCT. So where can I do BCT? Normally early breast cancer. Patient with early breast cancer in whom there is no contraindication, I can offer BCT. In LABC, normally I do MRM only. Normally. Fine. Now, what about the axillary lymph nodes? To remove or not to remove? What to do? To remove or not to remove? SLNB, no, that's not the correct answer. Thinking is wrong. Please understand. If lymph nodes are enlarged preoperatively, then what to do? Then remove all axillary nodes. Okay, then remove all. If not enlarged, only then do sentinel lymph node biopsy. आई बात समझ में? SLNB is only done in N0 axilla. It is not no axilla, N0 axilla. There should be no axillary lymph nodes enlargement. Okay, so are you clear? If the lymph nodes are already enlarged, you will do axillary clearance. That is a part of BCT. If they are N0, then you don't know, is there metastasis? Then you do SLNB. What to do in SLNB? You inject some chemicals like methylene blue. Some chemicals you put around the tumor like methylene blue or technetium-99, tagged albumin. It is injected around the tumor, peritumorally. So before I do the wide excision, first I inject these chemicals around the tumor, like you are seeing here. These chemicals will enter the lymphatics of the breast and they will go to the axillary lymph nodes. I take a cut in the axilla, find out which node has become blue or which node has the radioactivity. I find out this node. This is the sentinel node. What will I do with the sentinel node? Okay, node has become blue. What will I do with the blue node? I send it for frozen section. Frozen is like a rapid histology. It comes within half an hour. So I send it for intra-op frozen analysis. Frozen report tells me, is there Mets or no? If lymph node shows Mets, that means person is having axillary metastasis. In that case, you will remove all axillary nodes. So here you will do axillary clearance. However, if Mets are not seen, then what to do? Then just close the axilla. And what will you say? If I just close the axilla, what are the golden words? Close the axilla means job is done. अरे वाह, क्या बात है, खुश कर दिया. इतनी लंबी क्लास के बाद भी खुश कर दिया. Job is done. Nothing needs to be removed. Okay. So what am I trying to say? Here I have a choice. If nodes are not enlarged, I rely on SLNB. If they are enlarged, then sorry, you have to remove the nodes. But if they are not enlarged, I may be able to preserve the axillary nodes. This option was not there in MRM. MRM, it was compulsory. The nodes had to be removed, whether they were enlarged or not. That's the main difference. That's why MRM, the name tells you, it is a modified radical mastectomy. Radical माने remove the nodes, whatever is the state. Fine, आया समझ में? ऐसा करोगे तो एग्जाम में मिस्टेक नहीं होगी. And 3 short topics which someone was saying, sir, please tell this and that and this and that. It will be done. Just relax. Okay, I'm not running away. So first is mastitis and abscess. No, wide excision means remove with some margin. Simple mastectomy means full breast. Lymphadenectomy means the word radical has to come in lymphadenectomy. Okay. Lymphadenectomy means radical word aayega. That word has to be there, or it has to be specified. Okay. Now come to mastitis and breast abscess. It is seen in women who are lactating. The risk factor is cracked nipple. This is a PYQ. So if there are nipple cracks, nipple erosions, they are at high risk of breast abscess or mastitis. What is the agent responsible? It is Staphylococcus. Abscess, if you say anywhere, it is usually going to be Staph aureus. Anything on the skin is Staph aureus. Anything in orthopedics is Staph aureus because it goes from the skin only. So how does the condition begin? The Staphylococcus from the skin enters into the lactiferous ducts. You get the inflammation, that is mastitis. In mastitis, the treatment is antibiotics. However, if it is not treated or the organism is resistant, then you are going to get abscess. Abscess means there is pus. Pus means patient will get high fever. He will get swelling, high fever, painful lump, pus discharge. That means abscess. Fluctuation, yes. Next step will be here you will have to do ultrasound to localize and to quantify. To see, yes, pakka there is abscess, how much pus is there. And if pus is there and it is small amount of pus, less than 30 cc, you aspirate. Okay, you can aspirate multiple times also. Aspirate and give antibiotics. But if it's large volume pus, more than 3 centimeter, in that case, you put this tube. This tube is put under image guidance. This is called a suction catheter drain. It is better than doing IND. Okay, you rather do a suction catheter drain. What type of suction catheter is this? Name of this catheter or name of this device? This is a Romovac. It's a type of a closed suction catheter. Okay, it's a closed suction drain. Okay, Romovac. Any other closed suction drain you know? Any other closed suction drain you know? JP drain, very good. Jackson Pratt. That is also closed suction, correct. So that is breast abscess. Second is Phyllides tumor. Easy condition. What is the origin of Phyllides tumor? From what cells does it come? It is a mixed origin. Means duct also, epithelium and stroma. It can be benign, it can be malignant. Malignancy is if you see more than 10 abnormal mitosis. More than 10 abnormal mitosis in every 10 high power fields. This is something you have to know. 10 or more abnormal mitotic figures in every 10 high power fields under the microscope. How does a person present? Usually it will be elderly female. She will present with a huge lump. Is the lump mobile or fixed? Is the lump mobile or fixed? It is not fixed. There is no fixity. This you can diagnose on core biopsy. You get this typical appearance in core biopsy. You see these cystic spaces. and clefts, cystic spaces and clefts. You understand cleft? Cystic spaces, clefts, leaf-like arrangement. This is called as cystosarcoma filletes. Now, how to treat? What is the treatment? Do I have to do MRM for filletes? Core biopsy is needed. Yeah, how else will you diagnose? The other treatment is going to be excision, wide local excision or simple mastectomy. अभी इतना बड़ा अगर ट्यूमर है, then you will do simple mastectomy. If it's small, you can do wide excision. Here the margin is not 1 centimeter. Here it is 2 centimeter margin. Anybody can tell why? In breast cancer, you had 1 centimeter margin. Here you are taking 2 centimeter margin. Why? This is not necessarily cancer also. This may be benign. Still the margin is more. This happens in real life. Yes. Mixed origin means arises from epithelial cells and stromal cells. Yeah, because the risk of recurrence is high. That's why you have to take a bigger margin. Okay. And the third easy condition, fibroadenoma. This is also a mixed tumor. Comes from adenomatous components, fibrous components, both. Okay. Presentation, it will be a mobile breast lump. It will be small, painless. And usually it is seen in young women between 15 to 30 years of age. Okay, some of you may even be having it. If smile is small, no. See, in BCT, you have to give radiotherapy. You have to do SLNB. वो सब नहीं करना है इसमें. There is no SLNB here. It is only wide excision. No radiation भी नहीं देना इसमें. Okay, so this is a mobile mass. If you do a biopsy for this, you get this typical arrangement of the cells. This is called as stag-horn arrangement. Okay, this is called stag-horn pattern, like stag-horn calculi. Now the treatment here is you don't have to remove it. You can observe if it's small. See, a lot of people get fibroadenomas. It's quite common. If it's a small 1 or 2 centimeter fibroadenoma and you have it, nothing needs to be done. You can let it be. It's not going to become cancer. But you will do excision or enucleation if it is more than 5 centimeters. What is the name given for more than 5 centimeter fibroadenoma? It is a name given if it's more than 5 centimeter. What is it also called? Very good. It is also called as giant fibroadenoma. Or patient wants it removed for cosmesis. Or if it is showing something suspicious. If it is suspicious, in that case, you will remove it. Okay. Otherwise, not necessary. Okay, not necessary. Radio not a must to give for filletes, only if it's malignant filletes, otherwise not a must. Pain can be a sign, means an indication, yes, but they should not be painful. Why should it be painful? Sus how, sir? Like you do a biopsy and it shows complex features, complex fibroadenoma. That is a sus. So young female, mouse and breast is fibroadenoma. Okay. Fine. Calcification तो होती है उसमें calcification. It's called popcorn calcification, but that does not make it sus. Irregular calcification is a problem. Not a macro popcorn like that is okay. No problem there. Which is the most common thyroid cancer from all of these? Papillary. Overall most common is papillary. Risk factor is prior neck radiation. Okay, prior neck radiation is a risk factor. Hashimoto's thyroiditis is a risk factor. Thyroglossal cyst. These are some of the risk factors. Where does it spread? Normally it spreads to level 6 lymph nodes in the neck. Hematogenous spread is very rare. Diagnosis is on FNAC. You will see Samoma bodies. And you will see orphan anenuclei. Okay, Samoma bodies and orphan anenuclei. Tumor marker here is serum thyroglobulin levels. And treatment is going to be total thyroidectomy. with level 6 clearance. So you will remove level 6 lymph node. Delphian node also has to be removed. If it is less than 1 centimeter, what will you do? Then just do surveillance. Okay, you don't have to remove it, even though it is a cancer. If it's a very small papillary thyroid, nothing will happen. You can let it be. Okay, you can let it be. Second one is follicular. This is the second most common. Follicular is the second most common. Who gets follicular? Someone who has a long-standing goiter. So if the goiter was there for many months or years, it can become follicular thyroid cancer. Where does it spread? This is a PYQ. It spreads to bones. Usually it will go to thoracic vertebra and skull. Okay, thoracic vertebra and skull. And your diagnosis is not on FNAC. Then how to diagnose it? FNAC will not tell you. Biopsy is contraindicated. Then how will you confirm it's a follicular? You have to do frozen section. So it's a frozen section diagnosis, intraoperative. What will you see on frozen section? You are supposed to look for these cancer cells. This is the capsule. They have to cross the capsule. So there should be a capsular or vascular invasion. Like these are the blood vessels. The tumor cells should enter the blood vessels. So there should be a capsular or vascular spread. Only then you will know. And for that, you have to do frozen section. Tumor marker is the same, serum thyroglobulin. And your treatment is total thyroidectomy only. You don't have to remove lymph nodes because here there is no lymph node metastasis. Can follicular cancer have lymph node mets? Is it possible? Yes. How? How? You're all saying yes, like you know something. Tell that. Frozen section we did, right? Yes, we did. How can it go to lymph nodes? Because कुछ भी impossible नहीं है, बकवास ऐसा थोड़ी होता है. ऐसा होता ना तो मैं पूछता क्या? There is one variant which shows lymph node mets. Lymph node mets in I gave you the clue. Which variant of follicular has a lymph node mets? In addition to bone mets. Hertel cell, thank you. कितनी मेहनत कराते हो यार मेरे से. There is a Hertel cell variant. Okay. In that you get both. Lymph, it's more aggressive. The third is not that common, medullary thyroid cancer. It's quite rare. It is seen in MEN2 syndromes. MEN2A, MEN2B. 100% patients will get it. Here it shows metastasis to both. And histologically, it shows amyloid stroma. And what is the tumor marker? What is the tumor marker? It is calcitonin. There are two tumor markers. This calcitonin I have asked in many of the GTs. Calcitonin and CEA. Here the treatment is total thyroidectomy plus level 6 clearance. This is very aggressive. Huh? It's much worse than papillary follicular. Papillary follicular are quite nice. This is a bad cancer. Yeah, RET genius. Gene here is RET. Here papillary, I think the gene is BRAF. I'm not very sure. Huh? Not very sure. Like, I don't know why you expect me to know all the genes. Anaplastic, it is seen in women after 60 years of age. It is very locally aggressive. So the person will die very fast. It will invade into the trachea. Diagnosis, here you do a core biopsy. This is the only scenario where a core biopsy can be done. Okay, to differentiate it from Riedl's thyroiditis. There are no tumor markers. It has a poor prognosis. Okay, these people don't survive for a long time because it invades the trachea, recurrent laryngeal nerve, and the person dies. You can't remove it. Now, one very important point is what you have to tell me. Men 1A नहीं होता, men is only men 1. There is no men 1A. Men 1 is associated with pituitary, pancreas, and parathyroid tumors. Primary hyperparathyroidism. That's the most important one, PPP. So after total thyroidectomy, you have a PTC, papillary thyroid cancer. What should you do next? Very important, you do radioiodine scan. It is done normally 3 to 6 weeks after total thyroidectomy. Okay, 3 to 6 weeks after total thyroidectomy. Why are you doing this? What are you looking for in the radioiodine scan? Very good, to look for METs. So for METs, you will do the scan after 3 to 6 weeks. Means do thyroidectomy, wait for 3 weeks, then you do the iodine scan and you look for METs. If they are present, then you will give iodine 131 high dose. What is that called? High dose. What is that called? It is called ablation, radioactive iodine ablation. That's how you will kill the metastatic tissue. Fine. So this is one very important finding in follow-up of patients of papillary and follicular thyroid cancer. This is only done for papillary and follicular, not for medullary. Only PTC, FTC, not for medullary. Iodine 123 is for diagnostic. For ablation, you give high dose. And then, of course, you should know the complications of total thyroidectomy. Most common nerve injured overall. It is the external laryngeal nerve. What is the effect of injury of external laryngeal nerve? There is loss of pitch of voice. Many times it goes unnoticed. Recurrent laryngeal nerve is dangerous. It should not get injured. Most common site of injury of recurrent laryngeal nerve is when you are dividing the Berry's ligament. During division of Berry's ligament, the nerve can get cut. It can get injured in a triangle called Beer's triangle. These are the two important landmarks you should know where recurrent laryngeal nerve can get injured. Unilateral will cause hoarseness, bilateral will cause stridor, and the stridor will happen immediately on extubation. What will you do? What will you do if this happens? Patient gets stridor when you remove the endotracheal tube. You have to get a front of neck access. Okay, you'll have to get a front of neck access. Second condition is postoperative hemorrhage. It is a reactionary hemorrhage. Ligature slipped. Patient was shifted to the room. He coughed, ligature slipped, and he got a hematoma. And this hematoma will compress the trachea and person will get stridor again. But this will happen within a few hours. Okay, not immediately. By definition, 24 hours, but in practice, usually 1 or 2 hours. Definition से reactionary hemorrhage is within 24 hours. But 1-2 घंटे में हो जाता है. So if he starts getting breathless stridor, he starts getting a neck swelling or a neck hematoma, in that case, you have to take him back to OT. Intubate him, remove all the sutures, skin subacute facial sutures, and drain the hematoma. So when you will drain the hematoma, the compression will go. Fine. That is the important part that you need to know. And hypoparathyroidism is overall, remember this is the most common complication overall. So between these three, don't mark nerve injury. Nerve injuries are seen but this is not the most common complication. It is hypoparathyroidism. Why does it happen? गलती से निकालने की वजह से नहीं होता. It's mainly because of ischemia. Because the parathyroids get blood supply from the same artery that supply the inferior poles of the thyroid. Your parathyroids are over here, and the inferior thyroid artery supplies the parathyroids. So when I am doing thyroidectomy, if I ligate this artery over here, then the parathyroids will become ischemic, right? That's why to avoid it, you must always ligate the artery close to the gland. If you ligated it far away, it will become ischemic, and patient will present 2 to 5 days post-op with a perioral tingling, carpopedal spasm. This is NEET PG question. And you will have to check his calcium PTH. If it is low, you will have to give him supplementations. And this supplement will be required long term. Fine. So these are the 3 important complications that you should know. गलती से अगर हाथ में निकाल आ गया, means you removed it and it came in your hand, then where to put it back? Do you put it back here? हाथ में? No, don't put it back here. You put it back in the neck only. Okay. Putting it back here, that is done in parathyroid hyperplasia. Those are diseased parathyroids. There you intentionally removed them and some pieces you kept just for future. This is removing by mistake. So you put it back in the neck. Okay. Fine. Right. IV, no, actually कौन सा देते हैं? If he is symptomatic, you give IV. If he is mildly symptomatic, then you give oral. But if you want quick response, because calcium can affect cardiac hemostasis, you may have to give IV. Depends on the severity of the hypocalcemia. Okay. In my opinion, in your exam, one of these 3 cancers will come. Okay, in my opinion, one of these 3 cancers. Watch out for it. I will mark over here. Okay. So we have these easy cancers. We have done so many cancers. So these cancers don't seem very difficult anymore. First is renal cell carcinoma, seen in elderly smoker males. They will present with painless, profuse hematuria. Okay, they present with painless, profuse hematuria. Sometimes you may be able to feel a flank mass. Mass may be felt. Okay. Rarely there may be flank pain. All these are very late findings. If all these 3 things are there, it is called as too late triad. Okay, it is called as too late triad. What to do first? Thumb rule. Patient comes with hematuria. RFT. No, don't do RFT. You can do it, but that's not how you begin. You do urine routine microscopy and USG of what? किस चीज का USG? Here you don't do USG abdomen, you do USG KUB, kidney, ureter, bladder. Okay. Any person with urinary problems, urine routine, USG KUB. USG KUB will show masses there in the kidney, left or right, one of the 2. How will you confirm the diagnosis? Biopsy? No need for biopsy. It is an imaging diagnosis. You will do CECT, KUB. Okay. It's not that biopsy is contraindicated. It is just that biopsy not required. Okay, which means if I want, I can do biopsy. Do I have to do biopsy? No. Then if I want to look for local spread into IVC, I will do MRI of the IVC. It is called MRI IVC venogram. And for distant mets, PET scan. Fine, so same like other malignancies. X-ray QB is done when you are suspecting stones normally, not for renal masses. Okay. Now come to treatment. Treatment is based on stage. So I have put all the cancer stagings ek ke baad ek only. Means RCC, then prostate, then bladder. So if you are revising, you can just revise from these notes. Okay. Ek ke baad ek hi hai sare uro cancers. GI cancers also I did ek ke baad ek only. So then you don't get fried. Kahan se kare, kaise kare. It's simple. Now you need to know the stage-wise treatment. Now kidney is also not like GIT. Kidney is solid organ. T1A tumor is tumor size up to 4 centimeters. T1B size between 4 to 7 centimeters. T2 more than 7 centimeters. T3 tumor is embolizing into renal vein or IVC, below diaphragm, above diaphragm. So these are the different ways in which the tumor can spread. Remember, these are embolizations. It is not invading. Means these emboli can be removed. You can surgically take it out. T4, breach of Gerota's fascia. Okay, Gerota's fascia is breached. So this is T1, T2, T3, T4. Now tell me, is the treatment gonna be for early? Surgery with chemo, surgery with radio, surgery with both? Surgery with none. Unfortunately, the only treatment is surgery. There is no chemo radio possible. Okay, it is chemo radio resistant. एक ही इलाज है वो है surgery. For T1A tumors, you will do partial nephrectomy. Okay, for T1A, partial nephrectomy. For T1B, you can do partial or radical nephrectomy. You understand radical? Okay, radical means full kidney with lymph nodes. Partial means wide local excision. For T2, no option of partial, only radical. For T3 also, only radical. But something else also has to be done when I do treatment for T3, apart from radical nephrectomy. You also have to remove the emboli, so you'll have to do the embolectomy. So these IVC emboli can be surgically removed. You open the IVC and take it out. Tumor invading Gerota's fascia, you will do palliation. Okay, so simple. So RCC treatment is easy for you to learn. Obviously not easy for the patient because there is no adjuvant modalities. So if it is spread, it's spread. You can't really downstage it. Okay, answer this. The mass is 8/5/3. It is a renal cell carcinoma. What will you do? It will be radical nephrectomy. 8 means it is more than 7 centimeters, means it is T2. Okay, more than 7 becomes T2. Chemo radio doesn't work. Okay, now one easy cancer, that is CA prostate. Which part of the prostate it comes from? It comes from the peripheral zone, the part which is very far away from the prostatic urethra. Because it comes from the peripheral zone, it will not compress the urethra. So because it doesn't compress the urethra, usually the person is going to be asymptomatic. Usually it will be found incidentally, especially in men after 65 years of age. Okay. Yes, BEP, correct. BEP comes from transitional zone, which is just near the urethra. So that's why BEP will compress the urethra. That's why people who get prostatomegaly, they get urinary symptoms. I gave you all those examples, you know, that cinema hall. I gave you that cinema hall example in class. Remember not which queue to go in. Don't go in the wrong queue. Yes, in the airport. So that is benign enlargement, right? So patient present, it will be diagnosed usually incidentally, or if he has meds, and most commonly the meds go to lumbar vertebra. Same via the Bateson's plexus. Okay, lumbar vertebra via the Bateson's plexus. So he may present with backache. Now, how should you diagnose it ideally? First step is going to be you will do PR exam and you will check his PSA levels. On PR exam, you will feel a hard prostate. Okay, you will feel a hard prostate. Serum PSA levels should be elevated. See, if it's a normal person, they are less than 3.5. Here, they should be at least between 3.5 to 10. If it's this much, you should do a biopsy. And if it is more than 10, it means it's an advanced CA prostate. Sorry, it means it's a malignant. More than 10 is likely to be malignant. More than 35 is going to be advanced CA prostate. Fine. So the first step will be rectal exam and PSA levels. If you feel it is a CA prostate, the IOC is going to be a biopsy. So you will do ultrasound, TRUS, transrectal ultrasound with biopsy. How many biopsy pieces do you take? How many biopsy pieces? You should take at least 12 pieces because you want to calculate the Gleason score. So for that, you need so many pieces. For local spread, you will do MRI. And for distant, you will do PET scan. And then you get the TNM stage. Fine. So that part is easy. Same kind of investigation are also done for bladder cancer. MRI and PET scan only. Now the interesting part is the treatment. And this is also stage-wise treatment. So if it's a T1 tumor, T1 means it is found by chance, incidental. T2 means limited to prostate. Only for T1, T2, you have a possibility for cure where you will do radical prostatectomy. How radical prostatectomy is done nowadays? So for T1, T2, you do radical. Very good. Nowadays, it is done as robotic. Very commonly done nowadays. It is done robotic. So you do radical prostatectomy, then you give chemotherapy. For T3, T4, normally you don't go for cure, you go for androgen ablation. Because it's a testosterone dependent tumor. So you can give anti-testosterone drugs. Like you can give GnRH, like goserelin or leuprolide. Or you can give flutamide, bicalutamide, the receptor blockers. So these can be used if I am having an advanced CA prostate. But there is one exception to this rule. That is this, our favorite exception. Very old patient with a good Gleason score, with a very early CA prostate, will not agree for radical prostatectomy. In this person, you will offer him a surveillance. So imagine you are doing surveillance for a cancer. Which other cancer did we do surveillance for today? One more cancer we did. Papillary thyroid cancer less than 1 centimeter. That's because it was a good cancer. Here we are doing surveillance because this treatment is too much for such a small cancer. Okay, it is too much. नहीं कीमो तो देना ही है, रेडिकल के साथ कीमो भी देंगे. ओके, आई बात समझ लो. Fine. Now come to bladder tumors. They are not very tough. What type of bladder tumors are seen normally? They are the transitional cell carcinomas, TCC. Okay, transitional cell carcinoma. It is the only cancer we have studied in surgery which is occupational because of exposure to certain chemical carcinogens, certain dyes. People who work in textile factories, right? Aniline dyes are known. So how will bladder cancer patient present? Like RCC, elderly smoker male with a profuse hematuria. Tumor will bleed, he will get a lot of hematuria. What do you do first? First step, first check his urine and do USG KUB. USG will show there is a mass in the bladder. How do you confirm the mass is a malignancy? IOC. Here you do biopsy. Okay, cystoscopy with biopsy. Like you are seeing here. So you saw the mass. If possible, you can remove the full mass. You can do an excision biopsy. That is ideal. RM is routine microscopy. For local spread, you will do MRI. Distance spread, you will do PET scan. Okay. Routine and microscopy ऐसे ही लिखते हैं. When you prescribe it, you always write it like this only. Urine, routine microscopy. Routine is gross examination, where you look at the color, specific gravity, all those things. Microscopy is, so two samples go to two different people, pathologists and biochemists. Okay. ऐसे ऐसे सवाल आते हैं ना आप लोगों के, मुझे कभी कभी विश्वास नहीं होता that A, why are you asking these questions, and B, why do you expect me to know these things? अरे एकदम अर्जेंट मैं हर बार भेजता हूँ यार. whenever I finish I send it एकदम urgent, like even before I shut my laptop or even before I look at my mobile, I first send the PDF first, उसी टाइम पे. Okay, then I don't know why they don't give it in your giraft, why they keep it with them. Do they put anything in the PDF? Like do they put some watermark or something? कुछ भी नहीं. बराबर से देखो, होगा कहीं कोने में सेरिबेलम छुपा हुआ होगा. कुछ नहीं. नहीं नहीं, कुछ डालते होंगे यार. देयर मस्ट बी सम रीजन. दे मस्ट बी पुटिंग सम watermark. That's why they take time. Okay, anyways, come back. Enough of gupchup. There is still work to do. After Euro, we have little general surgery also. So, how do you treat bladder tumor? If it's a only mucosa, TA, or mucosa with lamina propria, T1 tumor. कि कुछ गाली वाली लिखा है क्या मैंने इसलिए? दे गो थ्रू द PDF और कि मैंने गाली तो नहीं लिखी हो. No, anyways, if it's an early bladder cancer, this is called as non-muscle invasive bladder cancer. NMI means non-muscle invasive bladder cancer. Here the treatment is going to be cystoscopic excision. So here you do cystoscopic removal, which is also known as TURBT, transurethral resection of bladder tumor, TURBT. And here the treatment is quite unique. After doing this transurethral resection, they gave chemotherapy in the bladder. That is called as intravesical chemotherapy. Okay, they give intravesical chemo, also called as contact chemotherapy. And the drugs that they use are mitomycin or your favorite BCG. BCG with the vaccine. It is put in the bladder. Okay, please remember this is only used for T1 tumors, not for T2, T3. T2, T3 you do radical cystectomy. And when you do radical cystectomy, there is one problem. How will you mixture it? So what to do after radical cystectomy? How does he mixture it? Vaccine has an immunological effect. It will call the T cells, they will eat the cancer cells. You do this. This is called as ileal conduit. Okay, so the treatment of bladder cancer, which is muscle invading, is radical cystectomy with ileal conduit. And then you give chemotherapy. And if it is invading adjacent organs, you give neoadjuvant chemo, then do surgery. Okay, so it's similar to GI cancers only. The only additional thing is this part. This was not something we had in GI cancers. Here, because you have access to bladder, you can give the chemotherapy directly in the bladder, right? Contact chemotherapy. A contact chemotherapy हमने कहीं भी नहीं use करा. Okay, so this is how you will treat bladder cancer. Quite simple. Now you can answer this. So patient is having metastatic CA prostate. What drug is used? Gocirelin. Okay. Alternative to gocirelin, leuprolide, flutamide, bicalutamide. These are the androgen ablation drugs. Okay. This is one of the favorite cancers for exam. Favorite. For some reason, they love this. That's why I told you the three cancers, one of them is CA testis. Now, who gets CA testis? Who gets CA testis? This is seen in young males. Okay, young like you and me. Okay, this is seen in young males, usually in 20s and 30s. Unlike all the other cancers that you studied, which were in elderly smoker males. And yeah, undescended testis is a risk factor. Hematogenously, it will spread to lungs. Like RCC, you will get bilateral cannonball mets. But seminoma, which is the most common one, will go to lymph nodes. That is seminoma. And it goes to lymph nodes which are in the abdomen, para-aortic. So testicular cancer goes to para-aortic lymph nodes, abdominal nodes. It doesn't involve inguinal nodes unless when will CA testes go to inguinal nodes? When will it go to inguinal? It does not go normally unless spread to scrotum. Very good. जो लोग लिख रहे हैं चैट में बहुत अच्छा. Unless it has spread to scrotum. Only when it goes to scrotum, from scrotum it can go to inguinal. Otherwise, it won't go to inguinal. Which is why don't do biopsy or FNAC. Okay, in CA testis, don't do FNAC or biopsy. Because it can go to scrotum, from scrotum it can go to inguinal nodes, right? So how to diagnose it? If someone is having a testicular mass, you do USG of the testis and you do tumor markers. Okay, you do USG and you do tumor markers. Like you should at least know the names: alpha fetoprotein, beta HCG, LDH. But none of them are specific for seminoma. So if you're suspecting and you can't do a biopsy, how to diagnose a CA testis and treat it? The next step is going to be you do a inguinal exploration. Imagine you are going to the testes, not from the scrotum. You are going to the testes from the inguinal route. You can see here, he's made a cut on the inguinal area. What is this thing? What is that thing to which the testis is attached? This vas नहीं, don't say vas, epididymis, no. Spermatic cord, okay, जिसके अंदर vas होती है, testicular artery होती है, all those things are inside it. Okay, so don't say vas. Vas is one of the components. So what I do is I pull the spermatic cord and deliver the testis. And I see, is there any tumor? If I want, I can take a biopsy also. So I do inguinal exploration. And if needed, plus minus frozen section. So here also I can do frozen section. That frozen section is called Chevasu technique. And then if it comes out to be malignant, I will do a high inguinal orchidectomy. Okay, so the diagnostic test is actually also a part of the treatment. It is a high inguinal orchidectomy. I am not doing biopsy. I am doing inguinal surgery. Imagine instead of eating food like this, you are eating food like this. You are actually doing that. Think of it like that. You are not going direct because you don't want to touch the scrotum. So you go from the inguinal area, pull the spermatic cord, see the testis, and then do the orchidectomy. So it's an inguinal orchidectomy. This is the only scenario where you are intentionally doing an inguinal orchidectomy. Intentionally. Fine. So these are the 4 malignancies you must know from urology. Now we go to the benign conditions. First, we talk about treatment of renal stones. ESWL. What is the L in ESWL? Extracorporeal shock wave lithotripsy. Okay, it is lithotripsy, where shock waves will break the stone. Okay, they only break the stone. So if the stone is very big, it can't be broken. Lithotripsy will be used for stones between 5 millimeters to 20 millimeters. Big stones, you can't do lithotripsy. They should be soft stones. So where can I not do lithotripsy? Stones more than 20 millimeters. Stones which are hard. Example of hard stone is cystine stone. Cystine will not break. Stone in the lower calyx. It will get stuck. It will not come down. And the most important contraindication is pregnancy. Because the waves can harm the fetus. Right? So these are, it's not really a surgery. The stone will be broken by the waves. But in today's day and age, it's not a preferred treatment. There are many contraindications. And the complication is higher risk of infections. Because the stones have bacteria sitting on them. So when you break the stone, the bacteria will get displaced and they will enter your blood. So in today's day and age, lithotripsy is not something that is preferred. What is preferred is always going to be PCNL, percutaneous nephrolithotomy. Okay, otomy means to cut and remove. So you're going to cut open and remove the stone. You are not just breaking it. So this is a proper surgery. It's a minimal invasive surgery where you pass a catheter guide wire, you pass the nephroscope into the kidney, see the stone and remove the stone. So it's a proper surgery. You break it and remove it surgically. So this can be used anywhere. Normally we will use it for stones which are more than 20 millimeters or 2 centimeters. It can be used for hard stones. Wherever I can't use ESWL, it can be used for lower callicial stones, big stones, or even staghorn stones. Everywhere I will use PCNL. So wherever I don't know what to do, I can do PCNL. What is the main contraindication? Pregnancy. So pregnancy mein I can do neither ESWL nor PCNL. Here the main complication is hemorrhage, because I have to puncture the kidney to go into the pelvis and remove the stone, right? Which is why a very popular technique is endourology, endoscopic removal, like RIRS, retrograde intrarenal surgery, URS, ureterorenoscopy. This can be done for ureteric stones. So PYQ, treatment of ureteric stone, it is URS, ureterorenoscopy. And small renal stones, means stones less than 20 millimeters with pregnancy or horseshoe kidney or obesity, means wherever it is difficult to do PCNL, I will use URS or RIRS. It does not have any proper contraindications. No, nothing really. HSK is horseshoe kidney. And complications, there can be ureteric perforation. That is one complication you should be aware of. right? So, no. More than 20 millimeters in pregnancy can do nothing. You wait. Let the baby be delivered, then you do the PCNL. Okay. Steinstrass is a complication of ESWL, street of stones. If you do ESWL on a very big stone, the fragments will be very big. So they will block the ureter. That is Steinstrass. Okay. So more than 20 millimeters, PCNL, less than 20 millimeters, either do RIRS or ESWL. Think of it like that, you will get the answer. इतना ही सोचो, आंसर आ जाएगा. Now come to urinary TB. Most common site in urinary tract where you get TB, it's going to be the kidney. But you must be knowing, from kidney, it will go and spread into the full urinary tract. From kidney, it will go to ureter, to bladder, to urethra, prostate, other ureter. So it full urinary tract, it will eat up. Which is why first site is kidney. How does it reach the kidney? It will be a secondary TB. Okay, secondary, it will be hematogenous. So first site is going to be glomerular vessels. Now, when it will reach the glomeruli, if the person has a good immunity, it will just form granulomas, which look like stones, which is known as pseudocalculi, if he has a good immunity. But if he does not have a good immunity, then it will start destroying the full kidney step by step. Like first, what will happen is it will form ulcers. Then it will form cavities, caseous, putty kidney, cement kidney. You can see this is putty kidney. Okay, the full kidney has become replaced by caseation. This is putty, pasty. From there, it will go to the ureter. It will cause kinking of the ureter, pipe stem ureter, corkscrew ureter. You can see all these changes. Then from the ureter, it will keep going further down into the bladder. In the bladder, it will cause gallfold orifice, small contracted or thimble bladder. So you can see, ek karke, it has destroyed the entire kidney, ureter, and the bladder, one after another. And unfortunately, patient will get the symptoms when the bladder is affected. Okay, till then patient did not even realize. So the first clinical feature is increased urinary frequency because of a thimble bladder. And by then imagine how much the bacteria has destroyed. Moth eaten is seen here only, yes, on imaging. Moth eaten appearance, it is written over here. Fuzzy calyx, moth eaten calyx. First appearance on IVP. So it has slowly destroyed the full kidney and gone into the bladder. Person presents with urinary frequency. What will you do? You will check his urine. What does urine show? Typically, urine shows pus cells, but no bacteria. This is called as sterile pyuria. Whenever you see sterile pyuria, what should you do? What should you do if you see sterile pyuria? CB night of what? किस चीज का CB night you will do? किस चीज का? ZN stain. Don't do ZN stain. ZN stain is only for sputum. You are going, whenever you see sterile pyuria, you will do 3 consecutive early morning urine samples. I'm writing short form EMSU. 3 consecutive early morning samples of urine. Send that for CB net. Okay, and you can also send it for culture. That's how you confirm urinary TB. So the sample can be urine. If you're doing any excision, you're removing the kidney, you can send that also as sample. But if you're doing urine, it has to be 3 consecutive. Like how sputum, we take 2 sputum samples. Urine, you have to take 3 samples because it's difficult to isolate the bacteria. What is the first image? What do you see here? What is the image? Not the diagnosis. No, don't diagnose it. Image. This is a plain X-ray KUB. Second image is an intravenous urogram. Okay. How do you know it is X-ray? You just see some calcifications here. Probably it's a putty kidney. Why it is not intravenous? You don't see the other kidney. You don't see the ureters. You don't see the bladder. Nothing is seen. That means it's not contrast. Compare it with the other. You can see both the ureters. You can see the bladder. This is IVU and it is showing a thimble bladder. Okay, it's a small contracted thimble bladder. Right. So that's how you come to know the difference between X-ray KUB and an intravenous urogram. MCV क्या होता है? कैसे डीडी करेंगे? What is MCV? गाली तो नहीं है ना? MCV. Okay, answer this. नहीं सर. MCV क्या है? No, see, in MCU, you will see bladder and urethra. यहाँ कौन सा bladder and urethra दिख रहा है? यहाँ तो सिर्फ bladder और ureter दिख रहा है. If you see urethra, then it could be micturating. And normally na MCU, if I want to see urethra, I take a lateral film. वो posterolateral wall में करते हैं, correct. Where you see bladder and urethra, you look at what you are seeing. If you are seeing bladder urethra, it is cystourethrogram. Patient is diagnosed with bladder cancer extended up to muscle, means it is T2. What will be the treatment? Radical cystectomy. Please remember, intravesical BCG is for T1. Okay, it's not for T2. Right? And we'll summarize these three simple topics in urology. Undescended is testis in the normal path of descent. Most common site of undescended testis. Answer: high scrotum or upper scrotum followed by inguinal. You can see over here. High scrotal, inguinal. Most common site of ectopic. Ectopic means not in the normal path. It is superficial, inguinal, pouch. Okay. If you replace pouch by ring, it becomes undescended. Here the word is pouch. Pouch is not normal. Pouch is formed outside. That is going to be ectopic. There is risk of seminoma, infertility, and indirect hernias. Okay, indirect hernia, congenital indirect hernia. When should you operate if it is diagnosed at birth? When should you operate? You wait for 3 to 4 months. Ideally, you should operate at 6 months. 6 to 12 months is okay. But you don't operate before you wait for 3-4 months. It may spontaneously descend. How to localize where it is there, where the undescended testis is, it is not in the scrotum. How to localize? First do clinical evaluation, then do imaging. And if you still don't find it, then do surgery. Surgery is the gold standard. Okay, gold standard to localize is going to be surgery. Fine, imaging can be ultrasound or CT. But if you still can't find it, do diagnostic laparoscopy. Second is varicocele, easy condition. It is a dilated pampniform plexus of veins in the testis, much more common on the left than the right. Clinically, you get a bag of worms feel. So when you palpate over here, you get a bag of worms-like sensation. How do you confirm the diagnosis? It is, you get a dragging discomfort. It's not really painful. You get some dragging sensation. It may be associated with infertility. Maybe. How do you diagnose it? You do testicular venous Doppler. And what is the treatment? This is where you will make a mistake. What is the treatment? TSD. So first is, if it's low grade, minimal, then do nothing. Then just do observe. Low grade, you don't have to treat. Just do observation. If it is causing some problem, the first line treatment is percutaneous embolization. What does this resemble? Anything else? We have done percutaneous embolization. What does it resemble? Embolizing the testicular vein means what? Varicose. Name of the treatment, which resembles this. Yeah, it's like sclerotherapy. Very much like sclerotherapy. Similar. You inject a chemical in the testicular vein, but if it is large or if it is recurrent, you will have to do excision. That is called varicocelectomy. Okay, that is a treatment for large varicoceles. Varicocelectomy. Fine. So that is varicocele, dilated testicular veins. Last is torsion. Easy disease. Okay, that is torsion. Hydrocele and spermatocele. Hydrocele will surround the testis. You can't feel the testis in a hydrocele. You only feel the fluid around the testis. How do you know it's low grade? It was found by chance on Doppler. Patient did not have dilated veins that you can feel. Spermatocele will be light में चमकेगा. It is transilluminant, but it's small. It is not around the testis. Okay. Correct. Now, what is torsion? The testis gets twisted. Okay. And because of the twist, you can see here, it will become ischemic. Most common reason for it undergoing this twist is a condition called high investment of tunica vaginalis. What is it also known as? AKA, also known as, very good, clapper in bell. It is also called as clapper in bell, like a ghanti. So the testis is hanging freely in the tunica vaginalis and it is at risk of torsion like this. Okay, clapper and bell deformity. Now you are happy. Suddenly from GCS intubate, you have become GCS moderate head injury. टन 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 टन. चोट लगने पे इतना पेनफुल क्यों होता है? $1 million क्वेश्चन है. इट्स नॉट रिलेटेड टू टॉर्शन. ओके. अभी तो पीडियाट्रिक बोन्स आना बाकी है. क्या? Pediatric bones is still there. Then I will just skip that word and say Browder charts. No. Browder charts. Okay, and don't look at my face. Look at what I'm writing when the charts come. Anyways, so all these three conditions, undescended testes is found at birth, ideally. Varicocele and torsion will present in teenagers. So the teenager will present with acute testicular pain, which worsens on lifting the testis. What is this called? This is Prain's test. Prain's test, positive or negative? If the pain gets worse, this is Prain's test negative. Okay. Prain's positive is the pain reducing. That is seen in epididymoarchitis. Originally, the test is for epididymoarchitis. Okay, it's ulta. ये तो हमने extrapolate किया है that okay, it also tells me about torsion. If doubt, I will do testicular Doppler, arterial Doppler. This is PYQ. This was asked in last FMGE exam. Child with acute testicular pain with absent cremasteric reflex. What is the next step? Answer was testicular Doppler. When should you untwist it ideally? Ideally, when should you untwist it? Ideally, it should be untwisted within 6 hours. Okay, ideally. And remember, after untwisting, if it's okay, you do orchidopexy. And always do both sides, contralateral orchidopexy also. मतलब दोनों तरफ करना orchidopexy on the affected side as well as the normal side. Okay. on the affected side as well as on the normal side. Always, because this clapper and bell will be there bilaterally. Today he got right torsion. After a few weeks, he can get left torsion. If you want to see testicular artery, you will do arterial Doppler. In varicocele, it is venous Doppler. Here it will be arterial Doppler. Means that is common sense. Don't have to spell it out. Okay. No need to spell it out. Varicose veins don't do arterial Doppler unless you want to get a cut from the radiologist. No. Epididymo-orchitis means inflammation of the epididymis. Hydrocele is fluid around the testis. They are completely different. Okay. Answer this. Testis transplant. Transplant or implant? Are you saying transplant the testis or implant? Transplant means donate from a living or a dead donor. There are implants, means if you had orchidectomy, you can put artificial implants. That is there. वो होता है. It's not very uncommon. Can do. There are implants after orchidectomy. Don't say उससे fertility improve होगी क्या? They are not functional implants. They are only for cosmesis. They are not functional. Cosmetic implants होते हैं. Anyways, his left scrotal sac is empty. Left testis is in the superficial inguinal pouch. If you see the word pouch, then it is ectopic. If I replace the word pouch with ring, it becomes undescended. Okay? ट्रांसप्लांट में स्पर्म किसका होगा? ज्यादा नहीं बाकी है, खाली जनरल सर्जरी तो है. आधा घंटा और लगेगा. नॉट मच. ठीक है, go to the washroom and come. We'll finish by 6. 6:10. You'll have time for your derma. Don't worry. Take 2 minutes break. 2-3 minutes में come back. Hello guys. लैब 1 का नोट्स रिवाइज करेंगे तो अच्छा है ना. मीन्स यू स्पेंड सो मच एफर्ट इन डूइंग लैब 1, देन व्हाई डू यू वांट टू नॉट यूज इट. ओके, चलो बढ़ते हैं आगे. नो, वी विल नॉट हैव टू rush through anything. We'll go the way we have been going. There is no rushing. And see, I have structured the class in such a way that towards the fag end the topics get easier. It's not harder. So Euro ke easy topics we just finished. These are the easy ones. We did the cancers first. Cancers are a little heavier, है ना? So general surgery is halka pulka. It won't trouble you. Okay, right? Chalo. Now come to first vascular, where there will be occlusion or narrowing in any artery except coronary arteries or cerebral arteries. Means anything that you study in medicine, वो छोड़ के, if any other artery is affected, it will be called as peripheral. And the most common cause of peripheral is atherosclerosis. And atherosclerosis is a diffuse disease. It will not affect single artery. It will affect multiple arteries. Which artery does it affect most commonly? Most common artery affected in atherosclerosis in PVD. In PVD, yeah? No, which is lower limb? Hmm. Which artery in lower limb? It is superficial femoral. Okay, this artery is most commonly affected in atherosclerosis, almost 70% cases. Another cause of lower limb PVD is Burgess disease. This is seen in young smoker males, young like you. Okay, not like me. Young means below 35 years. Smokers, males. Okay, so all of the above apply to you. And the thing is, it will typically cause occlusion of the small arteries, distal to popliteal, means chote wale arteries. So you know what you should do every time you smoke? One of my teacher used to do this. Every time he used to smoke, with one hand he would have the cigarette, with the other he would be palpating his dorsalis pedis. He was like, the day my dorsalis pedis becomes impalpable, I will stop smoking. So it is distal to popliteal. Yes, Arpit knows JJ Hospital, correct. That person is still alive, by the way. No, he's still alive, yes. I don't know about his ischemic heart disease and all, but lower limb it's in place. Hmm. It's not very common in females. It is usually seen in males, usually. It is related something to do with the smoking. Now, when you get a PVD, the first symptom that you get is intermittent claudication. It's the pain that occurs on walking some distance, not on taking the first step, some distance of walking. And it will be relieved within a few minutes. It's a cramping type of pain. It will be relieved within few minutes. Right? Not more than 5 minutes. It should be less than 5 minutes. If it's more than 5 minutes, it is unlikely to be ischemic pain. As the disease will become more and more severe, the person starts getting the complications, like he will start getting rest pain. Why do you get rest pain? Why do you get rest pain? It is the cry of dying nerves. Okay, it is the cry of the dying nerves. Nerves are becoming ischemic. Then you start getting ulcers, ischemic ulcers, and then you will start getting gangrene. And the gangrene that you get in this image, this is a dry gangrene because it contains line of demarcation. The part appears dry, shriveled. So whenever there is an acute gangrene, it is a wet gangrene. Whenever there is a chronic gangrene with this demarcation, it will be dry gangrene. Okay, remember this. Dry gangrene is always chronic. Like PVD, it's a chronic disease. right? So this is how the disease will manifest. These are some of the findings. Then you should know this. This is a PYQ, that a patient presents with pain in the calf, which is relieved by rest. What is the Boyd's grading? So it's quite simple. In grade 1, he gets pain, but when he continues to walk, the pain goes away. So he walks, he gets pain. When he continues, the pain goes away. How can the pain go away? It is because there is release of local vasodilators. They take care of the ischemia. Local vasodilatory effect. In Boyd's grade 2, he walks, he gets pain. The pain doesn't disappear, but it is bearable. So he walks with a limp. In grade 3, the pain is unbearable. He is compelled to take rest. And there is no grade 4. Rest pain is a different category. Okay, there are only 3 grades. Some books give 4 grades, but Boyd's did not give 4 grades. There are 3 grades only. So here it is relieved by rest only, which means it is grade 3. Fine. And if I ask you what is the next step, what is the answer? Next step. Next step is going to be arterial Doppler. And based on the Doppler, you will determine the treatment. Okay, so next step is going to be arterial Doppler. Fine. Answer this. Similar image was asked in the recent FMGE exam. They did not ask the C, but they asked what is affected. So patient presents with health checkup. He is diagnosed with asymptomatic varicose veins. What category does it fall in? Bearable pain is grade 2. If he has to stop, it is grade 3. So what is this? Which vein is affected? This is great saphenous vein, which is dilated. So this is dilated great saphenous vein varicosity, which is on the medial aspect. But how will you categorize it? This is going to be, if there are only varicose veins, it is C2. And if it is asymptomatic, it is C2A. Okay, there is no C2B. So I'll show you the CEAP classification. In a C1, you get precursors. Telangiectasia, which is less than 1 millimeter. Reticular varices, which is between 1 to 2.9 millimeters. Varicose veins are more than or equal to 3 millimeters. Asymptomatic A, symptomatic S, recurrent R. Then you start getting edema, that is C3. Then you start getting skin changes, that is C4. In C4, there is C4A, eczema or pigmentation, like you can see here. This is eczema. This is C4A. But if you get lipodermal sclerosis or atrophy blanchi, blanchi is a white patch, that is 4B. If you see corona, crown-like arrangement of veins, it is C4C. So what will be the C stage of this? What will be the C stage? So eczema is 4A, phlebitis is 4C. You will call it C4C. Okay, don't say 4A bhi to hai. You remember the example. You are an MBBS, you are also 12th pass. So you call yourself an MBBS, not a 12th pass. Okay, so that is eczema. Then C5 is healed ulcer, C6 is active ulcer. Now don't reverse this. A lot of people say active ulcer comes before healed ulcer. It is talking about the aggression of the disease. So if I see this, this will be venous ulcer, this will be C6. Okay, don't say C5. How do you know it's a venous ulcer? The location, it is at the medial malleolus, that is called as Gator's area. Okay, the location, medial malleolus or Gator's area. Second thing is, it's a shallow ulcer. Okay, it is shallow, it is painless, it has sloping edges. And the third thing is, what do you see around the ulcer? What are all these white things? That is eczema. So you are seeing other findings of varicosity, like eczema or pigmentation. So you know it is a varicose ulcer or a venous ulcer. If I ask you what is the next step, What is the next step? Patient comes with dilated veins or varicose veins. You will do venous Doppler. Again, I will specify venous. Otherwise, you would have done arterial Doppler. So I'll do venous Doppler. And the treatment, I can do conservative management, but there are some surgical treatments, at least you should be able to identify. This is my favorite one. This is endovenous laser ablation, EVLA, in which the laser is put in the great saphenous vein and the vein is burnt. And the second one, what you are seeing, this is foam sclerotherapy, in which a sclerosant is mixed with air and put in the vein. So the vein will undergo sclerosis. This is given by Tessari. Okay, this is a Tessari technique. Okay, this is Tessari technique of foam sclerotherapy. Right. Now in oral malignancies, the topic that they always ask in the exam are the neck dissections. So after I have removed the oral cancer, when I want to remove the nodes that are removed are given in some order. That is 1, 2, 3, 4, 5. 1A, 1B, 2, 3, 4, and 5. These are the nodes which are normally removed. So what all is removed? The types of neck dissection, the first one, the OG. That is the radical neck dissection, where he said, remove nodes levels 1 to 5. Remove the submandibular gland, tail of parotid, means these structures. This is submandibular and little bit of parotid. Remove that, as well as remove the sternocleidomastoid muscle, spinal accessory nerve, internal jugular vein. The other things also have to be removed. So imagine SCM is removed, so your neck shape will go. Spinal accessory nerve is removed, so shoulder function will go. This is the OG, the radical neck dissection. Obviously, they realized itna kaun karega. It's not so much is needed. Now what is done is modified. MRND means first part is the same. 1 to 5 level of nodes, submandibular gland, tail of parotid, but the last three structures are spared. This is what they ask in the MCQ. Structures which are preserved: sternocleidomastoid, spinal accessory nerve, internal jugular vein. Between these three, which structure is always preserved in MRND? If I tell you one has to be always preserved, because there are subtypes. No, it's not IJV. It is spinal accessory nerve. Always preserve. Because there are subtypes of MRND, type 1, type 2, type 3, old words, but spinal accessory nerve is preserved in all the types. If I do anything less, it is called a selective neck dissection, where I have removed nodes less than MRND, means there are types. Supraomohyoid, this is omohyoid muscle. This muscle you see here, it is omohyoid. I remove nodes above the omohyoid. That is nodes 1, 2, 3. That is called supraomohyoid. Or if I remove nodes 2, 3, and 4, that is called as lateral neck dissection. If you feel this is too much, at least remember supraomohyoid. Because ye karte hain. At least this level 1, 2, 3 are removed. It's not too hard. Now come to TPN, one of our favorite topics. When will I prefer TPN? Remember, it is the last resort. I don't like to use TPN if I can give enteral nutrition. So I will give TPN if GIT is diseased for more than 5 days. Means it is not available. Example, short bowel syndrome. Abhi GIT hai hi nahi. Short bowel is there. Too much bowel has been resected. Or ileus is there for a long time. Or person is having enterocutaneous fistula, which I have to operate. So scenarios where GIT is diseased, I will do TPN. Burns, I don't need to do TPN. Burns, I can give enteral nutrition. Now, how to give TPN? Most commonly used vein is IJV, but the best vein is subclavian vein. And remember, it is total. Total means it contains everything. You can see here, it contains lipids also, amino acid also, glucose also. Okay, so it will contain everything. Corrosive injury, I can do jejunostomy, na? I can give jejunal feeds in corrosive injury, right? So it contains everything. Of course, it does not contain fiber, goes without saying. But the problem is it is very cumbersome. Like when I give it from a neck vein, each vein will last for maybe 5 to 7 days. The neckline, the line that I put, will last for maybe 5 to 7 days. So if I have to use it for 1 month, I will have to put in 4 different places. First right IJV, left IJV, then femoral vein, other femoral vein, subclavian. You have to keep changing the sites if it is for long term. So it's very cumbersome. Most common complication overall is line sepsis, catheter line sepsis. Most common nutritional problem are deficiencies. Most common nutritional problems, you get zinc deficiency and you can get hyperglycemia. A diabetic patient, if you give him TPN, his sugars will shoot up. Right? So these are some of the problems linked with the TPN. Overall, it is catheter line sepsis. And then that favorite re-feeding syndrome that they always ask in the exam, where a person who was starving for a long time suddenly is given nutrition, all his electrolytes will get used up, so he will get hypophosphatemia. This is the most important. Hypomagnesemia, all hypos, hypocalcemia, and hypokalemia. It is because the electrolytes suddenly get used up. Yes, pollution fasting wala story, correct. Which is why always, if you want to avoid it, always do gradual feeding. Always start gradual feeding. If the person is prolonged starvation, fine, always start gradually, right? So this is about TPN, one of the favorite topics. Now come to knots, sutures. Few things I will give you about this knotting and suturing so that you are at least able to identify it. Because these kind of questions, if you get it wrong, now it's quite a crime. Hai. It's criminal to make a mistake in general surgery. You make mistake in GIT, I understand. Hepatobiliary. Best vein is subclavian. But these kind of questions, making mistake will hurt you. So first understand the knots. It's quite simple. Whenever they give you a knot like this, you should look at the loop. This is a loop and see how the threads are crossing it. Okay, see how the threads are crossing it. Like you can see both the threads are going above. On the other side, if you look at the other loop, both the threads are going below. So either both go above or both go below. If they are going on the same side, it is a square knot. Square knot is also called as reef knot. It is a secure knot. Okay, square knot or reef knot is a secure knot. Now see the other one. There is a loop over here. One thread is going from below, one thread is going from above. Alternate. Ek upar, ek niche. See on the other side also. This is the loop. One is going from above, one is going from below. This is a granny knot. It is an insecure knot. If you ever tie your shoelace, if you wear shoes with laces, the knot that you will tie will be a granny knot. Okay, you can try it out because you have to learn how to tie the secure knot. Automatically, you don't tie it. You have to do it in a certain configuration. So if you tie your shoelace, it will look like a granny knot only. Try it out. Right. And then this one. Now see here, this looks nothing like the other knots. What do you see here? I'll give you the trick. You are seeing 4 loops. You can see there are 4 loops here. If you see 4 loops, it is a surgeon knot. Because this knot is normally going to be made with a needle holder and a thread. You do that and you tie, do that and you tie. So you're not doing it with your hand, you're doing with needle holder. That's how you're getting so many loops. So if you're getting 4 loops, it is a surgeon's knot. Okay, again. Now, when I want to use any suturing, I need to know what materials I can use. So there are two types of suture materials, polyfilament and monofilament. These are the two types in which suture is made. Polyfilament will be multiple threads made into one, like a choti. Monofilament is a single thread. The problem with a polyfilament is bacteria can sit in between the filaments. So risk of infection is high, but they're not very well. Their knots remain very tight. Monofilament is ulta. It's a single thread, so infection risk is not very high, but knotting is poor. Knots become loose. In today's day and age, we prefer monofilament in most places. Okay, most places we use monofilament. Second thing is, for how long will the suture remain in body? It can be absorbable. Absorbable polyfilament, the one name you should know is polygalactin. Also known as common name Meckel. Very good. And remember, this polygalactin can be used anywhere. It is known as the workhorse suture. Okay, it is the workhorse suture. You can use it anywhere. So if you ever go to general surgery and you don't know what suture to use, you can use Vicryl. But in today's day and age, we have reduced the use of Vicryl because we don't use monopolyfilament that much. But it is known as workhorse suture. Non-absorbable polyfilament, the one name you should know is Mersilk. And it is used for drain fixation. Okay, it is used for fixing drains and tubes. If I want to tie it, I tie it with Mersilk. What are better sutures are monofilament. Monofilament absorbable you should know is PDS, polydioxonone or polydioxonone sulfate. This is used in the biliary surgeries and the urinary bladder surgeries. Anybody can tell why? Biliary, bladder, also on bowel. Bowel, though I can use many things, but biliary and bladder I always use PDS. Anybody can tell why? Because these are suture materials which can form stones, right? So if I do any suturing on the bile duct, if the suture does not remain forever, stone formation risk will reduce. If I use a permanent suture, non-absorbable, it will form stones. So here I prefer absorbable sutures. So that stone formation risk is not there. That's why biliary and bladder. Bowel में stone नहीं होता है. So bowel I have just added because it is commonly used, but the logic is applies to biliary and bladder surgeries. Non-absorbable, the one you should know is proline or polypropylene, which is used for vascular repair. It is used in mesh. So vascular surgeries, mesh plasty, that is proline. Fine. इतना basic आना चाहिए. Monofilament is absorbable. Monocryl is absorbable monofilament. It will get absorbed very fast within a matter of few weeks, which is used for subcuticular. That is monocryl. Now, when I have the suture, what are the suturing techniques? This you can tell me by yourself. What is this? What suturing is this? You have entered from here, gone inside, come out from here and tied. Enter, exit, tie, enter, exit, tie. This is simple interrupted. This is PYQ. Okay. This is PYQ, huh? Simple interrupted. You made a mistake in this. This is simple interrupted. The second one, this is continuous. But the continuous is special. You enter from here, all the bites are inside. You don't see any bite. Then you exit from here. This is subcuticular. Subcuticular, continuous. Now see this. You enter from here, go in, come out from here. Same line, enter from here, go in, come out from here. So there are 4 bites, all in the same line. Same thing is this also. 4 bites or in the same line. Whenever there are 4 bites, it is mattress. This is a vertical mattress. Okay, this is vertical mattress. Mattress means there should be 4 bites. 4 bites in the same line, vertical mattress. Both of these. If you see in this one, you enter, exit. So 4 bites form a box. This is a horizontal mattress. So whenever you are seeing any suture, please first see, is it 2 bites or 4 bites? If it's 2 bites, it is simple. If it is 4 bites, it is mattress. Then think about what is the orientation. A box leg orientation is horizontal. Okay, answer. So all will be hypo, nothing will be hyper. All the electrolytes get used up. This is INI-CET PYQ also. They asked what is the mechanism of refeeding syndrome? It is the consumption of the electrolytes causing a relative deficiency. Okay. Now come to burn surface area. If you are doing it in an adult, you will use rule of 9. Now you can be happy, right? You can use rule of 9, where head and neck is 9, full upper limb. Already you are laughing. Full upper limb is 9, full lower limb is 18, front is 18, back is 18, and 1%. You know what that one is. Okay, hello sir, how are you? That 1% is genitalia. If you have burns in patches, you use the hand rule. Okay, where the size of the patient's hand is 1%. And you know how it came. With one hand, you can hold your genitalia, your own genitalia. That's how you got the 1% rule. So if you have patchy burns, you can use that. And in children, you use these charts. Now you are happy. LNB charts or Browder charts. Now the problem with these charts are obviously you can't remember it. At least you should know that what components are changing with age. At least that much you should know, that the face and the head is changing, thighs are changing, and calf or the leg. These are the 3 components which are changing. Other components are fixed. So this can be used in a child. Second is you want to know the depth of the burns. No, foot is not a part. Foot is not changing. Foot is fixed. Only these 3 are changing. Second thing you want to know is the depth. Is it 1st degree, 2nd degree, 3rd degree? 1st degree means epidermal burns. They are going to have this typical appearance like a sunburn. They will be red, they will be dry, they will be painful, and they will heal without scarring. There is no scar formation. They heal within 1 week. Then you have 2nd degree superficial, which are going to look pink and moist, and they show blistering. Of course, they are also going to be painful, and they also heal without scarring, but normally they take a little longer, 2 to 3 weeks. Okay, like this, pink and moist. Please remember, burns that you get at home are these. If you spilled some hot liquid or you touched hot iron, hot plate, you get these burns. Okay, these are domestic burns. 2nd degree deep and 3rd degree burns are more dangerous. 2nd degree deep will appear white and mottled. There'll be fixed staining, like it looks like a dead body, that part. There'll be no pain, some sensations may be there. They will heal by hypertrophic scar. Okay, there will be hypertrophic scarring, excessive scarring. And full thickness burns are the most dangerous. They will happen because of electrocution, or you are caught in a building which caught fire, you could not escape, dowry burns, petrol, those kind of kerosene burns. Those are usually going to be 3rd degree burns. They require a very severe mechanism. They won't happen at home very easily. They will appear black and charred. They have no sensation because the nerves are burnt. They will heal by eschar formation. Very important. Eschar formation happens in full thickness burns. And if the eschar is circumferential, then person is at risk of If it's a circumferential eschar, person is at risk of compartment syndrome. That is called as tourniquet effect. It will constrict like a tourniquet. Okay, that is called as eschar formation. Person is at risk of having a compartment syndrome. Fine. So two things about burns. One is burn surface area. Second is burn depth. Third is the resuscitation, which people keep asking me, and I keep saying the same things. Okay, it's not rocket science. If they don't specify the formula, use ATLS formula. Okay, if they specify, normally they tell Parkland. Parkland said in the first 24 hours, use ringer lactate using the formula 4 into burn surface area into body weight. And split it as half in the 8 hours, remaining half in the remaining 16 hours. So in the first 8 hours, give 50% of your formula. Okay, balance 50% in the remaining 9 to 24 hours. But with Parklands, you may be over resuscitating. So there came a modification by ATLS. They said same thing, use RL only in the first 24 hours, but use half, 2 ml into burn surface area into body weight. Don't include first degree burns. They are excluded from your calculation. And monitor the urine output, keep this target. And if target is not achieved, then what to do? If target is not achieved, then what will you do? Give bolus. Okay, this is FMG PYQ. Give bolus of RL. How much bolus? 10 ml per kg. This was asked in last FMG exam. You have to give one bolus. So for adults, you will give 2 ml per kg. If the child is less than 14 years, then your calculation is 3 ml per kg. If there are electrical burns, your calculation is 4 ml per kg. So they are specifying age and specifying based on mechanism how much fluid you will give in the first 24 hours. That's easy. Now don't make mistake in this. When I was a resident, we used to use Parkland only. I think now they use ATLS. But मेरे टाइम पे था नहीं. मेरे टाइम पे सिर्फ Parkland ही था. Okay, and the last part, plastic surgery. And in plastic surgery, there are two ways of doing plastic. One is using grafts, other is using flaps. So grafts, we should know there are skin grafts, which can be split thickness or full thickness. Where will you use split thickness? If there are large wounds. But the problem with split thickness is it does not look very nice. So contraindication is areas where you need cosmesis. Second is areas where there is infection or areas where there is poor vascularity. Obviously, there you can't put any graft. And it is normally going to be harvested from thigh using these devices like a Humvee knife or a dermatome. You harvest it using Humvee knife, this one, or you can use dermatomes, and then you are going to mesh the graft so that it becomes more stretchable. And then you put it. But remember, whenever you put a split thickness graft, it has to be put on a wound like this. This is a healing or non-healing, this wound on which you have put it. Always put a graft on a healing wound. It should have good vascularity. It should be non-infectious. If you put it on a dirty wound, the graft will be eaten up by your staphylococci. Vascularity should be good. Similarly, now full thickness skin graft, I don't have too much. Okay, it's not available. So it can be used for small wounds. But it is cosmetic. So it can be used typically over face. Face is the side where normally we put full thickness skin graft. Okay, contraindication, large wounds. Because I don't have so much full thickness skin. And obviously infections, poor vascularity, I can't put it. And this is harvested normally from supraclavicular fossa or postauricular. So supraclavicular skin, postauricular skin. Why it is harvested from there? Do we shave the graft? Shave means remove the hair. Yes, you remove the hair. Surgical side से बाल निकालते हैं यार. You take the skin because it matches the face, the contour, the texture of the face. And this is harvested with knife or blade and scissors. No special equipment is needed for this. Fine. And full thickness graft is not going to be meshed. Yeah, you can take from both the thighs, you can take from buttocks, calf से भी ले सकते हैं. कोई हर्ज नहीं है. For split thickness, the donor site is not a big deal. It will heal by itself. But if I have wounds which have poor vascularity, big wounds, deep wounds, in that case, I need flaps. And you should be able to recognize these flaps. This is the first one. A rhomboid shaped defect is filled with a local flap from the side. This is a Limburg flap. It's a type of a transposition flap for pilonidal sinus. Second one over here, you removed a lip cancer and you are replacing it with tissue from the lower lip. This is called Abbey flap. It is also a type of transposition flap. Means either se udhar you are putting the tissue. Then this one, this is Z-plasty, which is used for scar excision. What type of flap is Z-plasty? What type of flap? This is also transposition flap. Okay, so if you don't know the nature of the flap, just say transposition. कुछ घुमा घुमा के कर दिया. And the fourth one, if fingertip was lost, yeah, you can use Z-plasty for cleft lip also. You can very much. Correct? So if fingertip was lost, you can advance the proximal tissue. This is a VY advancement flap. Fine. These are local flaps. But the problem with local flaps is there is only so much tissue you can pull from the side. Oral cancer resection, breast cancer reconstruction. There you need a lot of tissue. There you will use pedicle flaps and free flaps. Like pedicle flap, one you should know. This is deltopectoral flap. It is a cutaneous flap for head and neck reconstruction. And pedicled PMMC, which is the workhorse flap for head and neck. PMMC is pectoralis major myocutaneous. So you take tissue from the chest, put it on the face. Very commonly used flaps. But if I ask you what is the best flap, those are free flaps. Best things in life are free. And free flaps are very hard to use and very hard to reconstruct. They require artery to artery anastomosis. Like you can see this free flap, you take it from the forearm. This is called radial free forearm flap. Or if you need bone also, you can use a free fibula flap. It is a osteomyocutaneous flap. So these are some of the flaps which are used for oral reconstruction that you should know of. For breast reconstruction, the flaps are different. There also your pedicled and free flaps. Like pedicle flaps, important you should know is tram flap, transverse rectus abdominis, myocutaneous flap, this one. This is a pedicle tram. You take tissue from the lower abdomen, skin subcute, little bit of rectus abdominis muscle. Put it on the breast with the pedicle intact. This is your tram, pedicle tram. But ideally, the best flap is DIEP. It is a muscle sparing flap, right? It is a deep inferior epigastric perforator flap. This is the best flap for breast reconstruction, right? And the last slide, that is negative pressure wound therapy, also called as VAC dressing, where on wounds you put this particular dressing, which is attached to a suction machine. And the suction machine will exert a negative pressure of about 125 mm of Hg. And this negative pressure will keep sucking the exudate. It will keep sucking out the bacteria. It will improve vascularity, promote granulation. It will even bring the wound edges closer. But remember, it is used in non-healing wounds. Okay, non-healing wounds, diabetic foot wounds, burst abdomen, those kind of wounds are where you will put a vac. So what will happen when I put this vac dressing for 5-6 days, and then after 5-6 days I remove the vac, the wound starts becoming healthy. And once it becomes healthy, I put a skin graft. Job is done. ठीक है, हो गया काम. So that is what you should know about vac. Cool. अगर फ्री फ्लैप पूछेंगे so it's DIEP या free tram. DIEP is preferred because you are not using any muscles. So it will cause less trauma. Okay, done. Few things you should know going ahead. Please revise only the IMPs properly. Don't venture into new things out of FOMO. Now is not the time for that. Okay, this is not the time for FOMO. This is the time for reinforcement. Okay, I hope surgery is one of the subjects which rescues you and easily pushes you across the line comfortably. And then you can have interviews or meet me in cerebral hum whenever that happens. Hopefully, this is the last time you have to learn from me. And next, you will see me for recall. And then next, if you go into surgical specialties. Cool. Hopefully, this should be the end of your journey for at least for FMG preparation. Hopefully. Okay. All the best. Take care, guys. I will share the PDF with the team. Then you ask them for it. Okay. All the best. Take care. See you. Good night.
Hello students, am I visible and audible? Very good evening, all dear students. So how is your preparation going on? Okay. PDF. So wait a minute, I have just shared it with the team. Okay, the annotated version will be shared after the class. Don't worry. And anyhow, you have watched lab 1, lab 2, and this is lab 3. So, do you really need all these PDFs, right, for annotation? So, definitely it will be shared. But if you want me, I will also drop it in the your group. Not an issue. Okay. And how are these 2 days, 5th and 6th, and also half of the 7th? How was the marathon sessions? How did you feel? So I actually have shared it in the FMG group. You can use that if you want, the unannotated version. Okay, no problem. So till now you have done so much of hard work, only 10 days. So don't worry, you are going to do great. You are going to do great. Just trust in yourself and just continue the preparation. You are going to do awesome. Okay, chalo. So feeling anxious is very normal. If you're not feeling anxious, then it's a big problem. Revise daily only 10 days, okay? 17th is the exam and we are 10 days away from that. So now there is no point in giving GTs and mock. So in those GTs and mock, whatever you did, silly mistakes, try to revise all those silly mistakes. They are very important, right? Read all the options very carefully. These are some last minute tips I'm giving you, and actually image based questions are going to be very simple, and they are the ones which are high scoring for you. So don't miss out on the image based questions, and don't take dermatology light, because derma, along with integration of microbiology, pediatrics, pharmacology, so many questions are coming up to 6 to 12 MCQs you can expect, like not proper dermatology, at least in the form of the integration, right? So a lot of hard work has been done by me to compile all this. Okay, so you can just revise this. You can remember me as Dr. Maddineni Srinivas, DRMSD, MS Dhoni, like, right? And be till the last point of this class, you are going to gain so much of knowledge out of all these important topics. And I always say this to all my students: consider each MCQ as your 150th mark. Then you are going to take each and every MCQ very seriously, right? And these are my groups, you can join them. So this song will sing the next version of this in the cerebral hum event when we meet in live. हम होंगे कामयाब, हम होंगे कामयाब, हम होंगे कामयाब एक दिन, ओहो मन में है विश्वास, पूरा है विश्वास, हम होंगे कामयाब एक दिन. So that day is very near. Don't worry. This invitation you are also going to receive, and you are also going to join. We are going to rock the party. So he, instead of Jan 2025, this was last year. So it will be now Jan 2026, and you are going to be the students who are going to come for this, and we are going to all enjoy. You are going to get lot of goodies while you leave the cerebral hum event, right? It does not matter how slowly you go, as long as you do not stop. So just keep moving these 10 days. I know so many students will get so many doubts: am I worth it, can I do it or not? These things, okay, these type of doubts will be there, right? Chalo. uh, this session, don't expect me to explain all the concepts and all, so that much time won't be there. It is a marathon. Literally, we are going to just go like a rocket. It will be very fast. So just only thing is, you are going to listen to all important points which are most likely to be asked in the examination. All right. So with that quick note, so let us begin the discussion with the basics topic. Yes, everyone is able to hear, listen. Yes, it should be very fast. It should be very fast, right? Chalo, in the emojis, you can write down, and some students are telling that they felt the dermatology to be easy because of my lectures. Thank you so much. By God's blessings and my students' uh, intelligence, I am able to convey the info to all of you. Chalo. So yeah, the first concept is epidermal transit time, skin doubling time, or skin turnover time. Okay, chalo. So what is this? This basically is the time taken for the stratum basal cells to reach the stratum corneum and to get ultimately shed off into the environment, right? And what is the clinical significance of this? The normal duration is on an average it is 8 weeks. But there is one disease which is psoriasis. In this condition, what happens? The time is going to reduce by 1/10. So here it's going to become 4 to 7 days, because of which there's going to be clinically visibility of the scales over the skin. And these scales in the patients of psoriasis, they are described as silvery white scales. So that is the concept behind the scales in psoriasis patients. All right. So that is the one concept. Next, you need to know some cells of the epidermis. What are those cells? So I hope you all know that keratinocytes are the majority of the cells, forming 85 to 90% of the cell population in the epidermis, right? And there are certain non-keratinocytic cells which are very important. There are three of them which you need to know: Langerhans cells, Meckel cells, melanocytes. Okay, so these three we are going to see some important points. So mostly I have put it in a fashion that it is already pre-filled, and we are going to see the important points. Anything relevant, additional points I will tell you, right? So Langerhans cells, I hope you remember, these are the antigen presenting cells which are present in the stratum spinosum, and these are derived from the bone marrow or mesoderm, right? And these Birbeck granules are tennis racket shaped granules which are seen with the help of electron microscope inside the Langerhans cells. Right, so these are the points about Langerhans cells. Next is melanocytes and Merkel cells. So both of them, I hope you remember this Munni ko base pasand hai, the remix song. So base pasand hai Munni ko, MS Merkel cells and melanocytes. So basal, stratum basal is the address of these cells. And what is the melanocytes derived from? NCC, neural crest cells. And what are they going to have? They're going to have melanosomes which are going to produce the melanin pigment. And remember, the precursor for the melanin pigment is, it is tyrosine. How can I remember that? So just remember this black color tire. So that will help you to remember that it is tyrosine which is the precursor for the melanin pigment, right? Next is Merkel cell. So remember, it is ectodermal in origin, right? And it has neurosecretory granules which is going to help in the touch perception. It's basically a mechanoreceptor. It's basically a mechanoreceptor, right? And here you are able to see this is the melanocyte which is present in the stratum basal layer. It is having some dendritic processes. So it is going to supply to the adjacent 36 keratinocytes. So one melanocyte, 36 keratinocytes. What is it called as? What is it called as? It is epidermal melanin unit. So you also try to recall actively or passively by listening to these questions. And in the comments, your chat section, you can put your answer, whatever you remember. Okay, epidermal melanin unit. One melanocyte is going to supply its melanin to 36 keratinocytes. 36 keratinocytes, right? So next is this layer which is going to be the layer which is present below the dermis, which is the hypodermis. Hypodermis, remember, this is also called as the panniculus. And if there is inflammation of this layer, we are going to call it as panniculitis. Panniculitis. So we'll just add this itis. That is inflammation of the hypodermis, right? And just remember, in this layer, there are going to be fat lobules. There is going to be fat lobules. So this is also called as adipose tissue. This is also called as adipose tissue. Right. Next, we are going to see few important terms related to histopathology in skin. Right. So anything related to stratum spinosum, we use this term which is called as acanthosis. We use this term which is called as which is called as acantha. Acantha. So if there is thickening of the stratum spinosum, we call it as acanthosis. If there is, any disturbance because of which there is going to be separation of this keratinocytes from one another, then we are going to call it as acantholysis. And there one disease which you need to remember, which is very, very important clinically, where we are going to see the acantholysis is pemphigus vulgaris. Very good. Clinical significance is pemphigus vulgaris. This is the intraepidermal vesiculobullous disorder in which we can see the acantholysis happening. Can you remember any bacterial infections in which acantholysis can be seen? Yes, you do remember. They are bullous impetigo, and the other one is staphylococcal scarlet skin syndrome. And can you remember any viral infection? Yes, sir, you remember. Yes, HSV and VZV, varicella zoster virus and herpes simplex virus. These are all the conditions which we are going to see the acantholysis, because of which ultimately there is going to be a rounded cell which is going to be produced, which is also called as a Zank cell, because we are observing it with the help of Zank smear. We also call it a Zank cell, right? So some questions, we have already seen this in the lab too. Just a quick brief review of that. Weight of the skin is 4 to 5 kilograms, right? Deepest layer of the epidermis is stratum germinatum, which is also called as a basal layer. Synthesis of keratin mainly takes place in the stratum spinosum layer. Okay, Odland body. So these granules. So this is stratum granulosum in which they are present, right? Stratum lucidum is present in yes, between stratum corneum and granulosum, right? It is not the same actually. The answers are preloaded here. They were written in the lab too. It is preloaded here. Skin turnover time, we have already seen, this is 4 to 7 days, right? And what is this Malpighian layer? The bottom two layers, they are called as stratum Malpighian layer. Principal cells of the epidermis, they are keratinocytes. Yes, very good. The mnemonic is come, let's get sunburned in cerebral hum event, right? That is the order of the layers. Substance common skin, hair and nails, it is a keratin. Langerhans cells are present in stratum spinosum, right? Merkel cells, Munico base pus and the stratum basal layer. Fat, that is adipose tissue, it is present in the hypodermis. It is also called as panicles. Parakeratosis, persistence of the nucleus in the stratum corneum, persistence or presence of the nucleus in stratum corneum. Hyperkeratosis, thickening of the stratum corneum, right? Acanthosis, thickening of the prickle cell layer. Stratum spinosum is also called as prickle cell layer. Acantholysis is separation of the keratinocytes. Diascopy is done for observing the change in color when the pressure is applied with the glass slide, and this will help us to differentiate between the erythema because of blood vessel dilatation or petechiae purpura ecchymosis in which no blanching will be seen. And also this diascopy will also help in identification of the apple jelly nodules. So where do we see the apple jelly nodules? In which disease? In which mycobacterial infection? Yes, very good. It is the lupus vulgaris. Precisely, you should remember it as lupus vulgaris. Okay, which is a type of cutaneous tuberculosis. Absolutely right. Very good. So Zank smear, if we do, what are we going to see? We can see the presence of the acantholysis. Acantholysis can be identified with the help of the Zank smear. And you need to remember two lines, named lines in dermatology. The first one are Blaschko's lines, and the other one are Langer's lines. Langer's lines, which are also called as relaxed skin tension lines. So Blaschko's lines, these are pathways of the epidermal cell migration, which is going to be seen during the embryonic development. Epidermal cell migration during embryonic development. And you need to remember that these do not correspond to the arteries, veins, blood vessels, lymphatics, no, nothing. They're just the pathways of the epidermal cell migration. And you can easily identify them with the help of these shapes. You can see the spiral or the scalp, and you are able to see it is B-shaped over the back and S-shaped over the anterior aspect, and it is linear over the extremities. Right, so this is the identification mark, and also there will these lines do not cross the midline. There is no midline crossing of these lines from right to left and left to right. Whereas in the Langer's lines, remember, these are the orientation of the collagen fibers in the skin. Significances: if you have to give an incision, always give the incision parallel to this line, so the healing will be better. And how can you identify this? So Thanos is going to help us with the identification. So you can see this part, the chin part, it is looking same like Lord Thanos. So Lord Thanos, L for Langer's lines, L for Lord Thanos. So that will help you to identify. And also, if you see this picture, the lines are crossing from left to right and right to left very freely. There is no midline demarcation. Now, can you identify what are these lines? In the comment section, put what is these lines. Yes, absolutely right. It is Blaschko's line. So In fact, this was actually once a INICT question, but instead of the Langer's lines, they have given the the RSTL, the relaxed skin tension lines, and they have not even given Langer's lines in the options. Okay, they have given they have given this picture, they have given this picture, and they have given RSTL, relaxed skin tension lines in the options, along with three other lines, Blaschko's lines, some other lines. Okay, so you should also remember that RSTL, relaxed skin tension lines, are also Langer's lines. It's the other name for the Langer's lines. Right. So next, so we are going to discuss vesiculobullous disorders. Right. So you should know there are two possibilities of the vesiculobullous disorders. Everyone with me, whatever is important, I am going to discuss, and rest of the other topics, you need not know what are the other lines and what are the other options, which are not very important, right? Amitabh Bachchan is asking, this is not, I think, I hope this is not Kaun Banega Crorepati, and if I answer them, I will get the money. Okay. Chalo. Chalo. Okay, now next is vesiculobullous disorder. So we have this intraepidermal blistering disorders, right? We are going to have the flaccid blisters where there's going to be wrinkling, and in the case of the subepidermal blistering disorder, we are going to see that they are going to be very tense, filled with complete fluid. Okay, so this is the identification point, very important in the question. If you see the flaccid bulla is mentioned, it is intraepidermal blistering disorder. Okay, which is going to belong to the pemphigus group of disorders. It could be pemphigus vulgaris or pemphigus foliaceus. These are two possibilities in the flaccid. If it is tense, most likely it is going to be the subepidermal blistering disorder, which is going to be bullous pemphigoid, dermatitis herpetiformis. These are the important diseases from exam point of view, right? Next, we are going to discuss the flaccid acquired blistering disorder. So these belong to pemphigus group, pemphigus foliaceus, pemphigus vulgaris, and the other condition, staphylococcal scarlet skin syndrome, right? So in the case of the pemphigus vulgaris, you need to remember few important points. This is a vesiculobullous, immunobullous disorder. So it is an autoimmune condition. There's going to be autoimmunity against the desmoglein 3 more than desmoglein 1. So because 3 is involved here, the patients are going to have the mucosal involvement. There's going to be erosions, ulcerations in the mucosa, and over the skin, we are going to see the flaccid blisters, right? And in the histopathology, what is the important term which you need to remember? Histopathologically, we are going to see the row of tombstone appearance. This is a very important histopathological finding, right? And in the clinical, how to identify the acantholysis, we can perform the Nichols-Kiss sign, right? And in the Nichols-Kiss sign, there is going to be separation of the superficial layers of the epidermis from the underlying layers of the dermis. So this is what is called as Nichols-Kiss sign, positive in conditions where there is acantholysis, right? Very important point. So it is seen in intraepidermal blistering disorders. Okay, intraepidermal blistering disorders, not in subepidermal blistering disorders. Next is, this is the row of tombstone appearance. This may be a picture also, so you need to remember. So this is the epidermis and this is the dermis. So you can see the stratum basal cells, they are going to be attached to the underlying dermoepidermal junction with the help of the hemidesmosomes, but they are separated from one another, giving rise to this tombstone like appearance. So it is row of tombstone appearance. Again, I am revising this because it is very important. So this is the histopath which was once given in the NEET examination, where this is a stratum basal layer which is still attached to dermoepidermal junction. Okay, very important point. Remember, this is the histopath picture of pemphigus vulgaris, right? This is the DIF, which is the gold standard or investigation of choice in the vesiculobullous disorders. That is a DIF, direct immunofluorescence, in which we are going to see the fishnet, or it is also called as chicken wire pattern. And it is because of the deposition of the IgG and also C3 in the epidermis. So in the epidermis, there is going to be IgG C3 deposition. Next condition is pemphigus foliaceus. So here, what is the, it is also pemphigus. So but here, remember, it is first. So here the patients are going to have the antibodies against the desmoglein number 1 first. Because 3 is not involved, so mucosa is going to be absolutely normal. There will not be any problem in the mucosa. And the patients are going to have the scaly lesions. That is the crazy thing here in this patient. No blisters as such. Scaling will be there, especially in the seborrheic areas. And because acantholysis is present here, we can see the Nichols-Kiss sign, and also acantholysis is positive here, right? So these are the points which you need to remember related to the pemphigus foliaceus. So next condition is staphylococcal scarlet skin syndrome. Remember, dear students, this is just a extension of the concept of bullous impetigo. So in the patients of the bullous impetigo, there is going to be epidermolytic toxin A and B, and these are going to target especially the desmoglein number 1. The toxin is going to target desmoglein number 1 and it is going to destroy that, because of which there is going to be skin blistering, and the patients, because desmoglein 3 is absolutely normal, there will not be any mucosal involvement. Mucosa is going to be normal. Mucosa is normal. And this is bacterial infection, so it is going to be affecting the children, and the child is going to have fever. There's going to be tenderness of the skin if you try to hold nanna munna pyare bacche, and if you try to hold the baby is going to cry a lot because of the tenderness. And if you do a Zang smear, we are going to see the acantholysis, and of course Nichols sign is going to be positive in this children, and you are able to see the peeling off of the skin. Sheet like epidermal peeling is going to be seen. Chalo, next is the subepidermal blistering disorder, right? Chalo, next is this bullous pemphigoid and dermatitis herpetiformis. These are the important ones in the subepidermal blistering disorders. We are going to see one by one. First one is dermatitis herpetiformis. Okay, in this, remember, the patients are going to have the grouped papillovesicular lesions over the extensor surfaces, and this picture can be given. There will be some papils, vesicles, excoriations over the elbows and the knees. So these are the important areas, and the important symptom is going to be itching, and the important association is, what is the important association? Gluten diet. What is gluten diet? It is going to be the barley, rye, oat and wheat. So these are the gluten diet which patient should always try to avoid. And this dermatitis herpetiformis is also associated with celiac sprue or gluten sensitive enteropathy. So these are the important associations, right? And if you do a biopsy, we are going to see the presence of the neutrophils in the papillae, dermal papillae. So this is what is called as papillary tip microabscess. If you do a DIF, we are going to see the presence of the IgA deposition in a granular fashion, okay, in the dermal papillae and also dermoepidermal junction. And what is the treatment? This treatment is also very important. It will be dapsone. Remember, dapsone is a drug of choice, but if anyone asks you what is the treatment of choice, treatment of choice is to avoid the gluten diet. Gluten-free diet is going to be the treatment of choice. So that is about the dermatitis herpetiformis. Next is bullous pemphigoid. Very simple. The patient's age group is going to be very old. It is going to be 60 to 80 years, elderly age group. And the patients here are basically having a problem because of the production of the antibodies against the hemidesmosome. Hemidesmosomes, that is BPAG2 and BPAG1, BPAG2 and BPAG1. Because of which, what will happen at the dermoepidermal junction, there is going to be a split, because of which subepidermal blister will occur, and clinically the patients are going to have a lot of itching, and also there's going to be eosinophilic infiltration into the lesion, because of which there's going to be wheal formation. Urticarial lesions can also be seen. If you do a DIF, what are we going to see in the DIF? IgG and C3 is going to be deposited in a linear fashion at the dermoepidermal junction or basement membrane zone. So this is the important difference. So here also you are able to see that IgG C3 deposited in a linear fashion at the dermoepidermal junction. Right, so this is the tense bullous lesion which you are able to see, right? So these are the two things. Okay, but some important points related to these vesicular bullous disorders as a revision. So this is a patient of pemphigus vulgaris DIF, where you are able to see fishnet or chicken wire pattern. Just a quick revision, right? Fishnet or chicken wire pattern which you are able to see because of IgG and C3 deposition. IgG C3 deposition. So this is a patient of the bullous pemphigoid, where you are able to see this linear DIF picture. Okay, so this is also going to be the picture in the linear IgA disease. LIGA stands for linear IgA disease. So how can I differentiate both of them? In bullous pemphigoid, the deposition is going to be the IgG, whereas in the case of linear IgA, obviously it is going to be IgA deposition in a linear fashion. Alright. Next is dermatitis herpetiformis. In this, we are going to see the deposition of the IgA, but in a granular fashion. Granular fashion. So these are the DF picture related questions which can be asked in the examination. So next, some common things which you need to remember as one-liners or as buzzwords which you need to remember. Pemphigus vulgaris is a disease which is caused by autoimmunity. Okay, acantholytic cells are seen in Pemphigus vulgaris. Pemphigus bullae are located intraepidermally. Remember, so some very common points also students tend to make mistakes. So if you revise it again and again, you don't make that mistake. Intraepidermal bullae can be seen in Pemphigus vulgaris, not only Pemphigus vulgaris, but even in the Pemphigus foliaceus also. So Pemphigus vulgaris can be seen due to autoantibodies against desmosomal cadherin binding protein. Yes, it is both desmoglein 3 and also desmoglein 1. Right? Pemphigus foliaceus, F for foliaceus, F for first. So it is having antibodies against desmoglein 1 only. Row of tombstone appearance can be seen in the Pemphigus vulgaris, in which we are going to see the suprabasal split. Intracellular antibody deposition on immunofluorescence can be seen on Pemphigus vulgaris. Okay, subepidermal lesions can be seen in bullous pemphigoid and also in the case of dermatitis herpetiformis and also in the case of linear IgA disease. So these are all the subepidermal blistering disorders. Identify this immunofluorescence. If I give you this picture, what are all the DDs which you can think of? The first one is bullous pemphigoid and also linear IgA disease is also a possibility. So these are the two DDs which you need to think of, right? So linear deposition of the IgG3 is going to be seen in the case of bullous pemphigoid, right? Which will show Nikolsky sign and also bullous spread sign, both of them positivity. Yes, remember it's going to be Pemphigus vulgaris, right? In the case of bullous pemphigoid, Nikolsky sign will be negative because there is no acantholysis. Very important point. So subepidermal blister formation is there with neutrophils which are located at the tips of the dermal papillae. What is the treatment of choice? So treatment of choice, if it is asked you, if the option mentions gluten-free diet, please mark that. If the examiner asks drug of choice, then mark dapsone. Okay, then mark dapsone. Deposition of the IgA in the papillary tips or dermatodermal. What is the diagnosis? It is dermatitis herpetiformis. Deposition of IgA, again the same question. Okay, papillary tips. What is the diagnosis? It is dermatitis herpetiformis. Drug of choice is dapsone. So that is about the vesiculobullous disorder. So now we are going to see the hair topic. We are going to cover the hair topic. So you need to know the hair loss is alopecia. It could be, non-cicatricial or it could be cicatricial. Non-cicatricial is a permanent, it is a temporary form of the hair loss. Okay, whereas cicatricial, it's going to be hair loss which is permanent hair loss. Yes, everybody is with me and most of you may be having the problem of the hair loss for yourself also. Don't worry, after the examination, after 3 months of time, you are going to experience the loss of the hair for yourself. Can anyone tell what is that hair loss which happens after stress? Yes, what is it called as after the stress? Yes, it is called as the telogen effluvium. So telogen effluvium, because of the pregnancy stress or some infections, there is going to be hair loss in a diffuse fashion, that is telogen effluvium. If a patient is there, cancer chemotherapy, after that if there is a hair loss, then we are going to call it as anagen effluvium. It is because of chemotherapy or radiotherapy. It is seen in Manisha Koral, we have seen that you are seeing so many cancer survivors, this hair loss, we have experienced it in those celebrities, right? Next is patchy alopecia. Remember, in the dermatology, most important diagnosis you need to think of is alopecia areata, right? Of course, trichotillomania, tinea capitis, especially the non-inflammatory varieties, black dot and the gray patch. And secondary syphilis, you can remember in the patients of secondary syphilis because of the treponema pallidum, we are going to see the moth-eaten alopecia. There will be moth-eaten alopecia, which is a type of patchy alopecia. Next, in the pattern alopecia, again, this is a dreaded thing which is present especially in the community, which is the androgenetic alopecia. And the systemic, you can remember any thyroid hypo or hyper, and also systemic lupus erythematosus is also associated with the hair loss. So let us look at the patchy non-scarring type of alopecia. So we are going to see all these conditions, right? First, we are going to, see the patterned one. So pattern one, this is also important. What are the medications which are used and what is a pattern? So remember androgenetic alopecia. We are going to have this male pattern in which the frontal hairline is going to be going backwards, right? And I will tell you this in the class that the usage of the face wash will increase and the usage of the shampoo will reduce in the male pattern of androgenetic alopecia. And what is the treatment? We are going to advise that topically it's going to be the minoxidil, whereas in the form of the oral tablets it's going to be finasteride. And the other possibility is a female pattern of androgenetic alopecia. So remember, in the female pattern, the frontal hairline recession will not occur. It will not occur, only the central partition site hair loss will occur. And in the female pattern, we can safely use the minoxidil. Minoxidil can be used basically in both male and female pattern, whereas finasteride is only used in the male pattern of androgenetic alopecia. Okay, it cannot be used in the females. It cannot be used in the females. Finasteride is contraindicated in the females. So next is the alopecia areata. In this, remember, the appearance is very important. The smooth patches of hair loss with complete hair loss will be seen. Okay, and it is complete hair loss. We are going to see the involvement of the only black hairs, only the black hairs. Why? Because the white hairs are going to be spared, because the melanin is the also one of the antigen against which the autoimmunity is going to act in alopecia areata. And this, when we observe under the microscope the lymphocytic infiltration present at the peribulbar area, we are going to call it, describe it as swarm of bees appearance. Swarm of bees appearance. And what is the treatment for this condition, alopecia areata? Inject the steroids directly into the lesion. Intralesional steroids is the treatment which you are going to advise for alopecia areata. And here you are able to see the picture of the nails. Why is the nails given? So in the patients of alopecia areata, we are going to see the presence of the pitting as one of the important feature. Pitting can be seen in the nails in the patients of the alopecia areata, and this is going to superficial, regular, and fine pitting. So exactly opposite to that of the psoriasis, in which you are going to see deep, irregular, coarse pitting. And if you remember, we are going to see this important exclamatory mark hair sign in the alopecia areata patient. So if you remember, Will Smith's wife actually had this alopecia areata. Okay, there was one event. There was an event in which, Will Smith slapped the anchor. So this, you can remember with help of this exclamation mark hair is classically seen in alopecia areata. Alopecia areata. Next condition is the tinea capitis, and we know the tinea capitis is of two types. It is black dot variety and the grey patch variety. And remember, the black dot variety, the fungus is an endothrix. It is going to go inside the hair, just like the television. Okay, tonsills violation. If you remember, trichophyton tonsills violation, TV is kept inside the house, so it is going to go into the hair. So it is endothrix variety. Remember this point. Whereas in this grey patch variety, if you remember, this grey dog is very furious. It's very dangerous. We'll keep it outside. So this is organism is Microsporum canis. Canis will help you to remember the dog, right? And it is a grey color dog, so grey patch. So this is a type of ectothrix. Contrast to the endothrix which you have seen previously. So this is a patch of hair loss which is appearing green color, right? This is a patch of hair which is appearing as if some black dots are there, right? So this is black dot gray patch. And this is a picture which you are able to see the secondary syphilis because of treponema pallidum, moth-eaten alopecia is clearly visible over the scalp. Moth-eaten alopecia, right? Absolutely right. So few important questions. Okay, again a repetition. Alopecia areata, it's autoimmune disorder where there's going to be damage to the anagen hair follicles. So this picture, if it is given, the most likely diagnosis you need to think of is alopecia areata, right? Hypothyroid female presenting with patch alopecia. Remember, this is autoimmune condition, so this can be associated with other autoimmune conditions. Hashimoto thyroiditis may be the reason for this hypothyroidism. So you should think of alopecia areata. 35-year-old man comes with a hair loss and a swarm of bees appearance is there. This is the picture, actually. This is the picture, right? Histopathology. So you need to think of the diagnosis alopecia areata. So alopecia A is alopecia areata. AA is not Allu Arjun. Okay. A middle-aged patient presented to you shown baldness. Diagnosis is male pattern of baldness. Male pattern of baldness, where you are able to see there is this Batman who is born on this day in the shop, cutting shop, right? Next is the glands. Okay, साला झुकेगा नहीं. चलो हम अब चलेंगे glands की तरफ. Okay, everyone is with me. Everyone is with me. Okay. Yes, unfortunately, Tyson worked in one of the Telugu movies. What is a Telugu movie? Manya Patel is telling, that's why we are telling that we are Batman. Liger, yes, right. Chalo. So just try to identify these. Yeah, chalo. Try to identify what is this gland which is directly opening onto the skin surface. Come back to the topic. Okay, so yes, this is eccrine gland which is directly opening onto the skin surface. Okay, so these are the two glands which are opening into the hair follicle. These are apocrine glands and also the sebaceous glands, right? So you need to know some important points related to the sebaceous glands. So remember, sebaceous glands are going to open along the hair follicle, but there are some conditions in which they are going to open directly onto the skin surface. We are going to call them as ectopic sebaceous glands. So these images, they can be given in the exam, so you need to remember that these are called as Ford spots. These are called as Ford spots. Okay, these are called as the Tyson glands, and these are the Montgomery tubercles. Okay, so these are the ectopic sebaceous glands, right? So, and disorders of the eccrine glands, I hope you all know gonorrhea, which are also called the miliaria. So these are the prickly sun heat, which are going to be called as in Telugu chamata pukkulu, right? Miliaria. Next, coming to the apocrine glands, in these two disorders are there. One is hidradenitis suppurativa and the other one is the apocrine miliaria, or also called as Fox-Fodder's disease. So in Fox-Fodder's disease, the patients are going to be teenage women coming with itchy papules present in the groin and the axilla, right? Whereas in the hidradenitis suppurativa, it is both of these are because of the obstruction of the apocrine duct. But the problem in the hidradenitis suppurativa is going to be there's going to be superadded infection, because of which patients can have the nodules, the cystic lesions, the pus-filled lesions, the sinuses, the scars, fibrous tracts formation in the axilla and the groin. So this is going to be gross when compared to the apocrine miliaria clinical. Next is the acne vulgaris, which is also again very, very important. So what is because of what is the organism name? Yes, it is Propionibacterium acnes, which is nowadays called as QT bacterium acnes. So the condition is very ugly, but the organism is QT. So that is the ironical thing. And remember, this is going to affect the sebaceous gland. Also, it is going to affect the hair follicle. So it is a pilosebaceous unit disorder. And the lesions are going to be polymorphic. They are going to be 4 grades in the acne. So in the first grade, we are going to see the presence of the comedones. It could be open comedones or it could be white comedones. In the grade 2, they are going to be papular lesions, erythematous papular lesions. In the grade 3, they are going to be pustular lesions. And in the grade 4, we are going to see nodulocystic lesions. And the grade 4 is the most severe form of the acne vulgaris. Treatment is also very important in the grade 1 acne. What is the treatment? See, remember, in all the types of acne, we are going to use retinoids. In 1, 2, and 3, we are going to use a topical retinoids. In the grade 4, we are going to use the oral retinoid. Okay. In the grade 4, we are going to use the oral retinoid, which is called as isotretinoin. And you need to know the other name of isotretinoid. It is also called as 13-cis retinoic acid. 13-cis retinoic acid. So in the first 3 grades, we are going to use topical retinoids, which could be adapalene or it could be tretinoin. Okay. So adapalene or it could be tretinoin. This was also one previous year question or FMG exam. So whereas in the grade 2, we are going to, along with that topical retinoid, we are going to add the topical antibiotics, antibacterial agents, which could be clindamycin or it could be nadifloxacin. These are commonly used, and also it could be benzoyl peroxide. In the grade 3, we are going to add oral antibiotics, which can be any one of them. Okay, any one of them. It could be MAD, any one of the MAD. M is minocycline, A is azithromycin, and D is doxycycline. So these are the 3 which we can use. Any one of them. Okay, not all 3, it's any one of them, right? So next condition is the acne rosacea. So remember this term, it is though acne, it is not having any relationship with the acne vulgaris. This is basically a chronic inflammatory facial dermatosis where the lesions are going to be present on the centrofacial area of the face. As you can see, a centrofacial area is most commonly affected, and basically the problem here is with the blood vessels, vascularity, because of which skin is going to appear red in color. We are going to see dilated blood vessels. Okay, so these are all the changes which can be seen. And what is most important is the stage, which is a special stage called as phimosis type of rosacea, in which there is going to be this thickening and irregular surface, which can be seen over the nose, it can be seen over the chin, or it can be seen over the ears. So if it is present over the nose, it's called as rhinophyma. If it is present over the chin, it is called a gnathophyma. If it is present over the ear, it's called as otophyma. So these are the important points related to 5 meters step of rosacea. So questions for all of you: obliteration of apocrine duct leads to Fox-Fordis disease. Fordis spots involve the sebaceous gland. So these are the Fordis spots. So true or false about the Fordis spots? Lips are the most common site. Is this true statement? So this is absolutely true statement. Okay. So this is related to Propionibacterium acnes. What do you think is the exception among the given options? So remember, the sulfur granules are not characteristic of the acne. Okay, it is related to mycetoma. Treatment of choice in the case of severe type of acne is isotretinoin, which is the oral retinoid. And what is the side effect which is most commonly associated with isotretinoin? Remember, it is a teratogenic medication. It is the embryopathy which can be seen. Oral treatment of acne, remember, you should also think of the antibiotics, of course, along with the isotretinoin. That is also one of the oral medication. Okay, doxy or even these three, any one of them. Which drug? So remember, the minocycline, it is very notorious that it can produce pigmentation of the skin. That is a problem, right? Acha, okay. Which are the following? So this question actually was, having the option of embryopathy, neural tube defects. So that's why I have kept this as the answer. But yes, most common. Yes, a very good Jiraya, a very good observation. So if the option is given as cheilitis, cheilitis is the dryness of the lips. So please mark that. Okay, please mark that cheilitis, that is dry lips, which is the most common side effect which is seen with the isotretinoin. Very good observation. Right. Absolutely right. And remember, the causative agent of acne vulgaris is a Propionibacterium acnes. Not only that, there is one variant of acne which is called as fulminans. And again, the causative agent is Propionibacterium. Fulminans, just remember, the patient is going to have fever, severe acne lesions over the body. Okay, F for fulminans, F for fever. That's how you can remember. Right. So next is this picture. If you see, when you see this picture, always think of the obliteration of the apocrine duct followed by secondary bacterial infection, which is leading to the hidradenitis suppurativa. Right. Okay. Absolutely right. Now, some important observations of the nails in some important diseases. Okay. So nail psoriasis, if you remember, I told you that there's going to be absolutely opposite type of observation from alopecia areata. So here the pits are going to be deep, they are going to be irregular, and they're going to be coarse pitting. Right? In alopecia areata, it's going to be superficial, regular, and fine pitting. So that is a contrast of these two conditions. Next, in the case of nail psoriasis, we are going to see the deposition of this content which is present in between the nail plate and the nail bed. What is this called as subungual hyperkeratosis, right? And because of the subungual hyperkeratosis, what can happen is there can be separation of the nail plate and the nail bed. So what is this separation called as? This separation is called as onycholysis. Onycholysis, right? And also, yeah, important point, salmon pie. So salmon pie, salmon patch, the oil drop sign where we are going to see the yellow discoloration present below the nail plate. This is yellow. Oh, sorry, this is not yellow. This is a pathognomonic of the. This is pathognomonic of the nail psoriasis. And what is the description? It's going to be yellow discoloration of the nail bed. Discoloration of the nail bed, and this is very classical of nail psoriasis, and even the thickening of the nails can also be observed in the patients of nail psoriasis, right? So oil drop sign is seen in the patients of psoriasis. Very important pathognomonic finding. Core spitting, deep irregular core spitting, again psoriasis. Which nail finding of psoriasis is shown in this image? So this is a picture which is showing subungual hyperkeratosis. Okay, if there is proper separation which is being displayed, then you should mark onycholysis, right? Very important point. Next, this is the pathognomonic finding of psoriasis, which is given in this image where you are able to see this yellowish oil drop sign, right? Munro's microabscess can be seen in the psoriasis. This is a histopath picture based question which is there here. Munro's microabscess related to psoriasis. right? So next condition which we are going to discuss is related to pigmentary disorders. So just by looking at the image, you should be in a position to identify what this picture could be. Can anyone guess what is this picture? By looking at the image, where you are able to see brown pigmentation along with the hair presence over the back. Very good. So if you have watched my sessions, you will remember that it is the Baker Barber. Okay, remember, so I will give you clues. So related to Becker's Srinivas, so this appearance is going to be seen from not the birth, it is going to appear from the puberty. It's going to appear from the puberty. There's going to be suddenly the one side of the skin is going to become brown in color, more and more brown along with the increased hair growth. So this is a picture, classical picture of hypertrichosis, hyperpigmentation, which is Becker's nevus. Becker's nevus. So this point is important. Puberty. It is given. It is seen in from the puberty. You need to think of Becker's nevus. But if the it is in the question it was given that the pigmentation is present from the birth and hair is also present from the birth, then you need to think of the close differential which is called as CMN, congenital melanocytic nevus, right? So that is about these two conditions. Now coming to the disorders in which you are going to see the dermal melanocytosis. So this image, can you tell what is this image? Yes, very good, Mongolian spot. It is Mongolian spot. Over the lumbosacral area, bluish discoloration is present over the skin. You should tell me what is this called as? Ophir, yeah, nevus of Ota. It is nevus of Ota. Only identification. This is a blue color which is not having any hair growth. So this is the nevus of Ito. Right, nevus of Ito. And I hope you remember this story. Baker Barber will help us to remember Becker's nevus. Right, and also Ito in the blue color will help you to remember the nevus of Ito. So this is one more important image based question. So it's not 2-year-old, it's a 22-year-old. Okay, 2-year cannot become a pregnant. So in the pregnancy, you are able to see that there is this pigmentation over the cheeks. So what do you think is the diagnosis? So it is, if it is not given as a pregnancy, then you can think of melasma. But if pregnant individual is having melasma, we use this term called as cloasma. Right, this is an important point. Sunscreen lotion which we advise to these patients, we are going to use the zinc oxide or titanium dioxide as a physical sunscreen. So this is a physical sunscreen. And then next question which you are able to see, that is also a integrated question between the surgery and the dermatology. So melena is there, abdominal pain is there, pigmentation is there. What is the diagnosis you want to think of? It is a Peutz-Jeghers syndrome. Very, very important, right? Peutz-Jeghers syndrome. And if you see the small pigmented lesions over the trunk, then you should think of the lentiginosis, right? And if you are given this type of nevus in the puberty, it is present and brown color. Becker's nevus is the thing which you need to think of, right? And this, blue marks on the face and also sclera is involved. What do you think? Yes, it is a nevus of Ota. So these are some of the hyperpigment related questions. So here this is a patient who is having the defect in the tyrosinase enzyme, because of which there is no melanin production. Melanocyte is absolutely normal. Melanin production is not there, because of which the hair, the skin, and also the eyes, everything is going to become white in color. So this is what is called as albinism. Right? And the next condition is very interesting. Here you can see that this is a child. Here this is a child who is having this pybaldism. In the pybaldism, remember, there's going to be this white forelobe which is present over the forehead, and also vitiligo-like lesions over the rest of the body. So this is pybaldism, right, which is the autosomal dominantly inherited condition. So this, which of the following presents with hypopigmented patches is the question. What do you think is the answer for this question? Right, yeah. Just remember, blue nevus is not hypopigmented. It's going to be having bluish color. Okay, nevus of Ota, nevus of Ito, both of them are going to be blue in color. So remember, nevus anemicus is going to be hypopigmented. This was a neat question. So you just remember the name of this condition, nevus anemicus. right? Next is, this is a college student. This is a picture which is presenting with small depigmented lesions present over the body, which are there for 2 years. Right? What's the most likely diagnosis? Yes, this is a vitiligo. This vitiligo, can anyone tell what is important association with the vitiligo? Yes, it should be, you should think of hypothyroidism. Oh, that's autoimmune condition. Because of this being autoimmune condition, there can be association between other autoimmune conditions and the vitiligo, right? And what is the treatment which is commonly used for vitiligo patients? Yes, it is going to be the phototherapy, PUVA and NB-UVB. And among these two, if you are to select any one of them, select NB-UVB. That is going to be the better answer. Okay. And if you happen to see this type of vitiligo where it is the involvement of only one side and it is involving a segment and it is static for many years and it is not responding to the topical treatment modalities, then what is the diagnosis? Yes, it is segmental vitiligo. It is segmental vitiligo. Absolutely correct. So next we are going to see the papillosquamous disorders. Papillosquamous disorders. So in this, what are the diseases which you need to know? Psoriasis, lichen planus, pityriasis rosacea. These are the 3 important conditions among the papillosquamous disorder which are very important, right? So first one is psoriasis. So you already know a few important points related to psoriasis. That is, it is going to present with silvery white scale. So it is silvery white scale which the patients are going to have, especially the involvement is going to be over the extensor surfaces, over the elbows, or the knees, and also lumbosacral areas, right? And this condition is the most common type of psoriasis vulgaris, which is also called as, remember this was once a question, it is chronic plaque psoriasis, which is the other it is synonym for psoriasis vulgaris. Remember this was given as one of the options in the question, right? And if the psoriatic patient is having psoriatic arthritis, what do you use for the treatment of psoriatic arthritis? Very good, it is methotrexate, which we use, which might have been also discussed in the orthopedics. So if the patient of the psoriasis is getting pus-filled lesions, okay, over the body, then it is pustular psoriasis. This is a very favorite question of INSCT, right? And if the patient of psoriasis is developing this redness and scaling over the body, involving entire body, almost entire body, what is the diagnosis you want to think of? It is a erythrodermic psoriasis. Very good. It is erythrodermic psoriasis. Absolutely correct. So this is a very, 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 very important sign related to psoriasis, which is what is called as Auspitz sign. Remember Nikolsky's sign? If you remember Nikolsky's sign, it was seen in the vesiculobullous disorders. Auspitz sign, in which you are going to take a glass slide. We'll scrape the scaling, which is called as grattage test. We are going to see the bulkless membrane after the scales are removed, and finally we are going to see the end point of pinpoint bleeding spots. This is the positive Auspitz sign, which is classically seen in the patients of psoriasis. So the final point is the end point is pinpoint bleeding. But remember, the grattage test was also asked recently. So you need to know the grattage test is one of the component of the Auspitz sign demonstration, right? Now related to the histopath of psoriasis. So what will be the changes in the stratum corneum? There will be thickening of stratum corneum, hyperkeratosis, there will be persistence of the nucleus in stratum corneum, which is called as parakeratosis. There will be collection of the neutrophils in the stratum corneum, which is called as, you have already listened to this in this class itself, Munro's macroabscess. In the stratum granulosum, remember it will be either reduced or absent in the patients of psoriasis. In the status paralysis, there is going to be collection of the neutrophils, which is called as spongiform pustules of Kogoch. And coming to the dermal papillae, we are going to see the dermal blood vessels, dilated dermal blood vessels present in the dermal papillae, and the elongation of the reed ridges can also be observed. Elongation of the reed ridges. So these are all the important histopath changes of psoriasis. Now, some important previous year questions. So this is a type of psoriasis in which you are going to see this raindrop-like lesions over the body, which is gutted psoriasis, commonly seen in the children or the trunk after sore throat. So these are the important points related to gutted psoriasis, right? Next is the digits. they are going to appear like a sausages in the patients of psoriasis, psoriatic arthritis. So this is psoriatic arthritis, right? Auspitsin is seen in the psoriasis vulgaris. This was also one of the questions, and in the options it was mentioned as, remember, pustular psoriasis. Okay, so but remember, auspitsin is negative. It is not seen in some types of psoriasis. What are those types? You can remember them with the help of PIG. So what is P? It is pustular. What is I? It is inverse. And what is G? It is guttate. So in these three types of psoriasis, we don't see the auspit sign, right? So next is scratching leads to bleeding followed by further formation of similar lesions. So what is it suggest of? It is suggest of psoriasis vulgaris. It suggests of psoriasis vulgaris, right? Okay, so this is the question you need to identify among these which is not going to show this Koebner's phenomenon. Yes, very good. Herpes will not show Koebner's phenomenon. It is the PSLV, if you remember, that is a mnemonic which we remembered. Psoriasis, lichen planus, vitiligo. In all of them, we are going to see the Koebner's phenomenon positivity, right? In which you are going to see the morphological simulations appearing at the site of the trauma. Methotrexate is the treatment of choice for which type of psoriasis? So if you remember, yes, very good. Arthritis, if you can remember psoriatic arthritis, that is most important. Of course, in the patients of psoriasis vulgaris also, the that is the treatment, and in the case of psoriatic arthritis also, this is the treatment. And acitretin, can anyone tell what is the? It is pustular psoriasis, which is treatment of choice in the case of acitretin, pustular psoriasis, right? Remember, in the female patients, if there is psoriasis, if severe form of psoriasis is there, which is impetigo herpetiformis, which is the pustular psoriasis in the pregnancy, or if there is psoriatic erythroderma in the pregnancy, we cannot use the teratogenic medications, acitretin or methotrexate. In such case, we are going to use the steroids, right? Or we can also cyclosporin. But you all know that steroids, they are not used in the patients of psoriasis because they can lead to dangerous adverse effect of pustular psoriasis or erythrodermic psoriasis. Then why are we using the steroids here? Because in the pregnancy we cannot use the teratogenic medications, and we have to very, very, very slowly taper these medications in the pregnant woman, because both of them are going to have a bad outcome. That is the reason why we are giving some treatment with the steroids. And this, ignore this point. Okay, don't bother about it. Next is the lichen planus. I hope all of you know related to lichen planus. What are the P's which you need to remember in the lichen planus? Purple colored papules, plaques, polygonal shape, pruritic lesions which are present on the plexus, which are associated with the pterygium. So these are all the P's which you can remember related to the lichen planus. Plain topped, purple color, polygonal papules, plaques, which are present on the plexus, which are associated with the itching or pruritus. And remember this important term, Wickham stripe, which is a network like lacy pattern which is present on the skin and also present on the mucosa. And what is important trigger you need to remember in the lichen planus? It is the amalgam. It is an amalgam which is a filling used in the teeth. Okay. Right. So that is about this. And in the recent NEET question, there was one question which asked lichen planus, what is the most important infection associated with the lichen planus? You can just remember it is the HCV, hepatitis C virus, which is commonly associated with the lichen planus. Coming to the histopath of the lichen planus. So here we are going to see thickening of the stratum corneum, hyperkeratosis. And what are the important changes which are happening at the dermoepidermal junction? They are very important, right? What are those important changes? Right, 1 minute. Siri got activated. I don't know what I talked which activated the Siri. Okay, chalo. Next is the lymphocytes. Lymphocytes are going to be accumulating near the dermoepidermal junction, because of which there is going to be damage of the stratum basal layer, because of which we are going to see the presence of the some spaces. These are called as max Joseph spaces. Okay. And these lymphocytes, they don't be silent. They are going to go into the epidermis, which because of which there is going to be apoptosis of the keratinocytes, and these keratinocytes which are becoming apoptotic, we are going to call them as civate bodies. They are also called as colloid bodies. They are also called as colloid bodies. So these are the important changes which can be seen in the lichen planus histopathology. So this is a very classical picture of violaceous, which is the other name for the purple color. lesions which are present over the flexor wrist surface, right? It is a lichen planus. Right, okay. We can say it is seen in the lichen planus. Okay. Okay, what an imagination of all the students. I'm very, very happy. Chalo. So this is the pterygium of the nail. So this is a 30-year-old female presenting with lacy lesions in the oral cavity, that is Wickham's striae, and also genitals can have the Wickham's striae. Okay, proximal fold extended. So this is basically a pterygium description. So this is a lichen planus. So very straightforward questions will be asked related to these conditions. Okay, next condition is the pityriasis rosea. So related to pityriasis rosea, you need to know few important points. It is associated. What is the important association? Yes, it is human herpes virus number 7 viral. It's an associated viral infection. How can you remember this? Just remember the Thala, Dhoni, the jersey number is number 7. Okay, and if you see carefully, they are wearing the mother name over the jersey. So that mother patch, which is the initial lesion, which is also called as herald patch, can be remember related to the this thing pityriasis rosea. And yeah, this rose, it will help you to remember that they are going towards pavilion to give the rose flower to their mothers, and they're going to celebrate the Christmas. So that will help you to remember the Christmas tree pattern which is present over the back along the Langer's lines in these patients of the pityriasis rosea. So these are all the important points. Yeah, today is 7th Jan. Very correct, absolutely correct. So next we are going to see this is again the same thing. Okay, this is repetition. Band-like lymphocytic infiltrate the dermoepidermal junction sawtooth ridges, right? Can be seen in the patients of lichen planus. So this is a patient who's having this annular herald patch, mother patch. You are able to see small daughter lesion which are present or involved in the entire body, mainly the trunk. So this is the pityriasis rosea. This is the pityriasis rosea. So this picture related to this, all the following are correct except you need to identify the wrong statement. Remember the lesions predominantly are going to see over the trunk but not the genitalia. So that is a wrong statement. So this is again the same thing, Christmas. So these are one-liners, right? Next, we are going to see the bacterial infections. Okay, in the bacterial infections, remember we are going to have we are already seeing this staphylococcal scarlet skin syndrome and its manifestation. So I told you that bullous impetigo is just the local form of the staphylococcal scarlet skin syndrome, broader form. So in this the organism, please remember the organism, it is always staphylococcus which is going to produce a toxin which is going to target the epidermolytic toxin A and epidermolytic toxin B. So the other type of impetigo, which is the most common variety, it is the non-bullous impetigo, which is also called as the impetigo contagiosa. Remember, it can be because of the strep or it can be because of staph. And in this, the most important descriptive term which you need to remember is honey colored crust, right? Honey colored crust. Honey colored crust can be seen, and these all these conditions are commonly seen in the children. Okay, in the children. Basically, these are the pyodermas. So the next slide, which you are able to see, the important differences you need to know from erysipelas and cellulitis. Remember, the causative organism in the case of the erysipelas is always going to be the strep, and particularly it is group A beta hemolytic streptococcus. Whereas in cellulitis, the organism can be staph or strep. And the involvement in the erysipelas is going to be superficial when compared to cellulitis. Cellulitis is going to be even involved in the subcutaneous tissues. Subcutaneous tissue, it's very deep, and because of this depth in the cellulitis, the margins are going to be very ill defined. Whereas in the case of erysipelas, the margins are going to be very well defined. They're going to be well defined, as you are able to see here, right? And if there is a infection of the nail fold, we are going to call it as a paronychia, and if it is due to the bacteria, we are going to call it as acute paronychia, right? Erythema is going to be present around the nail fold, as you are able to see, and there is going to be erythema, pustular lesions. So what is the treatment of this condition? If there is a lot of pus, incision and drainage, and if we can prescribe, we are going to prescribe the antibiotics, oral antibiotics. So next condition is the cornybacterial infection, which are very important for you. That is the erythrasma, which is because of the organism which is called as Cornybacterium minutissima, minutism. The lesion is going to be the, as you're able to say, hyperpigmented, or it could be little bit it's not furfur, it's not furfur. Okay, furfur, that is pityriasis versicolor, it is a different condition. Hyperpigmented, or it could be even red colored patches and plaques can be present in the axilla and the groin. And if you are having a doubt, what you can do, you can take this wood slab. It's handheld device which is going to emit 365 nanometers wavelength of light. And if you put this light in the axilla, what we're going to see, we are going to see that there is going to be a fluorescence which is red, coral red or coral pink in color, which is classically seen in the patients of erythrasma. So all of these are very important previous year questions. And coming to the wood slump examination, the wavelength I have told you, the number of days in a calendar year, 365 nanometers, and it can be seen, the color can be differentiating from one condition to another. So in the P versicolor, the color is going to be described as yellow color. In the microsporum, trichophyton shown, basically these are tinea capitis, we can see blue color, right? And in the vitiligo, the color is going to be milky white, as you are able to see here. So it will become more and more white, milky white in color. So this is an image based question. Can anyone identify? Yes, this is a carbuncle. What is the important clue which the examiner is going to give you along with this picture? So it's going to be uncontrolled diabetes mellitus, which is important. Uncontrolled diabetes mellitus, right? So identify this condition. Yes, you are able to see this honey colored crusting. It is the non-bullous impetigo or impetigo contagiosa. So in these patients of non-bullous impetigo, what is the important complication you need to have in your mind? It is post-streptococcal glomerulonephritis, because the causative organism can be streptococcus and also staphylococcus. So this kind of picture you are able to see suggestive of infection, and we are having well-defined margins. Always think of the erysipelas, and erysipelas is because of the group A streptococcal infection. And this is a infant presenting with sheet-like epidural peeling. What is the diagnosis you want to think of after a pharyngeal infection? Yeah, staphylococcal scarlet skin syndrome, very important. And yeah, this is the erythematous pus collection is there in the nail fold. Okay, so this is paronychia. This is paronychia. A classical picture of the coral red, coral pink fluorescence seen in erythrasma. The causative organism is Corynebacterium minutissimum, right? Now coming to the bacterial infection, we have completed bacterial infection. Now we are going to discuss the fungal infections. Now let us discuss the fungal infections. Okay. So what is the causative organism for P. versicolor? Pityriasis versicolor. So it is Malassezia globosa, more than Malassezia furfur. Why is it called versicolor? Because versatility in the color is there. Both hypopigmented as well as hyperpigmented lesions can be seen in this patient, right? And this can be seen over the trunk, and also it can be seen over the face. And yeah, these are the important points related to this. Now this is a important micro dermatology integration. So that is a KOH mount is going to give rise to the appearance of short hyphae and round spores in a combination, and this is what is described as spaghetti meatball appearance. Very routine, or commonly heard term, spaghetti meatball appearance. So one question for all of you, if you put a wood slab on these lesions, what is the color which you are going to see? Yes, it is yellow color. Right, okay, so this is hyperpigmented macules. This is how the question can be asked. KVH spaghetti meatball is seen. So what can be the causative agent? Malassezia globosa and furfur. So Peter's versicolor caused by globosa furfur, right? So what is used to diagnose this condition, which is shown in this picture? This is the picture. So what are the possibilities? One is wood slump and the other one is KOH. We can also do KOH. A girl presented with lesions as shown. What is the treatment which are going to use? Topical azoles are going to be advised to the patient. Topical azoles. And I hope you remember this story of Angelina Jolie and Brad Pitt. So Pitty is there with the Brad Pitt, right? They are fun couple, but they have separated. So the Brad Pitt is eating the spaghetti meatball over the yellow table. That will help you to remember the yellow fluorescence spaghetti meatball appearance. And you know that he is a versatile actor. So versatility is there, versicolor. That will help you to remember pityriasis versicolor. and all the features of the Peter's versicolum. Alright. So we have already seen the black dot and grey patch variety of tinea capitis. So it's basically a fungal infection, dermatophytic infection. So Kerion and Favus, these are the inflammatory variants in which there's going to be a lot of inflammation and permanent hair loss. Cicatricial alopecia can be there. And you need to know that the causative organisms, zoophilic usually, what is the common causative organisms? It is trichophyton, mentagrophytes, and trichophyton verrucosum. I hope you remember the concept which we discussed, mental and very crack, right? So here the patients are going to be children, the children boggy, indurated, scalp swelling will be there, easily pluckable hair will be there, right? And there will be crusting lymphadenopathy. And if you do a 10% KOH mount, we can see the fungal elements. We can say the fungal elements. And in the case of the Favus, what is the causative organism? It's going to be Trichophyton schonleini. And there's going to be this yellow colored cup shaped crust which is called a scutula. Which is called as scutula. Yeah, these are this is a picture of Kerion which you are able to see, and this is a permanent hair loss which is seen, cicatricial alopecia. Even here also we can see cicatricial alopecia. So these are the important terms related to this. So I hope you all know. If you know, you know. If you don't know, you don't know. Tinea incognita, steroid modified tinea. We are going to say the patients are going to have less itching and more scaling because of the usage of the steroid. Steroid modified tinea, tinea incognita. Candida, it is going to present as white membrane which can be seen over the tongue and in the buccal mucosa. So this is the candidiasis, oral thrush. Right. Next is you need to identify what is the exception here. So it is not caused by candida. It is a Dobich or it's a Tinea cruris. So it's also called as Jockitch. It is commonly seen in the tropics. All of them are curve. So boggy swelling, child is coming with the boggy swelling. What is the possible diagnosis? It is Tinea capitis, especially it is Kerion. Right. Next is Tinea corpus gladiatorum. Remember Tinea corpus gladiatorum. Gladiatorum, it is going to be the trunk where the involvement of tinea will be there, especially. Right. A 20-year-old patient presenting with extremely itchy lesion on the arm, and you are able to see that there is one annular lesion inside the other annular lesion. So what is this? This is a tinea imbricata. Tinea imbricata. Right, absolutely correct. And this is a very, very, very important concept, that is deep fungal infections, subcutaneous mycosis or implantation mycosis. So sporotrichosis, chromoblastomycosis, mycetoma. These are three important conditions. So this condition is caused by sporothrix Schenke dimorphic fungus. It is also called as Rose Gardner's disease. Rose Gardner's disease. And you can see that there will be linear spread of the nodular ulcerative lesions along the lymphatics in these patients, right? Coming to chromoblastomycosis, the patients are going to present with a verrucous lesion. That's why it is also called as verrucous dermatitis. And we are going to have this copper penny body, also called as medullary bodies, also called as sclerotic bodies, muriform bodies, which can be seen on the KOH mount and also even in the biopsy. And why is it called chromoblastomycosis? Because the causative organisms are pigmented fungi. Pigmented fungi. Chromo is color. So what are the organisms? Can you remember the spelling? If you spell them, they are going to be fa. Okay, Fialofora, verrucosum, like that. Fa pronunciation will be there in these organisms. Right. Next is mycetoma. Related to this, you need to know that the causative organism can be a bacteria and also it can be a fungi. Right. That is an important point. And there is going to be this GST. GST, which is the triad which can be seen just goods and service tax, you can remember, or you can also remember the movie of Palakova, so the Mia Malkova. Okay, that is also GST, right? And the RGB will help you to remember all the points related to the two conditions. One is actinomycetoma, bactinomycetoma, you can remember this as, and eumycetoma, which is the fungi. Right, caused organisms was a recent question. So actinomadura madre, nocardia, and streptomyces are associated actinomycetoma. Right, and in the case of eumycetoma, the causative organism Madurella mystomatis and Grisha. And the most important differentiating point is, if the patient is having this tumor like growth, sinuses are there, granules are there, just see what is the color of the granules. Right, if the color of the granules is pale then probably it is a actinomyostoma. But if it is black, then it is a case of eumystoma. And if you see this question, it is farmer. So whenever you have this deep fungal infection, always there will be a mention of the farmer or the person is having a prick. Okay, so these are the important clues which will be given by exam. So there is this pain, is a swollen foot is there, sinuses are there. Okay, so there is also granules, grains which are mentioned, but and they are dark colored granules. So this is eumystoma because black colored or dark granules are there. So can you guess what is the answer for this question? Patient from Himachal Pradesh gets a thorn prick. There is verrucous lesion developing. What is the diagnosis for this case? What is the diagnosis? So remember, after a thorn prick, if there is verrucous lesion development, chromoblastoma is not sporotrichosis. Okay, remember what is happening. What is happening after the thorn prick is very important. Just like you are all preparing, okay, but some of you feel that it is very difficult to prepare. Some of you feel that it is a cakewalk. So just like you are all going through the stress, but some are reacting one way, some are reacting other way. Just like that, there is a prick followed by verrucous lesion development, then it is chromoblastoma. If it is a linear lesion, this porotrichosis, right? Next is this picture, farmer, swollen foot, gram stain negative, dark greens are there. So this was an actual question which was asked in FMG. So this is a eumystoma, even actinomystoma was there in the options. Okay, so this is how the examiners, slowly increasing the difficulty level of the FMG exam, just like NEET and INCT. So next, viral infections. Viral. So this is viral infection. So herpes simplex viral. One is going to produce the orolabial herpes. Orolabial herpes, which is also called as fever blisters or cold sores. Cold sores, right? And where they are going to see this grouped vesicular lesions present near the lips. Next infection is VZV, varicella zoster virus infection, right? So here we are going to see the chicken pox, which is the varicella infection in the children, right? And if there is a reactivation from the dorsal root ganglion, then we are going to call it as herpes zoster. Herpes zoster, right? So these are the questions. Chalo. This is a Bangkok. A patient is coming. Bagunara, Bangkok. So perioral vesicular lesions are there. What is the diagnosis? What do you think of the possible organism? It is a herpes simplex viral infection. So true about chickenpox. This is the integration between microbiology, pediatrics, and dermatology. True about chickenpox rash are all except. What do you think is the exception here? Yes, it is superficial centripetal and it's not palms and soles involvement. It is the rest of the body involvement. Okay, right. And child is presenting with fever and lesions are changing from one stage to the other. So what is the diagnosis you want to think of? What is the diagnosis you want to think of? This is pleomorphism, which is being explained in the question actually. So this is, yes, it is again the chickenpox. That is chickenpox, right? And this is how the image of the reactivated varicella zoster virus look like clinically. So where there's going to be involvement of one side, one segment will be affected. On the right or left side, there is most common involvement of thoracic dermatome. This is the shingles. It's also called as herpes zoster. Shingles. And you need to identify the false statement related to the shingles, herpes zoster. So yes, lesions are infective in seronegative individuals. Absolutely correct. Can be associated with meningoencephalitis, absolutely correct. Viral encephalitis, geniculate ganglion is associated in the Ramsay syndrome, absolutely correct. This is not bilateral symmetrical. That is an exception. That is a wrong statement. And what is the treatment? We are going to advise a val acyclovir for the patients. Val acyclovir for the patients. Next is molluscum contagiosum. What is the causative agent here? The causative agent is molluscum contagiosum virus, and this is basically a pox virus. Children are going to present with pearly white, pearl-like white, मोती के जैसा white होता है, dome shaped Raghavendra Rao papules, umbilicated papules will be present over the body, and similar history of the lesions, similar lesions will be there or in the mother and the siblings. Okay, so this is the classical description of the molluscum contagiosum, and yes, in the biopsy we are going to see this Henderson-Patterson bodies. Very good. Intraeosinophilic, intracytoplasmic eosinophilic inclusion bodies. Yes, very good. So next is the warts. it could be genital, which are called as condyloma acuminata, or it could be non-genital. It could be present any elsewhere over the body apart from the genitalia. All right. So the most common types of the warts which are present non-genitally, they are called as verruca vulgaris. Right. Okay, treatment part, you might have read that in your pediatrics. Okay, isn't it? It will be with acyclovir for the cases of the varicella, and in the case of molluscum contagiosum, basically it is a self-limiting, self-resolving condition. We can just give the parents reassurance that it will go away by itself. If the patients insist for any treatment, we are going to use the physical treatment modalities, that is to remove it with the help of a curettage. Or we can also apply the TC or KOH. So these are the treatment options, but commonly, remember, it is most commonly self-resolving. It will resolve on itself. There is no need for any treatment. Even we cryotherapy, we can do anything, but ultimately it will self-resolve. That's what is important, right? Chalo. Next is the verruca vulgar. So remember, verruca, wherever you hear, you have to know that the skin is rough, uneven surface, and there are so many types of the warts which can be produced over the body because there are so many types of HPV, human papilloma viruses. So if it is present over the plantar aspect, it could be deep or it could be superficial. So deep plantar warts, superficial plantar warts. 1, 2, and plain warts. So this plain wart is somewhat very peculiar, in which the wart is going to be plain instead of rough surface. There will be plain surface, verruca plana, and it is because of the HPV subtype 3. The rest of the other ones, commonly we are going to call the wart as common wart as what. So 4 alphabets. So 4, you can remember it like that. And laryngeal papillomatosis. How many alphabets are there in the larynx? It is number 6. So larynx, 6. Butcher, the number of alphabets is 7. Butcher's warts are HPV 7. Right? Yes, very good. Genital warts are because most commonly of 6 and 11. Right? So DSP, I hope you remember. All right, DSP, Devisha Prasad. Next is this condition, enteroviral disease, enteroviral infection, which is called as hand, foot, mouth disease, where we are going to see the vesicular lesions present over the hand, foot, and also over the buttocks, and also in the mouth. And what is the etiological agent? It is a Coxsackie virus. It is a Coxsackie virus. A6, A16, and enterovirus number 71. Enterovirus number 71. Right? So these organisms, they can produce lesions of hand, foot, and mouth. So next is STD, sexually transmitted disorder. So this is a very important topic which you need to know. STDs. So this condition is called as condyloma acuminata. Can anyone tell what is the close term related to this condyloma acuminata? Very good. It is condyloma lata. Condyloma lata, which is associated with the secondary syphilis. Yes, very good. Secondary syphilis. Secondary syphilis. Absolutely right. And in the anogenital wart, which is condyloma acuminata, remember there's going to be this pointed acuminatus, pointed rough surface lesions present to the genitalia. Right? So you are able to see this is a male genitalia. And here we have this picture which is showing the small papillary lesions along the coronal sulcus. What do you think is this? Yes, pearly pineal papules. So remember how to differentiate both of them. Very simple. Pearly pineal papules are physiological papillary lesions which are present in the coronal sulcus, right? And we are going to see. Okay, we are going to see the. If you see this picture, you are able to see that the lesions are present over the glans penis. So because this is infectious condition, glans penis is being affected. Whereas in the case of pearly pineal papule, this was once a image based question. So be very careful. This can be asked again. So be very careful. There will not be any lesions over the glans penis in the pearly pineal papules. So next is genital discharge. Again, this is a microbiology and dermatology integration. So gonococcal urethritis and non-gonococcal urethritis. These are the two things which you need to know. Non-gonococcal urethritis, most common caused organism is Chlamydia trachomatis. Okay, just comment in the chat section what you think is the answer. Okay, chlamydia trachomatis. Right, very good. And in the gonococcal urethritis, the constitutional symptoms they are going to be very severe. The discharges, pus is going to come out through the urethral discharge. Frank pus will be there. Whereas in the case of non-gonococcal urethritis, the symptoms are very mild. The mucoid lesion, mucoid discharge will be there. The patient is going to be chill. And also remember the incubation period is also very important. In the case of gonococcal urethritis, it is less than 1 week. Whereas here it is more than 1 week. So that is a broad thing which you can remember. Whereas in the gonococcal urethritis, in the gram stain, what is the observation which you are going to see? We are going to see that they are going to be these intracellular gram-negative organisms. That is the most important finding in the gonococcal urethritis. Whereas in the non-gonococcal urethritis, we don't find any organisms in the discharge. Coming to the treatment part, so this kit number 1, so you can just actually it has been changed recently, so you can remove this. Right, we'll see what are the drugs which are present in the kit. But before that, if you are asked for the treatment of gonococcal urethritis, what we can use, we can make use of the injection ceftriaxone. Where shall we write this? Here I will write it. Injection ceftriaxone. And for the purpose of non-gonococcal urethritis, we can use the tablet doxycycline. Okay, remember this concept in the patients of gonococcal urethritis, we have to also treat for the chlamydia because there is a possibility that chlamydia is also there, which is not manifesting. So that's why we have to, along with the injection ceftriaxone, give the tablet doxycycline. Doxy should also be given, right? So kit, we are going to see the kits at the end of the STDs, right? Yeah. Acquired syphilis. So you know that syphilis is because of Treponema pallidum. So initially it is going to cause primary syphilis where they are going to be the genital lesions which are described as single clean based painless indurated ulcer which is not having any bleeding on touch. So Shahrukh is there in this class along with Amitabh Bachchan. Okay, sure. So remember in this case, the syphilitic lesions are going to be painless, both the lesions in the genitalia and also the inguinal lymph node. So you can remember the name of the disease is syphilis. It is syphilis. Okay, that is the important point. In the case of the lymph nodes, remember it is going to be bilateral enlarged painless lymphadenopathy. Painless lymphadenopathy. And what is this motility called as? Can anyone tell what is the microscope which is used to identify Treponema pallidum? And what is the yes, it is dark ground microscopy, and this is called as corkscrew motility. Corkscrew motility. Chalo. Next, if this primary syphilis is not treated properly, then what will happen? It is going to be spread hematogenously and it is going to cause lesions over the skin and also in the mucosa. So in the mucosa, the Treponema pallidum is going to produce what is called as condyloma lata, which is going to be broad-based moist lesions present in the genitals, right? And also this can affect the individuals where they are going to be this hyperpigmented lesions present over the palms and the soles. Okay, so these are what are called as syphilids. These are what are called as syphilids, right? And yeah, that is about the syphilis. What is the treatment of the syphilis? If you may ask, that is going to be benzathine penicillin, injection benzathine penicillin. Right, that is going to be the treatment which is used, but treatment as such is not very important. So next is a chancroid. If you remember the crow, the everything related to this condition can be remembered. So this is Haemophilus do cry. The crow is crying and the patients also cry because the ulcer as well as lymphadenopathy are painful. Okay, that is the reason for the cry. And the ulcers are exactly opposite to that of syphilitic ulcer. So here there will be multiple ulcers with a necrotic base, and the ulcer is going to be very soft. It's non-indurated, and it is very painful. It's very painful, and it will bleed on touch because it is hemophilus, blood loving. organism. And if you examine the lymph nodes are going to be enlarged, and we are going to use this term called as bubo. So this is the bubo which you are able to see. And if you do the gram staining, we are going to say gram negative cocobacilli. Gram negative cocobacilli can be seen in the long parallel strands, right? And this is given a description called as school of fish or railroad track appearance. Treatment is with azithromycin. So this is a story which will help you to remember all the points related to chancroid. So this is a crow which is crying. It wants to eat the fish. It's not able to get the fish, so it is crying, and it has committed suicide by going to the railway road. The bad, sad story. This is the next modern ChatGPT Gemini version of the modern crow. And it knows that there are fish inside this tube. So it is throwing the azithromycin, and it is not only eating the fish but also drinking the water. So this is a modern crow. So with the help of this crow story, you can remember the chancroid features. All of them you can remember: the railroad tracks, school of fish appearance, the organism, crying crow, it is do cry, right? And also the treatment, azithromycin or even macrolides. You can remember chancroid, right? Next is the genital herpes. The causative organism is HSV2. Above the waist HSV1, below the waist HSV2. Right? Here there will be grouped vesicles which will rupture from the grouped erosions. If you examine the lymph nodes are going to be bilaterally enlarged. Remember, the genital herpes, the ulcer as well as lymphadenopathy both are painful. Okay, and the lymph node enlargement is not bubo because there will not be any pus collection in the lymph node. So it is not a bubo. Bubo term can be used in two conditions in dermatology. They are LGB and the chancroid. LGB and chancroid. Right, if you do the investigation, that is a Zank smear, what are we going to identify? Zank smear is a cytodiagnostic test. We can see both the acantholytic cells as well as the multinucleated giant cells. And what is the treatment? We are going to use a kit number 5, which is red colored kit consisting of acyclovir 400 mg TID for a period of 1 week. So coming to the donovanosis. Donovanosis, it's also called as granuloma inguinal, also called as granuloma venereum. Right? The causative organism for this condition is Klebsiella granulomatis, or also called as Calimactobacterium granulomatis. Calimactobacterium granulomatis. Right? And the genital ulcer, very important description coming up. The genital ulcer is beefy red, very, very red in color. It's beefy red. Exuberant granulation tissue will be there, and it will bleed on touch. Remember, in the STDs, two conditions which will bleed on touch. One is donovanosis. The other one is, what is the other one? Hemophilus ducrei, chancroid. Right? So these are the two conditions. And yeah, what is the status of the inguinal lymph nodes? They are not enlarged. So remember, the term pseudobubo is used for donovanosis. Right? And दो नो होते हैं इसमें, what are those two no's? No pain in the genital ulcer and no inguinal lymphadenopathy. No inguinal lymphadenopathy. These are the two no's. If you do investigation, the crust tissue smear, in this, yes, we are going to see this safety pin appearance. Safety pin appearance, okay? Right. And what will the treatment of this condition? It will be azithromycin. Not a common condition. It is very rare to be seen in the India. Right. Next is lymphogranuloma venereum. What is a causative organism? I hope you remember this. Chlamydia trachomatis with the help of the RGV. RGV. Yes, media, chlamydia. Okay. Genital ulcer, it is very rare. It is very difficult to see genital ulcer. It is unnoticed by the patients. If you see the second stage, which is the inguinal stage, we can see the presence of the bubo. And we are going to see this small groove, which is called as groove sign of Grenblatt, right? And in the third stage, we are going to see the enlargement of the genitalia because of the obstruction of the lymphatics. Okay, so these deformities, they are given names. They are called as saxophone penis, and also it is the elephantiasis. elephantiasis of the genital, female genitalia. Treatment is going to be with doxycycline. Treatment is with doxycycline. So I hope you remember the story of the RGB who likes the media attention, chlamydia trachomatis. Okay, he is going to come in the YouTube. There is going to be a song. Tararara, pap, 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 pap. Okay, so he is not, he's not playing this saxophone. Okay, so sorry, he is playing this saxophone, not the other saxophone. That is what you can remember. Okay, and also he made a movie in Telugu which is Shiva, in which there was cycle chain scene. So this was one student who told me the last class cycle chain related to the Shiva movie. Or you can remember he was actually against one party, political party in Andhra Pradesh, which is Telugu Desam Party. The election symbol of that party was cycle. So with the help of that also you can remember all the points related to RGB. Right. Coming to this, a quick. So A, B, C, D, E. So I will ask you, question. A patient is coming with multiple painful genital ulcers. You have examined the lymph nodes. Lymph nodes are painful. Okay. And in one patient, there is a bubo formation. So what is D? What is D? Yes, very good. It is chancroid. So bubo is absent in the E patient. So what is E here? What is E here? It is herpes genitals. Yes, HSV2 infection. Absolutely correct. So coming to this side, single painless genital ulcer is there. And there is no lymphadenopathy. There is no lymphadenopathy. What is the diagnosis? It is donovanosis. Donovanosis. There is another patient, painless genital ulcer, painless inguinal lymphadenopathy. What is the diagnosis? Yes, it is syphilis. Syphilis. Perfect. And there is a patient, single painless genital ulcer, and there is bubo. So what do you think is the diagnosis for B? Very good. It is LGB. Remember, bubo is always painful. Bubo is always painful. Right? That is an important point to remember. Okay. Yeah. Now this question, yeah, all are associated with human papilloma virus except. So this condylom acuminata is the viral infection. Verruca vulgaris, it's due to HPV. Okay. Mermesha is a deep plantar. What the other name for deep plantar? What is mermesha? Condyloma lata is related to Treponema pallidum, but not HPV. So male presented is urethral discharge. Okay, which color kit is going to be given to this patient? Okay, it is gray colored kit. Gray colored kit. Adult male, 4 weeks after intercourse, fever, button like indurated, painless ulcer, painless inguinal lymphadenopathy, painless syphilis. Okay, syphilis. So very simple questions will be asked. This is another question. Truck drivers, those who are going to Bangkok, all of them are going to have high chances of STDs. So that's what is the meaning of exander. History of painless lesions on the penis. Probably it is primary syphilitic ulcer. So skin rashes, as you are able to see here, over the palms and also over the trunk. So it is secondary syphilis. Right? Young female asymptomatic macules and papules on the trunk and reddish patch over the palate with a flat moist lesion on the vulva. So this description is very, very important. All of them are important terms related to secondary syphilis. Okay, so this is a patient of secondary syphilis in this clinical scenario. So what are all the clues? Flat moist lesion on the vulva. This is the condyloma lata. Patients of the secondary syphilis can have the generalized lymphadenopathy. Generalized lymphadenopathy. Yes, they can have generalized lymphadenopathy. Right? So what is the line of management? Yes, benzathine penicillin. It is going to be benzathine penicillin. Okay, right. Oh, Russian president is telling that I am looking like Brahmanandam. Painful ulcer on glands is seen in which diseases? Yes, it is chancroid. Right? And is there any other condition in which we can see painful genital ulcer? Yes, it is another HSV also one more possibility. Multiple bleeding painful ulcers can be seen in which condition? Multiple bleeding painful ulcers. So remember, multiple painful ulcers can be seen in the chancroid herpes simplex virus, but bleeding is a characteristic feature of chancroid. So remember that point. Group sign is seen in LGV. Okay, this we have seen this. So this is a symbol. What is the symbol? It is Suraksha Clinic. It is Suraksha Clinic. Some students have a doubt how to remember this. So imagine this is a individual. This is an individual with the hands put like this. You can just imagine this as the genitalia, which is being depicted at the center. So that will help you to remember that it is related to STD. Suraksha Clinic is protection male and female condoms. Okay, like that, and also it is going to treat the STD also. Alright. So these are some of the other emblems which you need to remember. And this is a kit. I hope you remember the mnemonic which we kept with the help of Sallubai. Right? What is that mnemonic? Anyone remembers? Grey girl wearing bracelet, reading yellow book. Okay. Grey girl wearing bracelet, reading yellow book. Right? Drugs you can remember if you can remember this order. The first colored kit is gray colored kit. Kit number 1 is gray. So gray colored, it is used in urethral discharge. Urethral discharge, what are the organisms? It could be gonococcus or it could be non-gonococcal urethritis, right? So gonococcus, if you want to treat gonococcus, what is the normal treatment? Ceftriaxone. But here we cannot, we are not going to give the injection, but we are going to use the tablets. So it will be with cefixime, 800 mg. And to cover the non-gonococcal urethritis chlamydia organism, azithromycin will be used. Okay, that is kit number 1. Kit number 2 is vaginal discharge. It might have been taken care by Raina ma'am. Oh, that's why I'm not going to go into this. Dosages, at least if you can remember which kit is having which medication, that is fine. You probably will not get so deep question that you are being asked the dosages also as minor difference. Okay, so kit number 2 vaginal discharge. Kit number 2 is vaginal discharge. So fluconazole, secnidazole will be taking care. Kit number 3 and 4, they are going to target the STDs because of the syphilis and the chancroid. So for to target the syphilis, treponema pallidum, the kit should contain benzathine penicillin. Benzathine penicillin. And to target the chancroid part, what is the medication which should be there? It should be obviously the azithromycin. Chancroid, crow is crying, throw the stones or azithromycin. And if the patient is allergic to penicillin, we are going to use a doxycycline along with that azithromycin will be there. Azithromycin will be there, right? So kit number 5, we have seen this. Kit number 6, it will be taught by Raina ma'am. Kit number 7, remember this is used in the cases of LGV bubo. So LGV, remember the treatment is with doxycycline. I have told you this. At least remember the medication name that is going to enough. The drug dosage most likely it will not be asked. Don't worry. And the last kit. So this is just a common sense logic. This is a anorectal discharge. How can anorectal discharge occur? Because of the individuals who are having the urethral discharge. Okay. So one, the patients who are having the urethral discharge, they are going to produce, they are going to manufacture the people who are having anorectal discharge. So what the organism will be the same. So the treatment is going to be the same. Okay. So if you see kit number 8, what are the medication which are there? If you see carefully, cefixime 800 mg, it is same like kit number 1. But the only difference is anorectal discharge, it is a little bit difficult to treat. That's why instead of the single dose of azithromycin, we are going to use the doxycycline, which is going to be used for more number of days so that the organisms are basically the same, gonococcal and chlamydia trachomatis, right? I hope you understand what is this. This is MSM, right? A simple concept. I hope you now can remember all the kits, the organisms and the drugs. Okay, is that clear? So just remember this mnemonic: gray girl wearing bracelet, reading yellow book. That will help you to remember everything. Absolutely correct. Lichen only read with no partner treatment. That is right. And also there are two more conditions in this, STDs which we discuss. Actually, the other one is candidiasis and also bacterial vaginosis. So these are the conditions: bacterial vaginosis, candida, and this condition which is the HSV. So these three conditions don't need partner treatment. Okay, these three don't need partner treatment. Next is eczema. Okay, eczema. Chalo. Few points: eczema, acute eczema, and very chronic eczema. In the acute eczema, we are going to see. Okay, chalo. Erythema, edema, vesicles oozing, and crusting. So these are the changes which you are going to see in the acute eczema, right? In the chronic eczema, what will happen is, because of there is a lot of itching, the patients are going to scratch so much, because of which there is going to be three important changes. Okay, what are the three important changes which can happen? So those three put together, we call it as lichenification. What are those three changes? Skin thickening will be there. Skin will become very, very thick, and it's going to become more and more pigmented. Okay, right, it's going to become more and more pigmented. And what is another change which can happen? It is going to have increased skin markings. Increased skin markings will be there, that is dermatoglyphics will be very much seen. Right, yes. Chalo, next is allergic contact dermatitis. Allergic contact dermatitis, which is ACD. Can anyone tell what is the investigation of choice for the allergic contact dermatitis? Yes, quickly. Chalo, very good. So it is a patch test. It is a patch test, and these are all the allergens which you need to remember. In the hair dye, there's going to be paraphenyldiamine, right? In the metal, there's going to be the adulteration with the nickel, right? And in the cement, this is potassium dichromate. And in the bindi, there's going to be para-tertiary butyl phenol. So these are important allergens which you need to remember. And this is a patch test. Now, question for all of you: in the patch test, at what time we are going to remove the patch, and what is the best time for taking the reading? So these are two different questions. Yes, very good. So after 48 hours, that is after 2 days, we are going to take the first reading. We are going to remove the patch, and we are going to do the first reading. And after 16 and it is 96 hours. So which is the second reading, which is the best reading. Yes, that is 96 hours is the best reading. Right, absolutely correct. So next is atopic dermatitis. Atopic dermatitis. Okay, so there's going to be something very interesting here. There's going to be three phases which we can see in the atopic dermatitis. So infantile phase, childhood phase, and adult phase, right? Okay, so in this, just remember the infantile phase is one peculiar phase where the patient with the children are going to have the involvement of the face and also over the extensor surfaces. Right? Whereas in the childhood and the adult phase, it is the flexures which are going to be affected. And what is this associated with? Is associated with atopic triad, where there is going to be allergic rhinitis and also bronchial asthma. Okay, upper respiratory and lower respiratory involvement. Investigation of choice for atopic dermatitis. Can anyone tell what is investigation of choice for atopic dermatitis? Remember, it is clinical examination. It is clinical examination, but not any investigation. And what are the important major diagnostic criteria? Yes, pruritus is a very important criteria, which is a hallmark, which you remember. So one student is telling Rajma criteria, it seems. It is Hanif Rajka. So yeah, you can also remember it as Rajma criteria. Right, and the typical morphology distribution, like we have told in the phases, infantile, childhood, and adult phase. And it's a very chronic condition, chronically relapsing condition. And personal or family history of atopy, that is allergic history, will be given in the question by the examiner. And what are the eye manifestation which can be seen in the patients? Yes, there can be cone-like cornea, keratoconus, shield cataract, anterior subcapsular cataract, infraorbital fold can be seen, which is called as a Denny Morgan fold. And we can see the loss of the eyebrows, which is called as lateral matrosis, or it's also called as the Hertogis. Right, this is regarding atopic dermatitis. Now coming to the histamine mast cell disorders, basically. So this picture which you are able to see, this is the urticaria, where we are going to see the urticarial wheals over the body because of the histamine release from the mast cells. Okay, and yes, we can write over the skin of this patient, which is called as dermographism. Another mast cell related disorder where there is going to be proliferation of the mast cells, it is called as mastocytosis. It's also called as urticaria pigmentosa. Where the child, okay, it's going to be a child who is a patient, a hyperpigmented lesion will be present over the body. Okay, and yeah, this is important sign. Very good, funny, you have marked it right. So it is a rubbing of this lesion which is producing the wheal formation because of the histamine release from the mast cells. It is called as Darrier sign. It's called as Darrier sign, right? And yeah, this is a child who's having this greasy yellow scaling present over the skull. So what do you think is the diagnosis? Cradle cap dermatitis, which is basically a seborrheic dermatitis. It's basically sebderm, which is specifically called as cradle cap dermatitis. Cradle cap dermatitis. Now coming to the parasitic infestation. So ectoparasitic infestation. Scabies, what is the causative organism? Sarcoptes scabies were hominis. Okay, what are the important pathognomonic findings? Yes, it is a mite. Very good. It's a mite. We are going to see the burrows present, especially in the web spaces. Skin involvement is going to be present in the circle of Hebra, which is going to the web spaces, the wrist, the antecubital fossa, the axilla, the areola, the nipple, and also genitalia. Okay. And if you do a KOH, the organism is going to appear just like this tortoise. But the only difference is it's going to have two pairs of anterior limbs, two pairs of posterior limbs. Medications, what are going to be used? Topical medication, which is the permethrin. It's a topical medication which is used. And remember, the oral medication is the ivermectin. Once there was a question which asked, a patient was having scabies, everything related to scabies was given as a clinical picture. And at the end, in the question, they have asked, what is the oral medication which is used? And the first option was permethrin. Okay, students mark permethrin. Okay, so don't make this kind of mistakes. Permethrin is a topical medication. Ivermectin is an oral medication. Read all the options very carefully. Read the last sentence of the question very, very carefully. Right? Next, scabies is normal, which will have few mites over the body. But there is a variant of the scabies which is very, very severe form. It is called as crusted scabies or also called as Norwegian scabies, in which case there is going to be millions of mites. So these patients are millionaires. Okay, slumdog millionaire, literally. So they are millionaire with the mites because they are having the less itching. That is a problem. There is no itching because of the underlying immunocompromised status. They could be HIV patients, or they could be cancer patients. Okay, cancer chemotherapy who are undergoing, and they could be leprosy patients. Usually, in India, beggars, if you see near the temples, they will be on small wooden planks. They will be moving around without limbs, so they also don't have any sensation. They could be getting this scabies. Okay, Norwegian scabies, right? So these patients are going to have this hyperkeratotic plaques, and also they could have this erythroderma over the body, the severe form of Norwegian scabies. And also in the question they can mention that it is a child who is having mental disability. So whatever may be the reason, because of all this, there is going to be less itching. Because of less itching, the mite is going to stay over the body. Right? That is the problem. So pathognomonic lesion in the scabies is burrow. Patient presented with lesion over the interdigital gates. What is the oral drug? Ivermectin. Incorrect about adult scabies. Right? Burrows pathognomonic, absolutely correct. Itchmites burrows into the stratum corneum, absolutely correct. Ivermectin blocks the glutamine driven chloride channels, thereby producing paralysis of the mite, correct. Remember, in the adult, the lesions are not going to be present over the palms and soles and over the face. So that is a wrong statement. In the children, yes, no doubt we are going to see the lesions over the face and also over the palms. Norwegian scabies, chemotherapy, leprosy. So all the immunocompromised status, you can mark them. So this is a question into disabled child, with wartic crust present over the body, and severe fissuring and scaling is present over the skin. It's a Norwegian scabies. Right? And these are some of the one-liners. Vagabonds, this is basically the lice infestation of the clothes. So this is Pediclosis corporis. And this picture was given, this was asked 2 to 3 times, I guess. Right? It is elephantiasis. It is elephantiasis. Mycobacterial infection, so lupus vulgaris. So in this, remember, the picture is going to be somewhat looking like this, where there is going to be a annular lesion, which is going to have one end which is progressing, and at the other end there is going to be scar formation. So this is the Lupus vulgaris. Lupus vulgaris, which is the most common type of cutaneous tuberculosis in the elderly. So this is another picture of lupus vulgaris. Both are lupus vulgaris. Here you are able to see the beautiful annular lesion, which is showing this central scar formation. And at the periphery, you are able to see that it is active and it is progressing. It is progressing. Yeah, in dermatology, we call any lesion which is looking classically as beautiful. So it is not actually beautiful. It is not non-beautiful lesion for all the non-dermatologists. Right. Okay. Next is scrophulodderma. It is the most common type of tuberculosis in the children. Right. Where there is going to be this mode of spread from the underlying tissues. So it is contagious. So contagious, the surrounding areas, the infection, the TB bacilli are going to spread onto the skin surface. Most common focus of infection is going to be the lymph nodes, and especially the lymph nodes which are present in the neck. So cervical group of lymph nodes is the most common site. So this is how the question can be asked. Ulcer with overhanging undermined edges in the neck region shown. What is the diagnosis? So this is how the examiner may ask you the question. It is scrophulodderma, or it is also called as tubercular lymphadenitis. So this could be given as one more synonym for scrophulodderma. Please mark the tubercular lymphadenitis. Next is fixed drug eruption. So remember, this is the FD, and the drugs which are implicated are, many. They could be painkillers, they could be doxycycline, or it could be mentioned metronidazole. So many medications are there which can produce fixed drug eruption. So what is the point about fixed drug eruption? The lesion will be coming at the fixed site because of the same drug. That is why it is called as FD. And it can also affect the mucosa along with the skin. And the special feature is always it will heal with a bad pigmentation. That is a problem here cosmetically. There will be a bad pigmentation left out, and it is going to be recurrent in nature because of the drugs at the fixed site. Next, another truck driver is coming. So this is the second truck driver which is coming in our class. He is having history of repeated herpes infections. Okay, and these are the skin lesions which are occurring after this herpes infection. What are these lesions looking like? They are looking like target lesions. Target lesions. So target lesions can be seen in erythema multiforme. And remember, in the erythema multiforme, herpes virus is the most common associated infection. SGS-TN spectrum, I hope you remember, the drugs are implicated in the causation of more than 90% of the patients of SGS and TN. And related to the border surface area, we have this SGS if it is less than 10% and more than 30%, we call it as toxic epidermal necrolysis. The drugs are so many drugs. You can just remember the anti-convulsants, the anti HIV infections, and the tubercular drugs. Any one of them can produce this SGS and TN. No need to buttify the medications. Coming to the involvement of the skin and the mucosa, remember the skin involvement, mucosa involvement, everything is going to be very, 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 very severe. Very, very severe. Okay. So in the mucosa, we can see hemorrhagic crusting in these patients, right? And in the skin, there's going to be sheet-like epidermal peeling. There's going to be sheet-like epidermal peeling. But most important point is the mucosal involvement is going to be very, very severe. Next, the colors. Okay, bleomycin. Bleomycin flagellate dermatitis. I hope you remember there's going to be this whip-like lesions which are pigmented lesions over the body. Minocycline, I told you that it is associated with the pigmentation, especially in the acne scars. And the color is blue color. Very difficult to treat condition. A patient anti-convulsant drugs is presenting with this type of a rash. So what do you think is the diagnosis? So this is a fixed drug eruption. Okay. So this is how the questions can be asked related to this NSAIDs joint for use for joint pain and same rash, same location, fixed drug eruption. So what do you think is the answer for this question? Yes. Chronic renal failure. Absolutely correct. Arey, don't worry, yeah, Penguin. This is. So, have you watched the lap 1, lap 2? ऊपर क्या है? किसका ऊपर? Oh, don't worry. The questions are going to be very easy. The rest of the other topics are also being discussed here. Maybe that why you're feeling it difficult. EMF is erythema multiforme. Erythema multiforme. Okay. Chalo, next is genodermatosis. So few more topics are there. We are going to wind it up. Genodermatosis is also called as phacomatosis. Phacomatosis, right? Neurofibromatosis type 1 is what is interested for us. Okay, we are going to see the presence of the neurofibromas. Neurofibromas. And what are these pigmented lesions which you can see in the NF1? So what do you call this as? Okay, so here with the pigmentation, yeah, this is cafe au lait macule. And what are these called as? These are the freckles, axillary freckles. And this is again the cafe au lait macule. So don't worry, the examiner is going to ask you simple questions. Okay. So we are actually looking at some difficult concepts also to be well prepared to face the NB. Right, this is a flexiform neurofibroma. Flexiform neurofibroma. Every time the examiner, they will do the same nautanki. Something will happen with the neat anesthetic because of which they will get um, disappointed, and they will show this revenge mode in other examinations. Okay, so that is what is happening. I hope this time it will not happen in the FMG examination. So this is yes, Lish nodal, which is pathognomonic for NF1 again. The tuberous sclerosis complex. Tuberous sclerosis complex. Here we can see the ash leaf macules present over the body, and shagreen patch, which is a collagenoma present over the lumbosacral area. And this is adenoma sebaceum, which is also known as angiofibroma. Angiofibroma can be seen in Cohen's tumor, which is also called as periangle fibroma. Periangle fibroma. Remember, by looking at this, angiofibroma and periangle fibroma, some students marked neurofibromatosis as the diagnosis. But be careful, these fibromas, they are seen in the tuberous sclerosis complex. And what is the full form of epiloia? It is epilepsy, low IQ, and adenoma sebaceum. Right? So that is about tuberous sclerosis. So you can mark the answer for this question. Patient presented with axillary freckling. What is the diagnosis? It is neurofibromatosis. Right? Most common neurological tumor associated with NF2. Remember, it is acoustic neuroma. This is ENT question to be precise. Young girl is having the low intelligence and epilepsy history is there. What is the diagnosis you want to think of? So what are these lesions which you are able to see over the central face? So diagnosed tuberous sclerosis. What is the lesion? Yes, it is angiofibromas. Angiofibroma. Absolutely correct. So some one-liner type of questions you can see here. Carpet tuxine can be seen in discoid lupus erythematosus. Discoid lupus erythematosus. So here is a patient. So many students are waiting for this moment. So butterfly rash is there in this patient. Systemic lupus erythematosus. Salt and pepper skin can be seen in the scleroderma. Scleroderma. Salt and pepper skin. Okay, so this is same thing. And just look at this picture. Velvety texture is there. This is the patient of Acanthus nigricans. Most likely the possibility of diabetes and obesity. Oh, this just yes. This is better to call obesity more common cause for Acanthus nigricans when compared to diabetes mellitus. Right, Acanthus nigricans. Now, this is very, very important slide coming up. Pellagra and acrodermatitis enteropathica. Both of them are having so many features in similarity. Only one difference is there. What are the similarities? So, if you observe carefully, they are having dermatitis common to both. But here it is photodermatitis and pellagra. Whereas in acrodermatitis enteropathica, it is a acral dermatitis. Obviously, acrodermatitis enteropathica. Diarrhea seen in both of them. And here, remember, the pellagra dementia will be there. And here in acrodermatous enteropathy, it will be alopecia instead of dementia. And it is because of the niacin deficiency. Acrodermatous enteropathy is because of the zinc deficiency, right? And the treatment is going to be lifelong zinc supplementation. Can anyone tell what is this necklace called as? So patients of pellagra will have a necklace. It is Castle's necklace, right? And this is a zinc supplementation to this given to this child, after which you are able to see this is an improvement. So that is a great improvement. Yeah, this diet is also important. Jowar, maize, alcohol. These are all associated with the pellagra. So now coming to the Hansen's disease. Hansen's disease. So few important points related to Hansen's disease which we are going to focus. Pityriasis alba and indeterminate leprosy. Remember, pityriasis alba, children will present with multiple hypopigmented lesions over the face, and they are associated with scaling. So these are the important points related to the pityriasis alba. Whereas in the indeterminate leprosy, remember, it's going to be single hypopigmented lesion in the face of a child. Here, remember, there's going to be atrophy of the skin, which is going to be seen. Atrophy of the skin. Now, coming to the types of leprosy, if you remember, we have various criteria, like, for example, Hanifin-Rajka criteria, and this classification, Ridley-Joplin classification, RJ classification, which is going to divide the leprosy into 5 types. 5 types, okay? TT, BT, BB, BL. So now first let us look at the TT leprosy. Here, just remember the buzzword is the annular lesion. Annular lesion, and there's going to be this saucer right way up type of lesions. So these are the important points. TT leprosy. That's all. In the BT leprosy, remember the patients are going to have the ill-defined as well as well-defined margins, and there will be satellite lesions, which are very classical of the BT lesions. So you can see here, this is a patient who's having this, small lesions which are surrounding the bigger lesion. So these are also satellite lesions. These are also satellite lesions. In the BB leprosy, I hope you remember all the points with the help of this wife and husband who are quarreling like Tom and Jerry always. So that will help you to remember the polymorphic nature of the lesion, which is going to give rise to the geographic map-like appearance, because wife and husband, they will quarrel and they will go to the world tour. So every time they will go to the world tour, and you can see that there is this inverted saucer appearance, because the wife, if she's angry, she will put the saucer with the tea, but in an inverted fashion. So that will help you to remember the BB leprosy. BB is wife in Hindi. Right, so that is going to help you to remember all the features. Next is borderline lepromatous leprosy. Yeah, before that, if you see the lesion, it's going to have the central punched out appearance, just like Swiss cheese appearance. Swiss cheese appearance. Again, which is commonly associated with the Tom and Jerry. Right. Next is borderline lepromatous leprosy. Here, the term which you need to remember is almost symmetrical involvement of the skin and the nerves. Okay. Right. And these patients, lepromatous leprosy, they are going to have the face which is looking like a lion-like faces. It's also called as leonine faces, right? And there is going to be loss of the hair of the eyebrow. So it is a madarosis. Glove and stocking type of anesthesia will be present over the palms and the soles. Lepra reactions. So rule of 5, type 1 lepra reaction, 1 plus 4 is 5, 2 plus 3 is 5. In the type 2 lepra reaction, remember, there will be new lesions produced because immune complexes can deposit anywhere over the body. So there are going to be new erythematous lesions produced, and they are called as erythema nodosum leprosum lesions present anywhere over the body. And it can be seen in the lepromatous pole, that is BL and LL. Right? And the treatment part, remember, the treatment for both type 1 and type 2 lepra reaction will be with the steroids. Continue immunity, give steroids. Continue immunity, give steroids. In the type 1 lepra reaction, the pre-existing lesions are going to become erythematous inflamed because it's a type 4 hypersensitivity reaction. So yes, in the pregnancy or non-pregnancy, the treatment is going to be the same. Continue MDT, give the steroids. Thalidomide, it can be used in the type 2 leper reaction. It's a gold standard, but we don't use it as a drug of choice because of the teratogenicity, and also it is expensive medication. Treatment, this was recently asked related to World Health Organization and also National Leprosy Elimination Program. So in both of them, the treatment is going to be this three medications: rifampicin, dapsone, and the clofazimine. The dosage is also going to be the same: 600 mg, 100 mg, 350 mg. So these doses, I hope you remember how to remember this. Okay. So rifampicin 600 mg, remember this dose. Dapsone 100 mg, remember this dose. Half of rifampicin is the monthly dose of clofazimine. Half of dapsone is the monthly dose of the clofazimine. So daily dose of clofazimine. So this is how you can easily remember. And in the POSI or multibacillary, the medications are going to be the same. The dosage is going to be the same. Only difference is duration. In POSI bacillary is going to be 6 months, and in the case of multibacillary, it's going to be the case of 12 months. Okay. Right. Rahul Kumar is giving one great way to remember. Deep say dapsone daily, it seems. Okay. That's a very good point, Rahul. Very good. Wah, Rahul, wah. Perfect. Right. Next is this POSI and multibacillary differentiation. This is also very important. How to identify a patient as POSI or multi. So if a patient is having 1 to 5 skin lesions, POSI bacillary. If the patient is having no nerve involvement, POSI bacillary. And if there is no slit skin smear, acid fast bacillus positivity, it is again POSI bacillary. If any one of this criteria is fulfilling with that of multibacillary, anyone, we brand that patient as multibacillary. So if there is 6 or more lesions, it is multibacillary. If there is even one nerve involved, it is multibacillary. Even if there is one acid fast bacillus seen, it is multibacillary. Right? So patient presented with hypopigmented rash with satellite lesions as shown in the image. What is the diagnosis? What do you think is the diagnosis? BT leprosy, Swiss cheese appearance, BB leprosy, right? All are used in leprosy except for diagnosis purposes. What do you think is the answer? So remember, lepromin test is not for diagnosis, it's for prognosis. Okay, so for prognosis. Thalidomide is mostly effective in the type 2 leper reaction. It's used in type 2 leper reaction. So some points related to tumors. So superficial spreading is the most common type of the malignant melanoma. So some points which were recently asked, that's why I'm covering them here. Okay, related to the melanoma. Okay. Nodular, it is the most aggressive form. Acral lentiginous. Remember, this is the most common type in the dark skinned individuals. So please bear with me for a few more minutes. It's going to finish. Okay. Dark skin. This was a recent INICT question. If you remember, acral lentiginous melanoma is the most common type of skin malignancy in the dark skin individuals. Most common type of melanoma in the dark skin individuals. So this, I hope you remember, this ABCD features related to melanoma. This was once asked in the MCQs. And if you remember, this is Hugh Jackman. He is having BCC. He is not dead yet. Do you know the reason? Because BCC is not going to show metastasis. That's why he is still alive. Otherwise, he would have died really. No, it is not because it's Wolverine and he is not immortal. That is not the reason, because it does not have metastasis. How does BCC present? Yes, BCC is going to present with the pearly white nodular lesions which will have telangiectasias over the surface. And because it is locally very invasive, it is going to form an ulcer. And this ulcer is, called as rodent ulcer, which will have rolled out edges. And very, very classical picture, site of involvement is above the line during the angle of mouth and the tragus. Okay, so above this, wherever you have this lesion, the pearly white or even the ulcer lesion, think of BCC. What is this condition? It is a xeroderma pigmentosum. Xeroderma pigmentosum. So remember, this was also a recent question. It is due to the defect in the nucleotide excision repair, where there's going to be damage of the DNA because of the ultraviolet rays, and instability will be there, and the patients are going to have all the possibility, all the possible malignancies: BCC, SCC, melanoma, AML, CML, MBBS, BDS, any type of malignancy can occur in this patients. Okay, so this is a very dreaded condition where the patients are going to succumb because of the malignancies. చలో జీవితం ఎవరిని వదిలిపెట్టరు, అందరు సరదా తీర్చేస్తుంది. ఓకే, in 10 more days you are going to enjoy, don't worry. So you can join my groups, you can just send hi sir to this WhatsApp number. I hope you all of you enjoyed this session. If so, please in the emoji section write, and in the comment section also write how did you enjoy this. And sing along with me in your own rooms. Be careful that others are not there, otherwise they may get frightened what is happening at around 9:15 time. बार बार हाँ बोलो यार हाँ, अपनी जीत हो उनकी हार हो. Here उनकी is NB, so अपनी is ourselves. Okay, कोई हमसे जीत न पावे, चले चलो, चले चलो, मिट जावे जो टकरावे, चले चलो, भले घोर अंधेरा छावे, चले चलो, चले चलो, कोई राह मेरा थम जावे, चले चलो, टूट गई जो उंगली उठी, पांच मिली तो बन गई मुट्ठी, एका बढ़ता ही जावे, चले चलो, चले चलो, कोई कितना भी बहकावे, चले चलो, कोई हमसे जीत न पावे, चले चलो, चले चलो, मिट जावे जो टकरावे, चले चलो. Okay. And this is also one related song. Tillo, you were like this. मैं ऐसा क्यों हूँ, मैं ऐसा क्यों हूँ, मैं ऐसा क्यों हूँ, मैं ऐसा क्यों हूँ. But probably you have got proper clarity after the lap 1, lap 2, lap 3, and हाँ यही रास्ता है तेरा, तूने अब जाना है, हाँ यही सपना है तेरा, तूने पहचाना है, तुझे अब ये दिखाना है. In 10 more days you have to show your knowledge, your not only knowledge, your grit, basically your ability to hold on. In 10 more days you are going to show that, and that's it in this session. If you have any doubts you can ask and reach me out on the Telegram group. And any doubts? Yes, common sense, please carry the common sense along with you to the examination hall. That is most important rather than all the knowledge. Some students suddenly become tunnel vision because of the cortisol effect in the examination, because of the stress. Some students are asking, sir, please फिर से पढ़ाओ. Definitely I will teach you again, but not in this class. Finish your FMG, come back to the NEET and ICT classes. We'll again continue the teaching. Cerebral हम लोग कलुद्दम, definitely, definitely. NEET PG में मिलेंगे. Paper is going to be on the easier side. We have actually discussed NEET and INSCT level of stuff also. Don't worry. समीर भाई, मेरे दोस्त जो 10th तक थे सारे हिंदी में बात करते थे, इसलिए मुझे हिंदी आ गया. वैसे हैदराबाद में हिंदी ऐसे ही आ जाता है. PYQs very important. पेपर मुझे देने के लिए एक स्टूडेंट पूछ रहे हैं। तो एक सब्जेक्ट तो दे दूंगा डर्मेटोलॉजी, बट बाकी सब्जेक्ट्स क्या करोगे? प्लास्टिक सर्जरी। This is a ritual every time. Students will be asking by keeping host and panelist option on the treatment options for their conditions. सर मुझे एंड्रोजेनेटिक एलोपेशिया है, सर मुझे टीनिया है, सर मुझे अर्टिकेरिया है, क्या करूँ मैं? Yeah, this hoodie is nice, isn't it? This is my name hoodie. Thank you. Raju Prasad Gupta. So enough to prepare an NPG. 6 hours of job. You'll be tired so much physically, emotionally, mentally, every early. Better if you can take some leave for few days, few months, and if you can prepare only for the NEET PG, that would be better option. छोटा डॉन कौन है भाई? डॉन को पकड़ना मुश्किल नहीं, नामुमकिन है। मुझको पहचान लो, मैं हूँ डॉन। दुनिया में लोगों ने दिल अपने फिर थामे, आया हूँ लेकर मैं फिर कितने हंगामे। दैट इज अ छोटा डॉन, चिंटू डॉन। Oh, don't worry. Okay. Telugu song. करके प्लीज थोड़ा बंद है। जय 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 बालैया। So there are 10 more days. Put your efforts. You are going to do great. Okay, there is nothing like motivation. These are 10 days only depends upon how much you are able to believe in yourself. That is the most important thing. So one Telugu song, okay? నమ్మవేమో గాని అందాల యువరాణి నేలపై వాలింది, నా ముందు విరిసింది, ఎందుకే అమాంతున్నామది, అక్కడే నిశ్శబ్దమైనది, ఎందుకో ప్రపంచం అన్నది, ఇక్కడే ఇలాగే నాతో ఉంది, నిజంగా కళ్ళతో వింతగా మంత్రమేసింది, అదేదో మాయలో నన్నిలా ముంచి వేసింది. So one student remixed this along with biryani. So definitely there will be some doubts. No, everyone will have the doubt, self-doubt that is my preparation okay? Am I good for the exam? But remember these 10 days, please be very careful. Believe in yourself, you are going to do great and you will achieve the success. Just, be chill. And along with that, there will be some stress. Having some stress is good. Otherwise, if you are stress free, that is also big danger. You will make mistakes left and right. You will make silly mistakes. But if you are a little bit stressed, that's okay. That's a sign of uh, that it's good things are going to happen. So if you want to know the reason for the yellow specks, you can attend the cerebral hum event. You can ask me in person. हाँ भाई, कॉमन सेंस लेके जाओ अपने साथ. ओवर थिंकिंग छोड़ दो और चेंजिंग द आंसर्स भी छोड़ दो. तो चलो, और कोई डाउट्स नहीं. वी आर गोइंग टू कॉल इट टुडे. थैंक यू सो मच. ऑल द वेरी बेस्ट, माय डियर स्टूडेंट्स. Thank you so much for the behind the scenes, the cerebellum team, the faculty, the students, God, everything for making this class possible and also making this class wonderful. Happy learning. Sarvam Sri Krishna Arpanam. Bye bye.